mitral valve quantification with dynamic assessment to provide quantitative information that can aid better understanding of complex pathologies. EPIC CVX Release 5.0 brings together the unique strengths of Philips and Tomtec to create a seamless, integrated experience for all your echo examinations. Designed for cardiology, built for better care. Philips EPIC CVX. Innovation and you, Philips. You want exceptional image quality. You need to assess the function of the whole heart, not just the left side. You need easy-to-use, robust quantification tools that deliver fast and reproducible results wherever you need them. With an 8% reduction in standard exam time and 21% fewer control interactions, ultrasound can be more definitive without extending exam time. You want to assess your pulmonary hypertensive patients more robustly, with a user-friendly tool to measure right ventricular function with consistent results. EPIC CVX uses artificial intelligence to align the view, position landmarks, and detect the RV border in as little as 15 seconds, enabling everyday clinical use. You want to measure global longitudinal strain quickly, to better assess overall cardiac function of patients in an everyday setting. EPIC CVX uses advanced automation technologies to deliver one-button push robust and reproducible results, eliminating the need for user interaction and aligned with the Speckle task force. You need accurate mitral valve quantification with dynamic assessment to provide quantitative information that can aid better understanding of complex pathologies. EPIC CVX Release 5.0 brings together the unique strengths of Philips and Tomtec to create a seamless, integrated experience for all your echo examinations. Designed for cardiology, built for better care. Philips EPIC CVX. Innovation and you, Philips.
Hi, good morning. How are you doing? ऑडियो आ रहा है? ऑडियो आ रहा है? आगे shots frequently. तो देख ये वाला नहीं है. 6:30 का देख. वाला है. ठीक है ना. सलाइन लगाना पड़ेगा तो तुमको कोविड सेंटर में जाना पड़ेगा क्योंकि कोविड है तो रिस्क मत. तो बेस्ट इज घर पे. होम क्वारंटाइन इज द बेस्ट. फीवर नहीं है ना उसको अभी. हाँ फिर हाँ तो उसको ना फ्लूइड इनटेक लेना. वाटर ये सब ले. नारियल पानी पिला और नॉर्मल वाटर विद नींबू पानी.
You want exceptional image quality.
Don't worry.
You need to assess the function of the whole heart, not just the left side. You need easy-to-use, robust quantification tools that deliver fast and reproducible results wherever you need them. With an 8% reduction in standard exam time and 21% fewer control interactions, ultrasound can be more definitive without extending exam time. You want to assess your pulmonary hypertensive patients more robustly, with a user-friendly tool to measure right ventricular function with consistent results. EPIC CVX uses artificial intelligence to align the view, position landmarks, and detect the RV border in as little as 15 seconds, enabling everyday clinical use. You want to measure global longitudinal strain quickly, to better assess overall cardiac function of patients in an everyday setting. EPIC CVX uses advanced automation technologies to deliver one-button push robust and reproducible results, eliminating the need for user interaction and aligned with the Speckle task force. You need accurate mitral valve quantification with dynamic assessment to provide quantitative information that can aid better understanding of complex pathologies. EPIC CVX Release 5.0 brings together the unique strengths of Philips and Tomtec to create a seamless, integrated experience for all your echo examinations. Designed for cardiology, built for better care. Philips EPIC CVX. Innovation and you, Philips. You want exceptional image quality. You need to assess the function of the whole heart, not just the left side. You need easy-to-use, robust quantification tools that deliver fast and reproducible results wherever you need them. With an 8% reduction in standard exam time and 21% fewer control interactions, ultrasound can be more definitive without extending exam time. You want to assess your pulmonary hypertensive patients more robustly, with a user-friendly tool to measure right ventricular function with consistent results. EPIC CVX uses artificial intelligence to align the view, position landmarks, and detect the RV border in as little as 15 seconds, enabling everyday clinical use. You want to measure global longitudinal strain quickly to better assess overall cardiac function of patients in an everyday setting. EPIC CVX uses advanced automation technologies to deliver one-button push robust and reproducible results, eliminating the need for user interaction and aligned with the SPECL task force. You need accurate mitral valve quantification with dynamic assessment to provide quantitative information that can aid better understanding of complex pathologies. EPIC CVX Release 5.0 brings together the unique strengths of Philips and Tomtec to create a seamless, integrated experience for all your echo examinations. Designed for cardiology, built for better care. Philips EPIC CVX. Innovation and you, Philips. You want exceptional image quality. You need to assess the function of the whole heart, not just the left side. You need easy-to-use, robust quantification tools that deliver fast and reproducible results wherever you need them. With an 8% reduction in standard exam time and 21% fewer control interactions, ultrasound can be more definitive without extending exam time. You want to assess your pulmonary hypertensive patients more robustly, with a user-friendly tool to measure right ventricular function with consistent results. EPIC CVX uses artificial intelligence to align the view, position landmarks, and detect the RV border in as little as 15 seconds, enabling everyday clinical use. You want to measure global longitudinal strain quickly to better assess overall cardiac function of patients in an everyday setting. EPIC CVX uses advanced automation technologies to deliver one-button push robust and reproducible results, eliminating the need for user interaction and aligned with the Speckle task force. You need accurate mitral valve quantification with dynamic assessment to provide quantitative information that can aid better understanding of complex pathologies. EPIC CVX Release 5.0 brings together the unique strengths of Philips and Tomtec to create a seamless, integrated experience for all your echo examinations. Designed for cardiology, built for better care. Philips EPIC CVX. Innovation and you, Philips.
Is valvular and strain in imaging valvular AI Marcelo.
Artificial intelligence.
This is पहले valvular.
तो पहले new insights होगा ना वो.
हाँ, new insights और Luigi का है. वो आया नहीं है.
Sorry, connected.
Hi, good afternoon everyone. Good morning everyone. Good evening everyone, wherever you are. I am Dr. Shantanu Sengupta. Joining me is Dr. Mahesh Ulwani.
Hi.
Yeah, so welcome you all to the second day of ECHO Nagpur 2020. This time a virtual meeting, and we have had a fantastic session yesterday with a lot of discussion, lot of talks, and it was amazing time. And so, Dr. Fulwani, how was it?
See, as expected, we had a tremendous session. We have set the standard very high, and I got a good response, good feedback from the people that we lived up to their expectation. Not we, everybody of us, all the faculty were phenomenal. The discussion was of high class. The lectures were very good, and they were helped a lot. So, and they expect even better today.
Great. So I think if we can have the Zoom here. So I see Dr. J.C. Mohan. Dr. Mohan, welcome back. Hi. I can see. I requested Dr. Chandra to join us. Dr. Chandra, can you unmute yourself?
Sure, I will, Shantanu, I think.
Thank you so much for being here. Hi, thank you, Dr. Chandra.
How are you?
Thank you so much. Actually, Dr. Mohan, he was knowingly, unknowingly, he joined the other link, and he was giving very good inputs yesterday. So I missed him, and I told him that if you can come on this main platform, faculty link, then we can say, he said, please, I will do it tomorrow. So thank you so much, Dr. Chandra. I think Nitin, Dr. Nitin Burkule and Dr. Amuthan, I can see both of you. Hi, Dr. Nitin. I think. Dr. Amuthan.
Good morning, good evening.
Good evening, good afternoon, everything, whatever. So thank you so much. So I think the first session today is by Luigi, and he's not yet joined. New insights about pathophysiology of
TR.
functional TR.
TR.
So, Dr. Mohan, what should we do? Should we? I can.
Next.
I mean, the main thing about Echo Nagpur or anything is we should have a discussion. I'm just trying to. There were already some questions which were unanswered. Do you think we should take one or two questions?
Yeah, we can take one or two questions till Luigi joins us.
Right. So the one question which was not solved yesterday was about MAC and use of E by E prime. So if you have MAC, mitral annular calcification, do we use E by E prime?
No, the guidelines say that in certain situations E by E prime is not valid. Those guidelines say mitral stenosis, prosthetic valve, mitral annular calcification, and a couple of other things actually where the annulus can get involved. You should not be using E to E prime. So we are fine with that. Actually, we could use other methods of looking at diastolic function. Maybe pulmonary veins would give us sufficient idea. We don't have to always. Pulmonary veins are a good way of finding out whether diastolic dysfunction is present or not. And number two, what is the estimated left, or let's call it left-sided filling pressure. Don't call it left ventricle filling pressure. What is the left-sided filling pressure? Pulmonary veins would give a fairly good idea about that.
Dr. Mohan, yesterday somebody told that you can use these criteria if the MAC is of lesser category or maybe less severity. But how do you decide whether MAC is less severe, moderate or more? Is there any fixed criteria for it?
There is a classification available for MAC. In fact, there are multiple classifications available. But I suggest, barring an occasional speck of calcium where you can use E to E prime, elsewhere we should avoid. But we also have to keep in mind that recent data is repeatedly suggesting us that E to E prime is a valid index largely in patients with reduced ejection fraction. The moment patients have near normal ejection fraction, E to E prime has a very low sensitivity. I was surprised to see a recent invasive versus echo where sensitivity of E to E prime was only 6%. Only 6%. I am aware of this study by Sharafov. Sharafov has actually done two studies and published in JACC showing that the sensitivity is close to 30% and specificity is a little over 90%. But sensitivity is too low, and he has given sensitivity for septal, which is 24%, for lateral, the sensitivity for septal 37%, lateral 24%, and average 30% sensitivity. So sensitivity is quite low in patients with preserved ejection fraction, and we need to keep that thing in mind when we are dealing with E to E prime.
But that is where we are looking for the diastolic dysfunction, when it is preserved. So
here actually the point is that if it is there, it is highly specific. But right, you can have good number of people who will have markedly elevated filling pressures and still the E to E prime may be normal or near normal. That is the difficulty. And that is one of the reasons why you should rely on two things. One is left atrial reservoir strain and the other is pulmonary vein flow. These two would take you ahead of E to E prime.
Yeah, so Dr. Chandra had suggested, he messaged me about the importance of IVRT. Dr. Chandra.
I think what JC mentioned is true. I mean, most of the time, you really need to look at the extent of the mitral annular calcification that is involved. And sometimes, we'll be surprised that if you scan a little bit posteriorly, just avoiding the iotomitral curtain, the septal area, you'll see at the crest of the interventricular septum, similarly the lateral wall, you may not be able to, you may be able to get the good tissue velocity, even though the annular calcium is present. If you have a sample volume about probably around 3 to 5 millimeters, and in that area you can get it. It's not that you can't get it. If it is too low, then you can't interpret. But on the other hand, if the signal is good and also the systolic velocity is well preserved, then you can use that. The other thing is to use the lateral area, averaging that. So I think in an extremely dense calcification like the one which is stenosis completely circumferential, there it's a problem. Sometimes it can also extend into the base of the ventricular myocardium and AV septum also, then it becomes a problem. Otherwise, you can try. I think the Jesse's point is well taken. The important thing is booster function as well as the LA. That will be a critical in these patients with the preserved ejection fraction, where you are having difficulty with assessing using the EE prime ratio. Then you can look at the LA strain, or even simply LA volume and booster function. You can look at both of them. They will show significant reduction. Then you know that LA pressure is elevated rather than depending on E prime alone. I mean, unfortunately, the pulmonary vein, we could get a good pulmonary vein and reversal and the duration of the reversal, like what Hadley had said. You can do that most of the time. But on the other hand, if you are not used to doing it, it doesn't become that easy. One has to practice. Another thing this thing also offers you is you can get IVRT with the tissue velocity also. So
right. I think that makes sense. So I think there was one paper where they have given a cutoff of IVRT of 80. So anything less than 80 milliliters per second is a high filling pressure, and not to use the E prime velocity in moderate to severe MAC. And if the IVRT is it is inversely proportional to the duration of IVRT.
Yeah, I agree. Yeah.
Dr. Nitin, your thoughts?
I think that was a very good JACC imaging paper about the IVRT. But I think in other way that most of these patients with MAC, they already have a lot of comorbidities. They are hypertensive, they are CKD, they are elderly. So the pretest probability of having a diastolic dysfunction is quite high. So most of these MAC patients that we see have concentric elevation, they have dilated left atria, they have the left atrial strength low. So most of the time when you see a very dense MAC, actually already that patient has got a very, very high chances of having a diastolic dysfunction. That is the way I look at it. So in that case, if the LA volume is high, then probably I think it already has a significant diastolic dysfunction.
Right. So one more question, is grade 1 diastolic dysfunction overdiagnosed?
Yeah, definitely it is overdiagnosed, because if you strictly go by ASC criteria, mitral E has to be less than 50 centimeters per second. And unfortunately, most people, the moment they see E less than A, they will write grade 1 diastolic dysfunction. While E less than A can have all three things. It can still be normal, it can still be grade 1, and it can sometimes be grade 2, especially if there is this you recorded E less than A during inspiration, and during expiration E and A are equal. So all three things are possible actually, and hence you are right that it is overdiagnosed. Grade 1 diastolic dysfunction is overdiagnosed. And I think the deceleration time must be taken in consideration, and only when it is exceeding 260 milliseconds, you should be talking about grade 1 diastolic dysfunction.
Right. I see. Okay, go ahead. Yeah. So I think Dr. Luigi is having some problem in logging in, but if I can request I can see Dr. Sunil here. Hi, Sunil. Should we take your talk earlier, and maybe when Luigi comes, we can? Will that be okay? So. Dr. Sunil Mankad is going to be stressing on strain imaging in valvular heart disease. If I can request Dr. Sunil to share his screen and slides.
Okay, I'm getting a message that host has this. Okay, there we go. Got it. Okay, good morning, everybody. It's a pleasure to be here again, and thank you again to Shantanu and Mahesh for the very kind invitation. And it's great to see my good friends and people that I'm very loyal to and have great respect for this morning. And I'm going to talk about a topic that's very close to being ready for mainstream, and I'll provide you data that would suggest that it's not a bad idea to do this and use it in the setting of valvular heart disease, and that's strain imaging. I have no disclosures. And the advantage of strain imaging in valvular heart disease is that it can detect subclinical LV systolic dysfunction before the ejection fraction falls. It can also be a prognostic marker. It may be useful in determining the time of intervention. Now, I only have 20 minutes and I could talk about multiple different valve diseases, but I'm going to focus on only two, and probably our two most important in cardiology, and that is mitral regurgitation and aortic stenosis. We won't tell Luigi that I didn't talk about tricuspid regurgitation. So this is an example. This is not a typical example, but we see here a 58-year-old man that's asymptomatic, but he has severe eccentric mitral regurgitation. You can see here that there's probably a flail posterior leaflet, not just prolapse, and a severe eccentric jet of mitral regurgitation going anteriorly. Now, this is the Mayo Clinic Formex, so here's the left ventricle in a short axis view. The left ventricular ejection fraction is normal. I'll give you the numbers in just a moment. So we have mitral valve prolapse, maybe a flail, and normal ejection fraction in an asymptomatic man. Here was the data from the echo. The heart was dilated, end diastolic diameter of 59, end systolic diameter of 38. The EF calculated at 66%. And the quantification of the mitral regurgitation did indeed show us that it was severe. There was normal RV size and function. He did not have pulmonary hypertension, but there was moderate left atrial enlargement. Now, according to the guidelines, this is the US guidelines, slightly different than the European guidelines. But if we focus in on the asymptomatic patient, his EF is more than 60, his end systolic diameter is less than 40. We can either do watchful waiting or active surveillance, as some call it, or we could go for repair. But if you go for repair, you have to have a more than 95% chance of success and a less than 1% expected mortality. He did not have either of these things, but nonetheless, I'm lucky to work at an institution where we at least approach these numbers. We're very close to them. So we made the decision to go ahead with mitral valve repair in our patient. And the repair was very good. Here's the pre-dismissal view of the mitral valve. But then this is the nightmare scenario. This is where your heart breaks. This does not happen often. I would say maybe 10% of mitral regurgitation patients. He did not meet any strict criteria for a class 1 indication for surgery, but we repaired the valve, and now the ejection fraction is reduced. So global hypokinesis. So we unmasked latent LV systolic dysfunction that was not picked up by just looking at the ejection fraction. And I think the calculated ejection fraction was around 39%. Once again, this is not the typical case. These are rare cases, maybe 10% of severe MR do we get LV dysfunction. And there is a chance that there'll be some recovery of the LV if we give ACE inhibition, beta blockers, etc. But nonetheless, in a 58-year-old man that was asymptomatic, this is less than an optimal outcome. So the question that we must ask is, could we have detected this latent or subclinical LV dysfunction despite the normal EF if we had used strain imaging? And can strain predict the outcome after mitral valve surgery for mitral regurgitation? And there is very much accumulating data, and I'd like to review that. So just for the fellows that may be watching, just to review what strain imaging is, normally we look at wall motion by looking at endocardial movement and wall thickening, and we basically call a wall normal, hypokinetic, akinetic, or dyskinetic, and then sometimes we even call it mild, moderate, or severely hypokinetic. These are all subjective and semi-quantitative measures. What strain imaging is a change in dimension. It's a dimensionless quantity and represents the percentage change in dimension. Lagrangian strain is basically the length, the new length, minus the original length divided by the original length. So you can see here, both of these myocytes would have velocity and motion, but only this myocyte that's changing its length would have actual strain. This myocyte would not. It would have velocity and motion, but it would not have any strain. We also look at strain versus strain rate. Strain is the absolute deformation or change that occurs, and strain rate is how quickly that change occurs. For example, here is two patients, the turtle in the hare, the tortoise in the hare. The tortoise has that strain rate, the hare has a much faster strain rate. Both of their strains are the same, but their strain rates are different. The hare has a much higher strain rate, just so you have the definitions. Now, today we use speckle tracking. Just like we look up into the skies and recognize the constellations, on the left we see Orion, we can look at the speckles in the heart, in the myocardium, and track those over time. So that's the way we measure strain. We measure the deformation and change in these speckles. Now, there's different types of strain. There is longitudinal strain, which is really what we're going to talk about today, and it's the most commonly used. And you can see here, with longitudinal strain, the myocyte is actually getting shorter. And because it's getting shorter, the distance, it's actually going to be a negative number. And normal strain is approximately 18 to 20% negative, longitudinal strain. Then there's circumferential strain, or the twist that occurs. And once again, in this case, the myocytes are getting shorter, so the strain is a negative number. And then there's radial strain. In this case, the myocytes are getting longer, so strain is a positive number. Know that these different strains exist. I'm going to really only focus on longitudinal strain for the purposes of this talk. So we can go back all the way to 2004, 16 years ago. Dr. Wahi and Dr. Marwick and the group, I believe in Australia, looked at patients with mitral regurgitation and whether they had contractile reserve or not, and what their strain and strain rate was. And the bottom line here is, if you had contractile reserve, you had a better strain rate and a better strain. So strain predicted if you would have contractile reserve in patients with severe mitral regurgitation. And it was close to those with normal controls. If your strain was abnormal, chances are you did not have contractile reserve. And I'm not going to go over the data, but contractile reserve does predict postoperative ejection fraction after mitral valve repair. These are two other papers that I'll include for references. Dr. Pepe Zamorano's group and a group in Korea have looked at strain in mitral regurgitation and predicting ejection fraction. I'm going to focus in on this paper by Patrizia Lancilati and Luc Pirard from Europe. And they looked at strain and, in fact, exercise contractile reserve strain in patients undergoing mitral valve surgery, and whether it could predict what the ejection fraction is postoperatively. And sure enough, baseline ejection fraction did not predict those that would have an EF less than 50% post-op. Now, these were mostly rheumatic patients, so they had mitral valve replacement, but nonetheless, and that's why I think the number and the percentage of lower EFs is higher than we would predict, but the EF did not predict it. Resting strain, however, did. More importantly, if we look closely, contractile reserve as well as the contractile strain reserve especially predicted those who would have a low ejection fraction. So strain and strain contractile reserve predicted who would have a low EF. We'll then move forward. This is a multi-center study from Cleveland Clinic and the Netherlands, and it looked at global longitudinal strain predicting LV dysfunction after mitral repair. We're now at the year 2012. And lo and behold, the number of people that had a low EF post-op is pretty low, 29 out of 204. And I think that's a fair example of what we see in daily practice. It's rare to have a low EF if you had a normal EF going into mitral surgery, but it does occur. It does occur. And guess what? Many things predicted that. If you had a lower EF, if your heart was bigger, either by end systolic diameter or by volumes, and global longitudinal strain also predicted if your EF would be low postoperatively. And when they did multivariate analysis, only two things stood out. If your end systolic diameter was greater than 40 going into the mitral surgery, or your global longitudinal strain was abnormal. So strain predicts whether you have a lower EF postoperatively. We then go to this study, and this is my former fellow, Melinda Tsai, who's at the Cleveland Clinic, and this is a Cleveland Clinic study looking at strain in a large population of patients. The previous studies I showed you were in the hundreds, but this is almost 700 or 800 patients in this particular data. This is Cleveland Clinic data. Some of these patients underwent mitral valve surgery, some did not. The first thing that Melinda and his group showed was that strain predicts outcome. If your strain becomes abnormal, irrespective of whether you had surgery or not, your mortality goes up. If your strain is abnormal with mitral regurgitation, whether you do surgery or not, your mortality is increased. This is another way of showing it. Abnormal strain, higher proportion of death compared to normal strain. Melinda also broke it down based on exercise capacity. The group that had the lowest proportion of death had a normal strain and good exercise capacity in blue. The green curve here had a normal strain but did not exercise very well. The yellow or gold group here had an abnormal strain but exercised well. So understand, strain predicted mortality more than exercise capacity. And the group that did the worst had poor exercise capacity and abnormal strain. So strain is definitely a prognostic marker. And like I said, many of these people, most, did undergo surgery, but it didn't change anything. Whatever your strain was still predicted your mortality. Some did not go undergo surgery, but nonetheless, it's a large study. The Koreans then went on to do another investigation. We're now very close to our contemporary time period, 2018, and they looked at strain in the prediction of outcomes after surgery for mitral regurg. And the way this works, this is a combined cardiovascular endpoint, but they're hard endpoints: death, stroke, MI, heart failure, etc. If you had LV dysfunction or you didn't have LV dysfunction, having an abnormal strain in green increased your risk of events. If you had AFib or were in sinus rhythm, an abnormal strain increased your risk of the combined cardiovascular endpoint. Whether you had mitral valve repair or whether you had mitral valve replacement, having an abnormal strain increased your incidence of events. So strain predicts outcome. And this is just another way of looking at their same data. An abnormal strain was associated with increased cardiac events. And if you look at death from all causes, strain predicted that as well. So it is definitely a prognostic marker in mitral regurgitation. All right, let's move on now to aortic stenosis. So when we look at aortic stenosis and we assess it, of course, we look at the aortic valve, we look at the LV function, and we look at the patient, whether they have symptoms, do they have hypertension, what is their end-terminal proBNP. Many factors go into it. And of course, most importantly, do they have symptoms or not? What I'm going to focus on is the asymptomatic patient, the asymptomatic patient with aortic stenosis. So this is Dr. Pellica from my institution's data, going back now 15 years. In an asymptomatic severe AS, meaning their velocities were over 4, their mean gradient was over 40, you can see that at 3 years, half the patients will have developed symptoms. And at 5 years, almost 70% of patients will have developed symptoms. So you're going to develop symptoms. Dr. Otto has reported the increase in the gradient and the velocity per year, and that's something to keep in mind. So in other words, aortic stenosis is going to progress. That's why there are those that argue that once you develop severe AS, maybe we should just fix the valve. But we have to remember that putting in a valve gives us a sudden death rate, or just, I shouldn't say sudden death, but a death rate of about 1% per year. That is the same as the asymptomatic patient with severe AS. So how can we find these 1% of patients that are going to die suddenly? Well, of course, we can do a treadmill. And this is data from Bob Siegel and his group looking at a meta-analysis. And if you look at the world's literature, there's not a lot of patients. We're talking about 500 patients total that have published in exercise aortic stenosis studies. It's, first of all, it's safe. Most importantly, you can see here that not a single patient that had a normal stress test, meaning a normal blood pressure response to exercise, no chest discomfort, no arrhythmias, no significant EKG changes, not a single one that had a normal stress test had sudden cardiac death. And 9 of those that had an abnormal stress test did have sudden cardiac death. So maybe a stress test can help identify those that are at risk for sudden death. And that we do this routinely, of course. The problem is these are elderly patients. Many of them have arthritis. Many of them are frail and simply cannot walk on a treadmill. So a treadmill test is not possible. In those patients, we often turn to N-terminal proBNP. And I suggest to you, and I'll show you the data here now, that strain should be in the same category as looking at an N-terminal proBNP. It is a prognostic marker in asymptomatic AS. So here is a patient with aortic stenosis that has an abnormal strain. What's the data? Well, this is data from Nagata going back 5 years. But if you looked at asymptomatic severe AS with a normal EF, because remember, if their EF is reduced, that's a class 1 indication for surgery. We're only talking about 100 patients, but strain predicted survival from MACE. So strain does have prognostic value. Here's another study now looking at different variants of aortic stenosis. If we look at the normal ejection fraction and preserved LV global longitudinal strain group, they had the best outcome. If you had impaired LVEF, your outcome was worse. But let's put in there the normal EF but abnormal strain group. Once again, these are asymptomatic AS. If your strain is abnormal, you did just about as bad as if your EF was low. Now let's look again at a different study. This is from Japan. If you have low flow, paradoxical gradient, but preserved strain, and normal flow peak gradient, your outcomes are pretty good. Once your strain becomes abnormal, if you have low flow, low gradient, or even if you have normal flow, high gradient, you did worse. So this group had an abnormal strain. This group had a high gradient. They did about the same. So strain predicts outcome. And the worst group, of course, was the low flow, high gradient group down here. So strain may not be as predictive as ejection fraction once your EF gets low, but nonetheless, it is of prognostic importance. And finally, a pretty recent study in JAMA Cardiology by the Europeans, Jerome Bax and others, looking at strain in asymptomatic severe AS group. And now we're talking a pretty good number of patients, 100, 200 and some patients. All right. So strain predicts event rate. Now, many of those events were simply AVR. They don't really tell you about sudden cardiac death. Death was not really reported in this study, but nonetheless, an abnormal strain resulted in increased events. So this is a fairly large group. So I would put it to you that just like a patient, if a patient cannot exercise with asymptomatic severe AS, we should look at strain just like we look at N-terminal proBNP and try to help make a decision as to the timing of surgery. I don't think it'll quite make it into the guidelines just yet because we're talking several hundreds of patients, not thousands of patients. But nonetheless, it's easy to do, it's reproducible, and it's something that we have in our arsenal. So in conclusion, strain imaging is a rapidly evolving technique which objectively evaluates global and regional LV systolic function. It allows for the quantification of myocardial function and detection of subclinical LV dysfunction. And it's very feasible. Larger trials are definitely needed before it makes its way to the guidelines, but the data is promising. And if your lab can do strain and do it well, I see no reason not to include that, just like we would include N-terminal proBNP in our assessment of patients with asymptomatic severe aortic stenosis. I'll close with this quote. This is Carl Gustav Jung, a famous psychologist. Your vision will become clear only when you can look into your own heart. He who looks outside dreams. He who looks inside awakens. But I'm more simple. This is a famous actor from the United States who passed away, but James Dean. Dream every night as if you will live forever, but live every day as if it could be your last. Thank you very much.
Thank you, Sunil. Amazing and simplified talk. So, a question right away for you. What's the cutoff of strain for MR to call it to be abnormal?
That's a good question. So in the studies, it was quite abnormal. So they used cutoff of -14, -15%. Now, in our lab, -18% is the cutoff of normal to not. So in other words, above, when we say above, I mean more negative than -18% is normal. I think anytime it becomes abnormal, I would be careful. But if it's quite abnormal, -14 or -15, I would be worried, and I would strongly consider an intervention. That being said, I think it depends on the skills of your surgeon. I'm lucky to work with some really wonderful surgeons, and I know in India there's some great surgeons as well. If your surgeon has great skill, then you have a lower threshold to operate. If it's going to be a replacement, then you're not as anxious to do the surgery. But -14 to -15% in most of the studies.
So can we
So really abnormal.
So can we straightforward say that when the GLS drops to around -15, he is a straightforward candidate for surgery or repair?
You can say that there is definitely LV dysfunction, and as long as there's no other cause and it is severe mitral regurg, I would say it's a pretty safe bet. But you make sure there's no other cause of the LV dysfunction, of course.
So, Dr. Mohan. Yeah. So we are talking about severe mitral regurgitation, but do you think if we have moderate mitral regurgitation with good LV function, but LV strain of around -13, -14, of course, other causes of LV dysfunction are ruled out. How do you think we should be very careful in this, in quantifying as MR, moderate MR?
First and foremost thing is that there are very limited studies on moderate mitral regurgitation. Actually, very, very limited studies. And quantification of mitral regurgitation is not an absolute thing. It's more semi-quantitative. Whenever I diagnose somebody with moderate mitral regurgitation, despite all parameters, looking at LV, left atrium, looking at pulmonary veins, regurgitant volume, PSI, and so on, so I always take help of CMR to decide how much exactly is the regurgitation. Closer it is to 60 ml with a low ejection fraction or low strain, more I am inclined for mitral valve repair. Closer it is to 40, less I am inclined to send these people for surgery. This is what I follow in my practice day in and day out, and I have been doing this thing for 30, 40 years.
Dr. Sunil,
please to make a comment on that.
Yeah, Dr. Chandra, anybody can comment.
I think that's a very, very reasonable approach, and he's right. As much as Mayo Clinic, we like to think that we're perfect at quantifying mitral regurgitation.
क्या करना है? So, how do we speak?
ये चालू हो जाएगा ना, इसमें जूम चालू कर देते ना लैपटॉप में.
इधर जूम चालू, ये भी वाईफाई गया ना, उनका वाईफाई वहाँ पे.
अच्छा, ओके. तो अपने इसमें कनेक्ट कर देना.
तुम्हारे इसमें कर रहा.
इसमें कनेक्ट कर देना.
कुछ कर सकते? तुम बताओ.
Eliminating the need for user interaction and aligned with the Speckle task force. You need accurate mitral valve quantification with dynamic assessment to provide quantitative information that can aid better understanding of complex pathologies. EPIC CVX Release 5.0 brings together the unique strengths of Philips and Tomtec to create a seamless, integrated experience for all your echo examinations. Designed for cardiology, built for better care. Philips EPIC CVX. Innovation and you, Philips. You want exceptional image quality. You need to assess the function of the whole heart, not just the left side. You need easy-to-use, robust quantification tools that deliver fast and reproducible results wherever you need them. With an 8% reduction in standard exam time and 21% fewer control interactions, ultrasound can be more definitive without extending exam time. You want to assess your pulmonary hypertensive patients more robustly, with a user-friendly tool to measure right ventricular function with consistent results. EPIC CVX uses artificial intelligence to align the view, position landmarks, and detect the RV border in as little as 15 seconds, enabling everyday clinical use. You want to measure global longitudinal strain quickly, to better assess overall cardiac function of patients in an everyday setting. EPIC CVX uses advanced automation technologies to deliver one-button push robust and reproducible results, eliminating the need for user interaction and aligned with the SPECL task force. You need accurate mitral valve quantification with dynamic assessment to provide quantitative information that can aid better understanding of complex pathologies. EPIC CVX Release 5.0 brings together the unique strengths of Philips and Tomtec to create a seamless, integrated experience for all your echo examinations. Designed for cardiology, built for better care. Philips EPIC CVX. Innovation and you, Philips. want exceptional image quality. You need to assess the function of the whole heart, not just the left side. You need easy-to-use, robust quantification tools that deliver fast and reproducible results wherever you need them. With an 8% reduction in standard exam time and 21% fewer control interactions, ultrasound can be more definitive without extending exam time. You want to assess your pulmonary hypertensive patients more robustly, with a user-friendly tool to measure right ventricular function with consistent results. EPIC CVX uses artificial intelligence to align the view, position landmarks, and detect the RV border in as little as 15 seconds, enabling everyday clinical use. You want to measure global longitudinal strain quickly to better assess overall cardiac function of patients in an everyday setting. EPIC CVX uses advanced automation technologies to deliver one-button push robust and reproducible results, eliminating the need for user interaction and aligned with the Speckle task force. You need accurate mitral valve quantification with dynamic assessment to provide quantitative information that can aid better understanding of complex pathologies. EPIC CVX Release 5.0
This is a
brings
hotly
together the
contested
unique
topic and
strengths
people
of
have
Philips
different
and
views of
Tomtec to create a seamless, integrated experience.
Great.
For
So
all your echo
I think
examinations.
Partho has joined.
Designed for cardiology, built for better care.
Yeah, Partho,
Philips
can
EPIC
you unmute?
CVX.
Yes. Good.
Yeah. Okay.
Good
So
evening.
Innovation and you,
Hi.
Philips.
Hello.
Right. So we have Dr. Chandra also here.
Hi,
What
Dr.
the-
Sridhar, how are you?
Good, man. Good. How are you? Good. Good to see you. And I enjoyed your talk yesterday.
Oh, thank you.
So actually, he was chatting with us from the other side. I said, why don't you join here? And so actually, I missed him in this scientific session this time for a talk, but he was kind enough to join us for the discussion. Thank you so much. So,
Shantanu,
yeah.
Ours is a completely male club, you know. I think Madhu is watching. Why don't you invite her?
Oh, Madhu is
and
there. Okay,
ask
I
her
didn't
to
see.
join.
Hi, Madhu.
Have
How are you?
At least have one woman, actually.
Okay.
Have at least one woman.
Hi, Madhu.
She's
I think she has.
Madhu, unmute yourself.
And screen also.
Hello.
Yeah.
I'm listening.
Yeah, we can.
Dr. Madhu, speak loudly and show your face.
Okay.
Show your face.
Uh,
I mean, unless you are in a nightgown, then it's a different story.
so,
No. I will just talk.
Okay.
Dr. Sunil, I have one question for you for this strain thing. Are you there, Dr. Sunil? Or yes.
Yes.
Yeah. Okay. So what about asymptomatic aortic stenosis with normal LV function? No low flow, no nothing. What is the cutoff of strain?
I think again, if it's quite abnormal, minus 15, minus 14, you have to be concerned. If they can still walk on a treadmill, we would prefer that. We would certainly incorporate the N-terminal pro-BNP. That's what we use at Mayo, but BNP is obviously better published. But I would say if it's quite abnormal, minus 14 to minus 15, I would be concerned about. I would push the patient to get the AVR. If they still refused, then we have to respect their opinion. Obviously, the treadmill, I think, is still the way to go. If they can walk on a treadmill and seeing their blood pressure response to exercise, that's still the best way to go. But I think strain is emerging as another marker, I think in a similar category to BNP.
Perfect.
We are aware of the paper Tom Marwick published last year in JACC Imaging, and that was 14.7 if it is asymptomatic AS and the GLS is 14.7 or less. Consider CMR. CMR shows T1 mapping abnormal. Consider surgery. 14.7 to 18. Every I think every 6 months to 12 months echo will strain, and above 18% every year, or every year, or every 2 years, I forget now. But 14.7 was cut off with Tom Markey, but he didn't say straight AVR. He said these people should first have CMR, and then if there is evidence of abnormal T1 values or T1 mapping, then they should go for surgery.
Yeah, so
So your view on that?
I think we had a small connection problem. So let me summarize for the audience. Dr. Sunil spoke about mitral regurgitation and aortic stenosis, use of strain, and he said that the cutoff of severe mitral regurgitation with good LV function should be anything less than -18. And if you are going to -15 and -14, you have to be very careful. Is that okay, Sunil?
Yes.
Right. And for aortic stenosis, if it is again around going to -15, -14, you have to be very careful. So this is, I would like to wrap up for this talk. And of course, Dr. Mohan highlighted all the details about pro-BNP. So if I can request Partho to share his slides, and he's going to focus on AI in echo.
Yes, so let me just share my slides here and go to my first slide. Are you able to see?
Yes.
All right, good. Thank you very much. Once again, it's just amazing to be connected virtually with everyone. And most of the people here are my teachers, friends, and Nagpur, being my hometown, it brings back special memories. And hopefully in the near future, we'll be having the opportunity to meet everyone back in person. But for now, Shantanu asked me to speak upon artificial intelligence in echo. And this is a territory that we've been working on, and there's a lot of buzz in the last couple of years. We've been working on for almost 6 or 7 years. And I think it's going to completely transform the face of how we perform echocardiography and cardiography. And while this is a technical topic, my interest is to present to you the core concepts of how an echocardiologist would be impacted. And I'm also very delighted that Mayo Clinic has taken up a major initiative in AI. I recently had an opportunity to visit them and present some of our work. And there is actually a complete separate department and division of AI that's working in concert with cardiology. And a lot of very cool work is coming out. And it's a field that we need to be looking forward to. It's translating very rapidly into clinical practice. So when we talk about AI, this is a slide that is Dr. Jim Seward's appearing as Obi-Wan Kenobi in one of the American Society of Echocardiography platforms and discussing with me. So it's a futuristic concept. We had an opportunity to present. This was in 2013. And that was the time frame I started getting connected to AI, and we produced some of the work and displayed some of the work. And it seemed to be a far-fetched concept at that time. And in fact, I didn't believe that this is going to translate so rapidly into clinical practice. And now we are 6 or 7 years down the road, and it is a certainty. It's impacting almost everything that is happening. And this figure shows actually somewhere around that time, 2012, 2013, we started seeing an exponential trend in, again, the research that started happening in application of AI in echocardiography. And you can see this is a curve of how much enthusiasm worldwide people have had in research in applying AI. And so this is a reality. This is something that we have to be embracing. And conceptually, how it's going to transform us is a journey that we need to discuss and be part of. We have a clear idea that we are having several parameters, and we spoke just now on valvular heart disease. We are seeing strain. So we have 2D, 3D, Doppler, multi-parametric strain parameters, and lots of information that we have to make decision from. And the most important aspect is that we're talking about these cutoffs and thresholds. These cutoffs and thresholds are extremely modified by the presence of other biological parameters. For example, a strain of -15 may have different meaning in an athlete's heart versus it will have a different meaning in a mitral stenosis. It will have a different expression for females versus males. So there is a multivariable, non-linear interaction between all these variables that can change what we call as normal or abnormal. And typically this is very difficult to use, therefore, in clinical practice, a single threshold. And most of the time, if you would have seen in guidelines, even for looking at mitral regurgitation, you can't just rely on one parameter. There is biological noise, there is instrumentation noise, and there is interaction between different parameters. So most of the time, we are doing a multi-parametric evaluation. Now, what is this multi-parametric evaluation, if you think about? Yes, you can come up with some solutions through a decision tree for a multi-parametric equation, but it's actually a non-linear model in your brain. Someone like Dr. Mohan, who has seen over years, has trained his neuronal circuits to be able to diagnose severe MR, reject one hypothesis through one model based upon the observations that he's seeing for a given case and make a decision. And most of the time, the decisions are very intuitive. Clinical intuition, unfortunately, still is an important aspect. There is a very important aspect of expert decision making that comes daily in our clinical practice. And we don't just react to some cutoffs or threshold. We take everything into context. And that is a model in your mind. There is an opportunity to bring that model to life and train computers. So echocardiography data is not only just growing in numbers. Not only we do a lot of echo procedures in patients, but also the information that is coming from echo is wide. There are several parameters. So we have tall and a wide big data that is coming out from echocardiography that needs to be taken into consideration and assimilated for an individual decision making. How do we do that? On top of that, you have to combine the clinical picture. You have to combine the cardiac imaging, echocardiography data with all the biomarkers and put that story together for a given patient. How do we do that? So this is a complex question that needs a solution. Most of the time, if you're an expert, you may be able to integrate for a given individual patient. But in absence of previous training, how would you do that? So there is therefore a need for understanding how different fields of engineering can be applied for echocardiography data sets and clinical data sets. So we know of a field called as data science, which interacts with big data. And artificial intelligence is a field that tries to bring this impact into action. So the artificial intelligence, if you just define it for lay terms, is an act in which machines start working like humans. They have a human-like tendency. So that is artificial intelligence. Machine learning is a subset of artificial intelligence where you are giving autonomy to a system. So the system automatically learns on its own. You don't have to train it. After you provide data, it learns on its own and it develops its own decision. So this is a full autonomy that is given to the machine after training, and the system is capable of training itself. You can influence the training, but it will learn on its own. And deep learning is a new area which works on bio-inspired, brain-like machine learning, neuronal subsets, where just as our brain learns from data, it's the same type of information that can be provided, and the same mechanism can be used by the computer. So it's a subset of machine learning. And on top of that, you need to have definitely physicians with their domain knowledge. You need to have engineers and programming people, you need to have understanding about mathematics and traditional statistics. So all of these skill sets are important in this whole process of machine learning application to bring them to clinical fruition. So clinicians therefore need to be able to work very closely with the engineers, and that's what we do, and that's what it's being done in Mayo Clinic, so as to understand how we can apply these concepts for clinical practice. So this is a schematic of how typically a supervised learning would be done for developing a machine algorithm. So you, let's say, have a data set and you have labels. You have a red label and a blue label. You give that labeled data initially to train a machine learning software, and it trains it, develops a model, separates it out, and this is called as a training. You're training, and then you send that trained algorithm to a separate set of data where you're not training it, but you're seeing its performance. So this unknown data or a testing data is a validation pool in which you see how well you have trained your machine learning algorithm and look for its performance. But remember, for all of these processes, you need to have labels. Number one, you need to have labels. Labeling is important if you want to supervise and develop a supervised machine learning algorithm. But most of the world is unlabeled. Just as a child interacts with the world when he starts, for example, walking, you don't supervise the child all the time. You don't tell what to do. It does on its own. So it interacts with the unlabeled environment and learns steps and does things on its own. So that is called as an unsupervised learning. When you don't have labels, when you don't train, but it trains on its own, making sense of the world, making sense of the data that is seen around. That's called as unsupervised learning. On top of that, the parent comes and gives him some degree of supervision so that he does not fall down, hurt himself. That is called as a supervised learning. So you have bulk of the machine learning or even human learning is unsupervised. And then there is a supervised learning on top of it. And finally, you have the reward. So if you see the child doing something unusual, something that is of danger, you reward or punish the child. That is called as a reinforcement learning. All of these processes are also applied for machine learning and utilized for a prediction of final events that are of interest to us. Remember, bulk of the medical data, bulk of the echocardiography that we do is unlabeled. There's a lot of unlabeled features where we do not know what the meaning is. So one of the tasks that machine learning, when you start using for application in echocardiography, is to understand the meaning of the data that is around it. So let's see how machine learning is going to transform. So number one impact that we're going to see is that it's going to use the augmentation of the old century solutions. For example, the ECG, the whole body potential is been condensed into a single line for ease of our interpretation. But remember, there's a lot of features from the 12-lead ECG. There are lots of features, lot of interactions, lot of stuff, nonlinear behavior we do not take advantage of. And you can take care of all of these and make up machine learning model. So if you can take some of the signals from the surface electrocardiogram, you can come up with prediction whether this ECG from a patient will have an echo that will be systolic dysfunction or diastolic dysfunction. There's a foundational work that was done at Mayo Clinic where prediction of severe LV dysfunction was possible based upon simple ECG on the body surface and with a very high ability to predict out in the real world. And this is getting applied in real time as we speak. Companies are being formed, and this is a true change that is happening. Remember, we do echo in a lot of patients. Many of them may be appropriate or inappropriate. Think about an opportunity to standardize the process where you can use an ECG, predict where there'll be the highest yield of performing an echo and perform the echo only in those patients. And this is a work that is going to come out in a couple of months where we have gone into a multi-center prospective trial where you have a ability for the ECG to predict out almost every feature of diastolic dysfunction that will otherwise only come from echocardiography, with great performance for predicting guideline-based thresholds for defining diastolic dysfunction. So look forward to seeing this in a couple of months. It's already accepted in JACC. So this paper is going to come out very soon. So what I'm saying, it's completely transforming the fabric of how we practice medicine, using AI for automated prediction of where echocardiography will be abnormal. And this is going to make it easy for us. If these solutions are well crafted and well utilized, it will be a good standardization technique for reducing the burden of clinical care that we see in the community. Number two, using AI for augmenting the 21st century solution. Let's say we have a lot of variables. Everybody has got now some kind of smartphone app that is tracking their sleep, what they eat, their pulse, and so on and so forth. Same way we have smartphones which can perform ultrasound. How can we integrate that data to make cost-effective solution? How could we understand what this patient's symptoms can be tracked, patient's activity can be tracked? We can make more meaningful integration of the information for training the models for predicting outcomes of interest. For example, this is a work that we did recently, a couple of years back, where we used untrained workers and fellows and residents to perform echocardiogram without giving them the ability or training them to do echocardiogram, and a machine learning technology was training them as they were acquiring the images. So you can see here, this is a pocket ultrasound smartphone on a smartphone, and this is a micro machine array. This is not a piezoelectric crystal transducer. This is a micro machine array transducer, which is acquiring the images and giving it the information, move it this way, move it that way. This is how you're going to obtain the apical four-chamber view, parasternal long axis view. And this particular product is already out. And there are several startup companies that are currently in the market trying to do the same activities. And the ASE is buzz with all kinds of abstracts and scientific work which is validating some of this concept. So imagine that you have an untrained physician who can be well trained to acquire images even using artificial intelligence. Number three, workflow efficiency, tremendous impact of AI. You don't have to learn the mathematics of how to do an AI. The algorithms are automatically behind in your systems. Almost every ultrasound system is having some form of AI that is taken place. For example, whenever you talk about an automated segmentation or boundary of the LV endocardial border, anytime you see an automation, there is an AI engine that has been trained and is automatically finding the contours of the LV. So you can see here, some of these solutions are automatically ingrained inside the computers, and they're working on the background, and they're helping the efficiency of the solution, be it stress test or whatever. We are going to see a profound, even further impact of AI very soon. Almost every measurement, every single measurement in echocardiography can be done automatically without you having to do it manually. Deep learning is profoundly changing and making it more consistent for application. There are several papers in pipeline right now that are coming in and showing the ability to just you upload the images, acquire the images, it takes care of all the measurements. You don't have to worry for any of the measurements. So deep learning is completely going to change and make it very cost effective and time efficient for you to perform your echocardiography. And this is a convoluted neural network, which is a form of deep learning, which is even tracking contrast boundary, providing you assessment of LV strain, LV volumes, ejection fraction. And this is just you upload the images and it takes on its own. You don't have to do a single click. So and imagine it has got an ability to not only track and obtain the volume, but it can also understand where to go. For example, here is a image where the person has taken a RV and then followed by LV. The task was to track the LV. So it knew that what it was tracking initially was the RV. So it jumped back from the RV to the LV and started tracking. And it can diagnose, and it can work in even in presence of poor image quality. So a lot of ability of these practical algorithms to do it in real time and provide real-time measurements is going to facilitate our ability to make decisions more promptly and get more quantitative information. AI can track, classify images, provide information about the measurements seamlessly and with a great accuracy. In fact, in this particular study, the accuracy of identifying images and tracking them was higher than board certified cardiologists. And this is a work from Rima Arnott's group from UCSF. And finally, this couple of months back, I had the fortune to write this editorial in Nature. And this is a breakthrough. This was a breakthrough in which 3D convoluted neural network, deep learning, doing a beat-to-beat tracking. Beat-to-beat tracking means it's going on every single beat, and it's predicting what the ejection fraction is going to come out at the end of the systole. So you can see here, the prediction is not after you have given the image, it is doing in real time as the images are being acquired with very little delay. And it's going to be able to give a prediction after a few beats, a few frames that, well, this is going to be the ejection fraction. And of course, it gets the ejection fraction at the end of that cardiac cycle. More importantly, this is very crucial because there are certain places where we have challenges. For example, human tracking of LV ejection fraction or strain for several beats is an impossibility. You cannot keep on doing the measurements back and back. For example, in a patient with atrial fibrillation, you have 10 to 15. For example, the guidelines say that you need to do average of 5 beats in atrial fibrillation. How many of us do it actually? No one does it in real life. So here is an ability for us to get the real ejection fraction, several beats averaged, so that we can make powerful implication for applying our guidelines to clinical practice in a more standardized fashion. So this is the work, and this is going to happen not only for ejection fraction, strain, and every parameter, which is very variable and changes from beat to beat. So this beat to beat variability is something that we have not taken into consideration, and it opens up the possibility to understand cardiac function, that variance from beat to beat. Just like we have heart rate variability, maybe in the very near future, there will be beat to beat variability of the cardiac function over time that can be taken into consideration. Not only measurements, once the measurements are obtained, it can almost predict what likelihood of that patient. Is this hypertensive heart disease? Is this amyloid disease? And so on and so forth. Athlete's heart. Some guidance about what is being seen with the measurements could appear in real time as the images are being acquired or as the images are being interpreted. This is really useful because this will allow us, for example, at the late evenings when we are tired and we are going up and reading some of our echoes, it will reduce the likelihood of us making mistakes. So this is going to be almost like a decision support tool you will activate when you're tired, and it will help you to guide through the end of the day, because workload is not reducing, workload is only increasing. Disease is not reducing, disease is only increasing, and we are going to do more and more echocardiography. That's what is going to happen. And this work from Rahul Deo's group in circulation showed the ability to detect automatically HCM, amyloid, pulmonary hypertension, so on and so forth. This is quite incredible, that automated measurements and followed by automated diagnosis. Risk stratification scores. So when you talk about Framingham risk, ASCVD risk scores, ability to predict the mortality from stress echocardiography, so on and so forth. This is where machine learning does extremely well. Prediction of where the stock market is going to go is a routine application. We use AI for the stock market all the time. Same way, predicting where is life going to be for a patient is an important question. And I think personalized decision making is going to be more powerful. And this is a work coming from, I think I'm projecting right now a work from CT, but similar work has been done in echocardiography, where the machine learning algorithm outperforms the traditional statistical scores that are used in clinical practice. education and standardization. I showed you that we can use echo for looking at images and quantifying the images. Here is an imaging being done, and it's waiting and giving a feedback to the worker of how best. Now you got the 4-chamber view. Yes, gamification of education. It's basically almost like training people to get the feedback on how best to perform echocardiography. Imagine this being used for our fellows and routine clinical education sonographers. This is going to allow us to translate our ability to teach people on how to perform education, educate them on how to perform echocardiography more seamlessly before even the robots come in, and maybe when the robotics comes, and perhaps even that stages will be a different world where we will be taking over to do different caliber of working in the near future. So standardization, education, everywhere is applicable. Up till now, I spoke about supervised learning. There is also a lot of need for understanding the unknown data, unlabeled data. A lot of the work that is going on in heart failure, for example, there's a lot of confusion. What is heart failure, diastolic dysfunction, heart failure with preserved ejection fraction? And here is where we started using the unsupervised learning, trying to understand what is diastolic dysfunction. And yesterday, as I said, that we need powerful tools for understanding diastolic dysfunction. This is where we started working. There's so many variables that define diastolic dysfunction. And we started using algorithm, which are called as clustering algorithm, which can learn on its own from the variables and group patients into different patterns of risk. These clustering algorithms have really become very powerful and can identify patient clusters superior than the traditional guideline documents. And here is a work where we showed the ability to perform diastolic dysfunction classification and remove the indeterminate cohort and provide prognostic information. This was an initial attempt, which has subsequently proceeded with more work. This is Dr. Tokodi. We published this work in JACC Imaging a few days back, where the clusters of the patients were automatically identified, and you can see their abilities to predict the subsequent cardiovascular outcomes in form of heart failure, hospitalizations, and death. So automated information gathered, clustered, and then teaching us on identifying the high-risk phenotypes. This is the next era and is going to allow us to move in the new world of artificial intelligence. So cardiac ultrasound applied to echo to extract the information that would otherwise only come from cardiac magnetic resonance, like T1 mapping or delayed gadolinium enhancement scars. And Dr. Kagiyama won his Young Investigator Award last year for this work, which is now published. Imagine your echocardiography becoming so powerful that it is able to provide you information that would otherwise only come from CMR. That could be very useful to decide which patient needs a CMR. That could be a strategy. And finally, this work, which is being presented, and Dr. Pandey is a Young Investigator Award winner this year. You will hear about this work at the ASC Scientific Session. Was transformational. It not only trained the ability to learn the unknown, so we identified high risk and low risk clusters, but we developed a classifier which was then applied for patients undergoing invasive cardiac catheterization, and it was able to predict invasive filling pressures. Not only able to predict invasive filling pressure, but also we went back into the old trials, the TopCat trials, and we identified the TopCat trial, which was not able to identify the impact of spironolactone. When you apply the lens of machine learning, it segregated the groups of the patient where there was a therapeutic effect. So imagine your ability to identify individuals who are going to respond to therapy. That's going to be very powerful because it is very heterogeneous. These heart failure patients are extremely heterogeneous, and our ability to identify in this heterogeneity the groups, subgroups that can be responding to therapies is very critical. You cannot apply the same knowledge for every patient because it's not an average patient. Your patient is a single patient with its own attributes and feature, and you need to be able to come up with a personalized solution, and that's where it's going to go towards. All kinds of data from echo, strain, vector flow mapping. How do we integrate it further on? We need AI, and this is a work which was published, which is online right now in JAC, which allows us to seamlessly integrate more and more data quickly and make solutions from all the information that is coming through. Finally, the question that's often asked is, will AI replace us? The answer is no. AI is not going to replace us, but people who don't use AI will be replaced by people who embrace AI. So AI is not going to replace us. It's only going to elevate us up into higher domains of function, into high calibers of function. Remember, the AI right now that we use is not as good as the bio-inspired brain. It still makes a lot of mistakes. We need a lot of data to train it. Human mind can learn from few examples, few rare cases, and we know how quickly to extrapolate. That strength is currently not there in AI. But we can make AI to work for us. We can make the AI to do things which we do not want to do. Routine measurements, all the mundane work in the day-to-day activity, which you don't enjoy. Let us make AI do that, and let's evolve in our higher caliber of working so that our days are much more enjoyable and we come more closer to patient-doctor relationships, which are more critical for taking care of our clinical practice. But we are seeing a profound change. This change which divides us from hypothesis-driven approach to observational research. Observational research typically has been considered not the best. But remember, there was a divide even in the 16th century when Isaac Newton spoke about looking into nature and understanding the observation and then deriving your hypothesis more powerful than tunnel single strain hypothesis, which you can completely mislead. And that's what is happening now, that AI probably allows us to understand the nature better, understand human disease and the complexities better, and allows us to evolve into far more nuanced way of looking into disease and physiological mechanisms. And the whole taxonomy of cardiology is going to change. How we understand disease is going to change. We need to embrace a high dimensional data-driven approach. We need to move away from our singular, simple decisions that are derived from thresholds which are univariable or single variable driven. We need to change from that to a high dimensionality to understand the complexity of the disease. And I believe this change is happening very quickly as is being projected in the journals. And this change is going to allow us, embracing this change is going to allow finally to be able to go in the direction that even national organizations are expecting us to do. We have to strategize and come together and embrace processes that will allow us to evolve. The evolution is imminent. The train has left the station. We have to catch on to this direction, and we need to all embrace toward this dimensionality that is evolving in the near future. Thank you very much once more. Again, this journey is credited to all people who have inspired me and continue to inspire me daily. All the work that has come on from my mentors, my people, my friends, they keep on moving me every day. And I think we just continue to evolve and grow each day. Thank you very much.
That was something which was very phenomenal. We are all amazed by the work which can be done using artificial intelligence, but there are certain things which I would like for my knowledge to understand. Is it that there will be some intra-observable variations also over here, or machine will take care of everything?
In fact, that's one of the best things. The intra-observe variability with machine learning is extremely low. In fact, if you give the same image, you or Shantanu would analyze it with different ways, but the computer algorithm will come with zero variability if it's the same image. So the variability is definitely reduced remarkably. So one thing is to reduce the variability, and the other thing is to think about the variability as a natural. Every physiological variable the variability has a meaning. One is the instrumentation variability, but you need to differentiate the noise and the instrumentation variability from the biological variability. Biological variability may have a lot of information and powerful. In fact, let's say heart rate variability, right? It's a powerful information. It can predict cardiac death. So we need to tease out the different types of variability. Variability sometimes is very noisy, not useful. On the other hand, it can be extremely powerful. So machine learning allows us to tease out some of these.
That's great. So artificial intelligence will come over very fast now, and soon will probably help us in knowing the clinical criteria of the patient, when they should go for surgery, when they should go for medical management, and what is the valve area of this patient, what is the strain of this patient, etc., etc. Are you sure?
So what I'm going to say right now is what is currently happening and is already happening. It's not like measurements are being taken over by AI completely.
Great.
Right? This is eminent. You do a clean image capture, it will take over the measurements. And the measurements that come out, and it's not me just, I think a lot of people here and I can see Luigi also, everybody's working on AI. And this is the measurements side, the things that, we do a lot of LVOT measurements, for example. So much of variability comes in. In LV volume, how do you segment properly? There's a lot of variability in echo measurements itself. So that will be taken care of by AI, so as to get a standardized measurements. You have an opportunity to overrule it. Right? You have an opportunity to overrule, but it will reduce your time and, to trace and track and calculate. That's there. Whether it's going to completely change our abilities to diagnose, that's not yet there. I mean, some of the FDA licensed product that we are currently seeing have already utilized automated measurements, automated calculations. This is already there. So I think what I'm saying that start embracing at least that direction for automation in echocardiographic acquisition and measurements. Whether it can go and predict out for you the disease states, that's an area that is still evolving. It is not yet completely mature, but there's a lot of promise and a lot of work being done in that direction.
So Partho, we have questions. Do you see a continuous ambulatory echo coming soon?
Continuous ambulatory echo will require you to, you can ask any question. These are all research questions. Currently, we don't have a device or a design where you can do an ambulatory echo. But let's say you develop change the transducer, you flatten it up, paste to the patient's wall, walk out with AI. I say, why not? You can do that. Those are the questions you can do now. I mean, you can form a company. If you have the engineers, you have the people, you can have these kind of products that can come out. Why is the transducer required to be always held in the hand? Why could you not have some kind of a sleeve that you wear and the transducer automatically finds all the views and windows? These kind of activities are going to happen. It's not there right now, but these kind of questions are going to happen.
So let me ask Luigi. I know he's also working on AI a lot. So there's a question. There are a lot of companies. All the companies have an automated LV function assessment, automated strain assessment. So do you suggest the echocardiographers or the delegates to embrace them if they have a good image, or do it manually? Which is better?
Well, at the moment, I am currently having all automated measurements of Doppler profiles, both pulsed and continuous. For example, 3D echo datasets, just the datasets that have a very good image quality. Otherwise, we still need to have some manual editing. There is a very nice work made by the group in Chicago using the heart model. That is one of the most advanced artificial intelligence on the market, showing that in consecutively routine patients, this is reliable in around 66% of the patients. So 2/3 of patients can be completely assessed without any manual intervention, with all the benefits that Parto listed. But still, the image quality is an issue, at least for the algorithms that are currently on the market.
So this question, I think Dr. J.C. Mohan can answer. In the present state, is AI cost effective in India?
I think the point is AI is being introduced in everything. Simple 12-lead ECG, which you are now interpreting, has a lot of artificial intelligence. It gives you width of PR, QRS interval, STT. It gives you diagnosis. It gives you possibilities. That is all artificial intelligence used, and there is hardly cost getting into. Are you paying more for that ECG? Even an ECG machine which is costing 30,000 rupees giving that information. Everything is there actually in there. Yeah. So we are already knowingly, unknowingly using more and more artificial intelligence. And as Luigi said, that for the HM model, we don't pay anything extra actually. The HM model is evolving. They have it, and life is getting easier actually. At least in 2/3 of the cases, Luigi said, the life is much easier. You get LA volume. You get LV volume, you get stroke volume, and for that matter, calculation of aortic valve area becomes easy. At least you have the stroke volume, you just need a VTI of you. So I think artificial intelligence is already there. It wouldn't be cost effective in any case. It is probably going to lower the cost because the time you spend on the machine will be much lower. So the machine can be used to do more cases, and you just require the data and then the machine analyzes it. I think it's going to be cost efficient and cost saving rather than cost expanding.
I think it's a very valid point, because the second question also is important. One of the delegates says that the medium version of echo machines are not provided with AI features and softwares, and if provided, the softwares become very costly. The reason I'm taking it up because a few of the vendors are online with us, and I don't know how to track it. Yeah, so the problem in this part of the country is a lot of people have a medium machine, and this automated softwares are expensive. That is about the concern. So I think we have the leaders here who are giving us insights about AI. Do you think this can be solved in any way?
Absolutely. There are so many echo companies that are coming with AI. So if they don't lower the cost, somebody else is going to take over the market.
That's good. That's good.
That's good.
Okay. There are at least 4 or 5 AI companies right now in US, and they are going to look into the market and they're going to capture it very soon, very quickly.
So they are taking up the echo market.
Yes, and not only the machines, but some of these tools are being made available as softwares. It's a question of time. Within a couple of months, few months after they learn about the softwares, they will be made available. And then, so this is actually, it's a competition. So it's a main market. I mean, I do not attest any single vendor. What I'm saying is, like, this is for the general good of the world, that we embrace and we lower down the costs and we give the best product.
Great.
You should not buy a product, a system which is not giving you the latest FDA version, period.
Perfect. So I think we can surely discuss a lot about it, but I think the main key which Partho and Luigi and Dr. Mohan, everybody told, is that to implement AI, you should have a good image quality. Unless and until you don't have a good image quality, things will not follow.
But I mean, wait for the image quality also, because there is a way, there are automated tools which will tell you, yes, this image quality is not good.
You showed
Don't
it.
apply AI. So don't worry about even that. There's tools that I cannot, I mean, those kind of things, automation is also available.
Already these software like the intelligent scanner, eye scan, is already telling you, you press it and you will get the best of the image. But I was just taken away by what Shantanu said. surprisingly, the vascular work with these radiologists do, they have more artificial intelligence than the diastolic dysfunction analysis we do.
Yeah.
I have seen is that when they do a renal Doppler, it gives you for 10 beats, it gives you systolic velocity, diastolic velocity, PI, resistance index in a jiffy. Can I get that diastolic function in a echo machine? Sure, I can get it. It shouldn't cost money. Why isn't anybody, not even in E95, you have this system that, look, I have taken 6 beats of the transmittal flow, and now it just traces it. It gives me everything it gives me. Everything, including IVRT, everything it gives me. And then it saves my time. I don't have to start measuring. And similarly, once I get the tissue Doppler, same way it gives me 5 beats. All 5 beats an average, all 5 beats an average, or all 6 beats. And because life becomes much simpler, like the radiologists are enjoying that work.
So one question, the strain value is dependent only on the machine. How can we confirm that the machine is giving the right value or not? Anybody can take it.
The strain value is
dependent only on the machine. How can we confirm that the machine is giving us the right value or not?
No, so I think and Luigi is here. Strain standardization softwares, some of the softwares, some of the companies have worked together in the strain standardization task force. And so ask for the latest software that has been standardized because that will be the one that you will ask to be used in clinical practice, number one. Number two, even if there is a standardization, I think the request would be to maybe when you follow up the patient on the same system so that inter-vendor variability can be reduced. But having said that, I think Luigi and others have already worked on standardizing a powerful metric, global longitudinal strain, which is now already in guidelines for routine application in clinical practice.
Great. Thank you so much, Partho, for an amazing lecture, and I think we have to stop here. Now, we have, I see Luigi joining, and I think we missed you at the first talk, but I can also see Marcelo ready with his talk. So what do you do?
I'm sorry, I was just busy in the clinic and I missed the point. Give Marcelo the priority.
Okay. Thank you so much, Luigi, for being with us. Marcelo, can you unmute?
Hi.
Hi. Are you ready with your presentation? So maybe.
Thank you so much, Luigi.
Yeah. So after Marcelo, I think Luigi can.
Tutto bene a Milano?
So Marcelo goes for endocarditis, infective and non-infective. Yeah. Thank you.
And also, Partho, congratulations on a wonderful presentation. This is fantastic always to hear from you. Yeah, you are always fostering technology, learning, going to the advance of the humankind. Fantastic, Partho. That is absolutely great. In this presentation, I believe that we're going to jump back to the past, not to the future. Is it okay, Shantanu?
Yeah, it's all good.
Can you see my screen?
Can you see my screen?
Yes. Yes.
The screen is visible, Marcelo.
Is it okay?
All right.
Okay. All right. So, can I begin?
Yeah.
Yeah. All right. So we're going to talk a little bit on non-infectious endocarditis. And also just a little bit on infectious endocarditis. Just beginning from a case from a 25-year-old man from central Brazil. He presented dyspnea on accession orthopnea, paroxysmal nocturnal dyspnea, and he had some sort of that 4 years ago, and it worsened in the last 9 months. He presented repetitive episodes of pulmonary thromboembolism, pulmonary hypertension, induced by recurrent chronic pulmonary emboli. So he presented pulmonary artery systolic pressure over 100 millimeters mercury. He presented also, very importantly, a positive cardiolipin antibodies and lupus anticoagulant. So he presented at last antiphospholipid syndrome and he went to a pulmonary thromboendarterectomy. In here, we can appreciate the pictures. Let's see. Yeah, it's running. So we can observe, we can depict, Luigi, a huge mass attached to the aortic leaflets, and we can beautifully observe here. It's running quite well. Didn't seem to present aortic stenosis. We can observe from different planes, from different views, from 2D, from an en-face view as well, as from a longitudinal view from the LV outflow tract. And also you could observe that there was not aortic regurgitation. This is very interesting. From the 3D, once again, the thickness and a mass attached to the aortic leaflets. We can beautifully observe from an en-face view. The leaflets could very easily open, and there was also a lead of a pacemaker in the superior vena cava, and also from the surgical view, we can also observe that it was a huge mass all around the aortic leaflets. He went through a surgical procedure, and we can observe here the surgical finding, the aortic opening, and the surgeon was taking some sort of mass. And from the microscopy, we can observe that was a huge mass attached to the aortic leaflets, as well as a huge thrombus on the pulmonary artery. So the histopathology of the mass disclosed the fibrin, just fibrin, and the histochemical for bacteria and fungi was negative. This is from the hematoxylin eosin stain and trichomic acid masson stain as well, beautifully demonstrated in blue at the right. Whenever coming back to the histology of the mass, it just disclosed fibrin and granulocytes, neutrophils, and the histochemical for bacteria and fungi was negative, absolutely negative. So coming back a little bit in history, part 2, we can see that in 1865, a very important guy, Armand Rousseau, first characterized the association of thrombotic events in malignancy. See, we are in 19th century. In 1888, Ziegler identified the vegetations in the cardiac valves. But at that time, they were associated with chronic inflammatory states, many different inflammatory states. But in 1920, Emanuel Lieberman, this is historic, this is very important, recognized a subset of endocarditis, which he could not characterize accordingly or according to the available classification. At that time, you can see you had so many different classifications over time, over the decades, the following decades, due to the lack of an apparent cause. 4 years later, Luigi, 1924, Emanuel Lieberman and Benjamin Sachs, this is very important, published just 4 cases. Can we believe today, just 4 cases? It was not a cluster of cases, just 4 cases of a peculiar valvular and myocardial vegetation lesion at Mount Sinai Hospital in New York, which was examined clinically and during the post-mortem examination, and proved to be free, absolutely free from the demonstrable microorganisms that were first designed as atypical verrucous endocarditis. We're talking about 1924, the 30s. At that time, Lieberman and Sachs included this kind of endocarditis in the group of undeterminate endocarditis, which was at that time also included the so-called terminal or cachetic endocarditis, the so-called Lieberman-Sachs endocarditis. And you see it was originally described as valvular mass, almost like mulberry-like clusters of a verrucle, mostly involving the mitral and the aortic valves, accompanied by leaflet thickening and valvular dysfunction, most frequently stenosis, very rarely insufficiency. And this entity was later named Marentic, from the Greek. Can we just believe from Greece, from the Greek marantikos, which means no more than wasting time due to the wasting state of most of the patients. Most of the patients died. In 1936, Gross and Friedberg named the lesion non-bacterial thrombotic endocarditis, NBTE. But you see, however, considering the negative results in the pursuit of all infective agents, pathogens, the lesion is more appropriately named non-infectious and not non-bacterial thrombotic endocarditis. This is very interesting because since the first descriptions, NBT has been associated with many, many different diagnoses, almost like as malignancy, chronic inflammatory states, infectious disease, many different infectious disease, and autoimmune disorders, many different immune disorders, more frequently to sepsis, what is not uncommon, and to burns. This entity has been reported in a very wide range of age, with no sex predominancy. It involves any cardiac valves, but predominates in the aortic valve, followed by the mitral valve. Those vegetations generally are found in previously healthy valves and vary in size from microscopy to very large. We can detach and cause distant infections. This is very interesting. And very interestingly, they occur characteristically in the coaptation edge of the leaflets and are constituted by degenerating platelets intermingled with fibrin, most of them with fibrin and platelets. And the local inflammatory response is flexible, which can explain the high frequency, almost like average 42% of detachment and embolization. Here we have a second case, a patient with 6-year-old woman, was a woman hospitalized due to marked asthenia, dyspnea, edema, and jaundice. She had a past medical history of hypertension and hypothyroidism. And recently, she had been diagnosed with a combined lesion of the aortic valve, predominantly stenosis, not insufficient, and heart failure. From her echo, TT echo, we just observed concentric ventricular hypertrophy and a mobile and filamentary vegetation attached to the atrial surface of the mitral valve, measuring almost like 15 to 10 millimeters. The patient was screened for viral hepatitis and autoantibodies, which resulted in a positive antinuclear antibody titer 1/320 speckled pattern with this sort of pattern. So the patient was referred to a tertiary cardiology center with a working diagnosis of infective endocarditis in the suspicions of infective endocarditis, but the blood cultures were repeatedly negative. And the outcome was unfavorable with worsening of his respiratory function, and then she died some days after. And we can beautifully see the pathology of the aortic valve. Just can see this is a gross view of the 3-leaflet aortic valve, showing no more than calcified aortic stenosis and vegetation, which measures 9 to 6 millimeters. And the vegetation was attached to the ventricular surface of one of the aortic cusps. We can observe that calcium nodules were recovered by lipid deposits projecting outwards to the aortic surface in the thickness aortic leaflets. This is a combination perhaps in between aortic stenosis and atherosclerosis. This is very common. And the histopathology of the vegetation disclosed fibrin with no inflammatory cells, and the histochemical search for bacteria and fungi was absolutely negative. Very interesting. And the autopsy of this patient showed an extensive venous thrombosis of the right iliac vein. It was followed by great vessel pulmonary embolism with extensive infraction areas, most possibly the cause of death. And the authors infer the possibility of a thrombophilia associated with an indeterminate autoimmune disease, which could explain the thrombotic phenomena and the presence of NBTE. Once again, autoimmune disease associated with thrombotic events, what is very, very possible in such sort of situation. It is possible that the mitral valve vegetation that was detected on the TT detached by the time of the autopsy was done, it could not be found. This is very interesting. We can have all together some autoimmune disorders with the thrombotic events with autoantibody situations. This is very interesting. Another case is the third case we have in here, a 30-year-old Brazilian woman with the diagnosis of systemic lupus erythematosus, malar rash, photosensibility, polyarthritis, lower limb palpable purpura, and 3 pregnancies. This is very important also as well. The combination in between autoimmune disorders, thrombotic events, and some events like pregnancy. And the second, she presented preeclampsia and premature birth on the 30th week of the gestation. And the third, that was a miscarriage. So from the lab, she presented decreased C3 fraction of the complement, proteinuria, antinuclear antibodies were also positive. So she presented lupus, problems during the pregnancies, miscarriage, antinuclear antibodies, and a positive anticardiolipin antibodies. This is very important. The histological assessment of the purpuric lesions disclosed leukocytoclastic vasculitis, what is very important concerning systemic lupus erythematosus. And we can observe here from the arteriography, there was a occlusion of her right lower limb, popliteal occlusion, what is very important. So this association between antibodies, immunodisorders, thrombotic events, all together. This is very important. So we can know by history and also by literature that Liebman-Sachs endocarditis may be considered as a form of non-bacterial endocarditis, can be observed and associated with systemic lupus erythematosus. It is one of the most common heart-related manifestations of lupus. Naturally, that the most common is pericarditis. Mitral valve is typically affected and the vegetation occurs on the ventricular and atrial surface of the valve. The vegetations can be small and formed just from the strands of fibrin, neutrophils, lymphocytes, and histiocytes. Liebman-Sachs rarely produce significant valve dysfunction, and the lesions may for sure embolize quite a lot. So this association between the Liebman-Sachs endocarditis for 1924, first description, and a higher risk for embolic cerebral disease in people with systemic lupus erythematosus is not rare. So from the pathology in lupus, it is almost the same as non-bacterial thrombotic endocarditis, with exception for the focal necrosis with hematoxylin bodies that can be found in just lupus endocarditis. This is very important. As we can remember from the histology, the hematoxylin body is a dense, homogeneous basophilic particle, stainable with hematoxylin, and it can just represent degraded nuclear material for injured cells, along with autoantibodies and a limited amount of cytoplasms. Hematoxylin body occurs in lupus erythematosus systemic. It is just called LE body. And whenever it's extracellular, it can be ingested by leukocytes, whenever it's going to be known as LE cells. We can just picture here from this chart, from this picture, and hematoxylin body with in purple. Also, what is very important that this association between Liebman-Sachs endocarditis and alpha-phospholipid syndrome was first noted in 1985. So during history, we're coming from 1924, 1936, and now 1985. And this antiphospholipid syndrome is an autoimmune, hypercoagulable state caused by antiphospholipid antibodies, and it provokes naturally blood clots, thrombosis, and both arteries and veins, as well as pregnancy-related complications such as miscarriage, stillbirth, preterm delivery, and severe preeclampsia. They are all together. And the diagnosis criteria is very interesting because it's based on clinics as well as on lab tests. It is based on the evidence of one clinical event, for instance, thrombosis or a complication following pregnancy, and 2 autoantibody blood tests spaced at least 3 months apart, but could confirm the presence of either lupus anticoagulant or anti-beta-2 glycoprotein I. As we can see, they are a subset of endocardolipin antibodies. So they are just together. How it is important to follow time, many decades, to understand what is in depth concerning the disease. But coming back a little bit more in past, Luigi, a little bit more, 1,000 years ago, we're just coming back to a desert, Atacama Desert in Peru and Chile, almost like 1,000 years before the coming of Christ. We can have some from the histological examinations of species of some mummies, we can see some findings connected to endocarditis. So this is very interesting because non-infective endocarditis diagnosis 1924. In reports or findings connected to endocarditis almost like 1,000 years before. The mummies from South America. And we can see almost like infections endocarditis, you can see the same mass, the same vegetations as described by Jean Coursat in the century 18th, almost like the syphilitic lesions. And also the first description from Echo, from Dillon in 1974, you can have most beautiful from 3T echo, even from TT, some sort of destruction of the tricuspid valve, as well as this, almost like the destruction of the mitral valve. And this is so important to have so many different presentations for infective endocarditis, almost like abscess, and from TT to D and to TT, 3D, as well as from atrial field, and also some very interesting concordance in between TE, 3D, and for instance, in this prosthetic valve partial dehiscence. And we can just most beautiful observe from the 2D TE, from the 3D TE, and the surgical finding. Really, the 3D TE is really, really important for the surgical procedures today, and also for the hybrid presentation in the hemodynamic. And if coming back to what we have in endocarditis, you can most beautifully see the observation, the endocarditis lesions in the aortic valves as observed here from the pathology service of my hospital in Brazil. And you have so many different problems concerning embolization and also formation of different problems in during the endocarditis and infective endocarditis process, like as in this here, that it was a patient was presented and mitral valve aneurysm secondary to the aortic valve endocarditis. It was treated conservatively, and he observe here that was performed a valvuloplasty. It was taking the lesion, and then a conservative surgical treatment was undertaken by Professor Pablo Pomerantsev from our team. And also, we do strong believe that TEE, the repetition of TEE, can add most beautifully most of the important diagnostic issues that we can follow and we can try to find during the endocarditis process. We can absolutely to repeat that. And also this combination of non-infective thrombotic events, embolic events, we can just most beautifully observe the same thing, absolutely the same thing, or even worse positions following the infective endocarditis, as we had here in this patient, that it was a 59-year-old woman. She presented a mitral valve prolapse and a history of endoarthrosis lumbosacral and hematuria. And she presented endocarditis by streptococcus viridans and presented a left kidney embolism a spleen embolism, and iliac artery occlusion, as well as cerebral bleeding. See, this is very important to make a short division in between non-infective to infective endocarditis. And also, whenever we have the same thing, we have, for instance, endocarditis in patients who present also lupus erythematosus systemic as well. So this is very interesting because we can have the same clinical presentation. Even sometimes we can have negative blood cultures, but in fact, it is due to infective endocarditis and not to non-infections endocarditis. It's a case of a patient with the lupus erythematosus systemic, and in this case, there was endocarditis by Streptococcus gallolyticus, which is not uncommon, it's very common. And we had a perforation of the aortic valve, as well as the perforation, almost like the destruction of the mitral valve, as observed from the surgical view. Also, we can have some complications, very interesting, observed following infections endocarditis, as you can have here. Patient presented a prosthetic valve, bioprosthetic valves, and there was a new cavity, a perivalvular new cavity with flow coming through this cavity. And we can observe in here, let's see if it's running. The 3D is not running. Okay, we present the same thing by 3D TE. And also today you have to have some attention to the different device that we're going to deal with concerning the possibility of infectious endocarditis. This is a closure of the left atrial appendage, and we're going to implant different devices, and also we have to be very aware of the possible presence of infective endocarditis. And today, naturally, that we're going to use a multimodality approach to investigate at last the possibility of infectious endocarditis. And we're going to use for sure the PET scan and for the investigation of this. And we're going to have some different areas of high glucose uptake, but we are going to show later how importantly we have to be very aware of the results. And this is very interesting because, as you know, Luigi, this is a very important paper concerning groups from Europe and groups from outside Europe, almost like 40 patients. The chairman is Professor Gilbert Rabi de Marseille, and it is very interesting because we had some important information from Europe and from outside Europe. We have 27 patients involved in this paper, 27 countries from Europe and 13 from outside Europe. We have some patients from Canada, US, Brazil, Argentina, Egypt, India, Pakistan, Japan, Egypt, elsewhere. And this is a very important group trying to study what is going on today on the world of infective endocarditis. It was a study in which were enrolled more than 3,000 patients. They were from 13 centers from outside Europe and 27 countries from Europe. So we had in here we had 3,116 patients, 646 from outside Europe. And this is very interesting because a paper is being written today that we're going to compare what we have in data in patients from Europe comparing to patients from outside Europe. This is very important to understand today how is this so old disease, but we have so many different issues today. As we can see, for instance, the most common microorganisms today are closer to staphylococci in more than 40% of the patients. Can you just believe that? It's not streptococci anymore, it's just staphylococci. And they use, for instance, the PETI the 18F, fluorodesoxyglucose, PET was performed in almost like 17% of the patients. And the sensitivity for prosthetic valve endocarditis was almost like 67%. But for non-native valve endocarditis, just 28. And for device related to endocarditis, just 16%. So we have to keep those numbers in mind to make the right consideration, right? For prosthetic valve endocarditis, 67%. For native endocarditis, 28%. And for device-related endocarditis, 16%. And also, just can you believe that embolic events occurred in almost like 21% of the patients? If you are coming back a little bit to non-infectious endocarditis, it is so common to have embolic events, but also in infective endocarditis, just 21%. And negative endocarditis, we had in almost like 21% of the patients, 21% of the patients. Even with all technology concerning the trying to find out the most fastidious agents, and also trying to find out, for instance, Coxiella burnet that we had in this court, less than 1% of the patients. So this is very important to have in mind the embolic events, 21%, and the negative endocarditis, almost like 21%. This is absolutely important. And also the predictors of mortality, as we had renal insufficiency, creatinine over 10 milligrams per deciliter, heart failure, the length of the vegetation. This was so controversial. We have come forward and back concerning the length of the vegetation. This is important. This is not important during decades, but in this cohort, the length of the vegetation over than 10 millimeters was really important. Cerebral complication, abscess, and failure to undertake surgery when indicated. So we have many, many important data from this very important collaborative study, which we have as chairman, Professor Gilbert Habib. So take into consideration some words from William Osler, from his so classic custodian lectures from very, very, very below and past. He once said that I have loved no darkness, sophisticated no truth, nursed no delusion, and allowed no fear, concerning the need to go for the understanding of difficult situations. I do strongly believe that we have to do the same thing today concerning the coronavirus pandemic, absolutely the same thing. We have to grab different efforts from different continents just to foster goodwill, just to foster brotherhood in between the different parts from different continents of the world. Thank you so much. Back to you, Shantanu.
Marcelo, excellent talk about both infective and non-infective endocarditis. A question, can we differentiate Liebman-Sachs endocarditis from an infective endocarditis on an echo?
It is absolutely difficult, but you can see whenever we don't have, for instance, insufficiency in the valve, we can just guess. But you see, the clinical features are absolutely important. For an infectious endocarditis and non-infectious endocarditis, the clinical features and the clinical environment is absolutely impossible to be a part of the echo findings. And I do strongly believe that for any disease, isn't that? I think that the findings from echo, from the multimodality findings, from different techniques, we can just have to be together the clinical features.
So, Dr. Jason,
clinical features.
Yeah, sorry, go ahead.
For any disease, I think that is absolutely important because you see, from our roots, we are cardiologists. So we have to have in our soul, in our mind, ever ever the clinical features and the clinical yield or the clinical possibility of this or that disease. This is impossible to be a part of TECO or any technique out of that.
Yeah, so Dr. Mohan, this European paper of the whole, which included the whole part of the world, showed that staph was the main organism. You have had experience of infected endocarditis like last 40 years. Do you think there is a change in the pattern in India?
So I completely agree with the findings of Euroendo group. I actually 3 years back did a meta-analysis of all the studies published from India in last 10 years of infective endocarditis, and published that paper in API textbook of medicine. It was 2017. The dominant organism was Staphylococcus, and it accounted for exactly this number, 37%. Actually, we are 37%, followed by Streptococci, which were in mid-20s, and then of course other organisms. But keep in mind one thing: the meta-analysis of all the studies published in last 10 years were the same. We had culture positivity not exceeding 50%, median culture positivity at 50%. That is our major issue. And staph was the dominant organism. That is also true. And the other thing is, we still continue to have mortality, which was average of about 20%. So these are some of the things I remember from that paper I wrote 3 years back. And yes, staph is the commonest organism now.
Right.
Any predictors?
Professor Mohan.
Yeah.
No, go ahead.
No, you can go.
Professor Mohan, what do you think is the leading cause for such mortality concerning infective endocarditis?
So what we are seeing is patients are being treated with antibiotics empirically. They get some relief. The disease goes on, it destroys the tissues, produces septicemia and multi-organ dysfunction. Now, unlike in Western world, where probably with the first onset of fever and some rigors and chills, you would like to draw blood cultures, take samples, and try to reach a diagnosis. In my country, at least, most of the time, empiric antibiotic therapy is the commonest thing. That is why acute disease becomes subacute. It keeps destroying the tissue. It keeps actually the vegetations keep becoming bigger, and you have more of this problem. That is my feeling.
And any predictors of bad outcome? For example, thromboembolism, or for that matter, mortality also?
No, the bad outcome actually are the common. One, of course, is that people who have prosthetic valve endocarditis have a bad outcome. People who have actually hemodialysis, repeated hemodialysis, and have infective endocarditis, they actually have bad outcome. Fungus and staph has bad outcome compared to Streptococcus. People with larger vegetations have more embolization and bad outcome in general. People who have multiple embolization, more than one, especially to spleen, liver, and kidney, have more mortality. So one could actually think of these things in multiple different ways. But people who have actually abscesses and are fistula formation, are treated conservatively, they have a very high mortality.
Great. Thank you, Okay. Yeah.
And also, perhaps, Professor Mohan, we're going to face another word for infective endocarditis concerning the new procedures from hemodynamic. Isn't that because we're going to have so many different new procedures that we're going to face out, for instance, patients from TAVR, patients from closure, different devices, mitral clip, etc., tricuspid clip, etc. So we're going to have a new position, a new word from the following years, following these new techniques that we're going to face most daily.
Yeah, I agree with you. And also, I think the first part of your talk was extremely interesting, the so-called NBTE. Now we are recognizing it more and more. We are recognizing more and more. we don't have to treat the valve, but we have to actually anticoagulate these people more often. And of course, primary antiphospholipid syndrome usually comes to us with a bad obstetric history or history of pulmonary thromboembolism, or these people are sent to us by a murmur because mitral valve gets involved. The secondary antiphospholipid syndrome, which is actually secondary to lupus, Sorin syndrome, rheumatoid arthritis, also we are seeing a lot. The current data from India suggests that combined Sorin syndrome and rheumatoid arthritis, 1% of the entire population. And a good number of these people actually later on present to us with secondary antiphospholipid antibody syndrome. And we are now getting more and more aware of this phenomenon. We are not seeing that much in malignancy, but in other diseases we are seeing. So thank you very much for bringing that to our notice. We have presented such data actually in our previous meetings, and we will be more careful in future in looking at these things.
Thank you, Dr. Marcelo. So I think we can request Dr. Luigi to share his slides on functional TR. He's going to give us new insights about the pathophysiology. A very important entity should not be neglected. Luigi.
As you said, I'm trying to share with you what we have learned all this year looking at the pathophysiology of functional tricuspid regurgitation. And I would start from a clinical dilemma. Differently from all the other valves, aorta, mitral, or pulmonic, we have an entity that is a so-called isolated tricuspid regurgitation. That means a tricuspid regurgitation with no apparent cause. That is quite uncommon because we don't have any isolated mitral regurgitation or mitral stenosis, aortic regurgitation, or aortic stenosis. And when we puzzled about this entity, we were really worried because despite it's isolated, so that means that there is no apparent cause. It is quite frequent because its prevalence is around 22% and is an independent predictor of mortality and morbidity, as you can see in this seminal paper by Jan Topisky and co-workers. Another issue is that looking at the current concepts about the pathophysiology of functional tricuspid regurgitation that have been nicely summarized by Gilles Dreyfus in this review in 2015, you see that he divided in two main causes. So the first one are the left-sided heart diseases that create an increase of right ventricular afterload with a consequent right ventricular remodeling, and then it brings to tricuspid annular dilation and eventually leaflet tethering, creating the tricuspid regurgitation. What is interesting that also atrial fibrillation in some way, but it's not been written in this paper, there is an alteration of right ventricular function that at the end brings the same annular dilation and tethering. And also, when we look at the most recent guidelines, these are the joint European Society of Cardiology, European Society of Thoracic Surgery guidelines for management of valvular heart disease. And when we look at the etiology of tricuspid regurgitation, you see that they say pathological tricuspid regurgitation is more often secondary to right ventricular dysfunction following pressure volume overload in presence of structurally normal leaflets. So it seems that the right ventricular is the main playmaker in this etiology of tricuspid regurgitation. However, when we look at our patients, we have a completely different perception. I will present two brief cases showing you directly the point. This is a 61-year-old woman. He has a thyrotoxicosis due to Graves' disease, and she has no cardiac history, but she starts to complain because of heart failure, and at the ECG, rapid atrial fibrillation was detected. Due to the symptoms of heart failure, the patient undergoes an echocardiography, and as you see here, you have the main pictures starting on the left, dilation of the right atrium. There is no coaptation of the tricuspid leaflets, as you see here, with the large gap over here that you can better appreciate in this zoom image. And I don't need to make any quantitation to decide that this is a severe, if not a torrential, tricuspid regurgitation. The patient undergoes thyroidectomy due to this main disease, and after 1 month after the cardiological follow-up, the ECG records a spontaneous conversion and maintenance of a sinus rhythm, and the symptoms of heart failure were completely disappeared. And what you can see when you repeat the echo is that it seems the echo of a completely different person. There is not anymore any lack of coaptation, but there is quite a good coaptation of the tricuspid leaflets, and the torrential tricuspid regurgitation spontaneously became quite mild. When we compare the findings of these two echoes that have been recorded just 3 months apart, you see that there was no major change in the size of the right ventricle, just an improvement of right ventricular function due to recovery of the sinus rhythm. There was no major change in pulmonary pressure. What is striking is the volume of the right atrium that was almost halved by the spontaneous recovery of the sinus rhythm, followed by a very significant shrinking of the tricuspid annulus, and of course the reduction of the vena contracta of the regurgitation. You may object that this is a very peculiar etiology of acute atrial fibrillation, but I can show that also in most conventional cases we can see the same. Here is the case of a 74-year-old woman with no cardiovascular risk factors. She had the first episode of persistent atrial fibrillation that was treated with drugs, but then there was a recurrence of the atrial fibrillation. The patients complained from palpitations and dyspnea on effort. So she came on the emergency room for the pharmacological cardioversion to sinus rhythm. The day after the cardioversion, the patient underwent echo, and these were the findings. Once again, we have an enlarged right atrium and a large gap between the tricuspid leaflets on the left side image. And once again, the color tells you all the story that this is a very severe tricuspid regurgitation, also documented by the reversal flow in the suprahepatic veins, as you can see. This was April 2018, and the patient was considered for surgery, but as you can see, there are thickening of the tricuspid leaflets, so the surgeon wanted to have excluded any hints of carcinoid disease before undergoing surgery. The patient underwent, of course, a complete 3D echocardiography. You can see here very nicely the regurgitant orifice that is huge in the view from the ventricular view, and we can make also planimetry of that, documenting an 0.8 centimeter square, confirming the color Doppler echo. And then the patient also, we made a quantitation of the right ventricle with the normal volumes, normal function. That is also documented by the strain of the free wall that is almost supernormal. What was striking once again was a huge volume of the right atrium that was 74 milliliters a meter square. Current technology allows also a quantitation of the tricuspid annulus. That is a new software that we have available that perform a semi-automatic quantitation. And so we can define an enlargement of a tricuspid annulus area that is 10.1 centimeters square, and also an enlargement of both the maximal diameters and the so-called four-chamber diameter. During the follow-up, the patient was a little bit lost while taking all of these exams to exclude the carcinoid, but 1 year after, she came back for an echo, and once again, there was a spontaneous reduction of the atrium and the annulus, as well of the severity of the regurgitation. And repeating again the comparison between the two echo studies, this time everything was measured with the 3D, you see that there was not a big change in the right ventricular volume. That was normal at the presentation and remained normal. A usual improvement in the ejection fraction with the sinus rhythm, the strain persisted normal, no major change in the pulmonary systolic pressure. But once again, the right atrium that was almost halved and followed by a significant reduction in tricuspid annulus area and in the diameter. And so we developed a different opinion about the pathophysiology of functional tricuspid regurgitation, and saying that there is a so-called atriogenic functional tricuspid regurgitation, where the major player is not the ventricle, that doesn't change significantly its size in the early phases, but it's the main player is the right atrium. The dilation of the right atrium creates the dilation of the tricuspid annulus, the reduction of the tricuspid annulus sphincteric contraction that leads to imbalance between the tricuspid annulus area and the leaflet area with the central regurgitation that you can see here. These are data that we have just published in CASE and in JACC cardiovascular imaging. And to follow this idea, we also made a very extensive study using current 3D technology to quantitate the left ventricle, the right atrium, and the annulus, and to elucidate this mechanism. Quite a large study population, almost 400 patients with every kind of functional tricuspid regurgitation, secondary to left heart disease, secondary to pulmonary hypertension, secondary to severe pulmonary regurgitation in tetralogy of low patients, and of course, secondary to atrial fibrillation. And what we found that confirmed our findings is that the tricuspid annulus area is more closely related to the volume of the right atrium than to the volume of the right ventricle. And this is true. We can skip this to go to this graph that shows the zeta score of the various parameters: tricuspid valvus annulus area, tenting volume, maximal volume of the right atrium, and the diastolic volume of the right ventricle. The blue columns are patients with atrial fibrillation. The orange one, patients with tricuspid regurgitation secondary to left heart disease. The gray one, patient with pulmonary hypertension. And the yellow one, patients with the tetralogy of Fallot. And as you can see, The largest tricuspid annulus area is of a patient with atrial fibrillation who actually have the largest atrium but don't have an enlarged right ventricle. Patients with an enlarged right ventricle, like pulmonary hypertension or tetralogy of Fallot, indeed have a very small or relatively small atrium, and there is almost a mild enlargement of tricuspid annulus area, and the main mechanism there is the tethering of the leaflet showed by the increase of the tenting volume. And so this is the graphic explanation of that, starting from normal, with the normal right ventricle, normal annulus, and the normal right atrium. You have a different scale in looking at the right ventricle. The tetralogy of Fallot have the largest ventricle, but also the smallest right atrial volume, so they have a smaller annulus. Look at the atrial fibrillation, that they have quite a small ventricle, but they have the largest atrium, and so they have the largest annulus. And the reason why is the right atrium that is the main, the driving force for the dilation of the annulus stays into the anatomy, as shown by this anatomical specimen from our pathologist, showing that in the muscle fibers that enters the tricuspid annulus are those of the atrium, but not those of the ventricle, as you show here. And so here you can easily understand why the tricuspid annulus follows more the atrium than not the ventricle. These our data were also confirmed by previous paper by the group in Los Angeles, Futsunomiya and co-workers, that showed that patients with the largest annular area in the mid-systole and those with the lowest annular contraction are patients with atrial fibrillation, and compared with the patients with tricuspid regurgitation that is secondary to left heart disease. So, coming back to the clinical dilemma from which we have started, this is also a combining hypothesis, because if you look at the data, you see the percentage of a patient with atrial fibrillation in this cohort of patients with isolated tricuspid regurgitation. So we also, more recent paper by Topilsky and co-worker, highlighting the fact that the atrial fibrillation is highly prevalent in all types of functional tricuspid regurgitation, up to 70%. And in atrial fibrillation, the right atrium and tricuspid annulus seems to enlarge more easily than the left atrium. And also the role of the atrial fibrillation that can start the functional tricuspid regurgitation. Functional tricuspid regurgitation dilates more the atrium and then creates more atrial fibrillation. So this is the unifying hypothesis where we made two main mechanisms leading to functional tricuspid regurgitation compared to the normal. We have the so-called atherogenic functional tricuspid regurgitation, where the mechanism is more annular dilation with no or very small tethering of the leaflet, and the so-called ventricular functional tricuspid regurgitation, where there is not so much annular dilation, but the displacement and the repositioning of the papillary muscles secondary to right ventricular remodeling creates the tricuspid regurgitation. And these are nice examples on a recent review published by Denisa Muraro, showing the main features of the atrial functional tricuspid regurgitation and the ventricular functional tricuspid regurgitation that then have been summarized in this table that you can find in the Journal American Society of Echo of last January. So we end up with a quite more comprehensive algorithm of the pathophysiology of tricuspid regurgitation, where there is one side in which there is a volume overload or pressure overload that created the right ventricular dilation and dysfunction. This creates more tricuspid leaflet tethering that drive into functional tricuspid regurgitation. But also we have all kinds of diseases that creates more an increase in the left atrial pressure, left atrial size, and even lone atrial fibrillation that acts mainly on the size of the right atrium. In those patients, is the tricuspid annulus dilation the starter of the functional tricuspid regurgitation. It's obvious that in more advanced stages, the two pathophysiological mechanisms can merge. This is my conclusion. So now we should be aware that the right atrial volume and function is a previously unrecognized main determinant of tricuspid annulus size. Atrial fibrillation and right atrial dilation are highly prevalent causes of tricuspid regurgitation in a patient with otherwise normal right ventricle and tricuspid valve. And the fact that the population is becoming older and older, and the atrial fibrillation increases its incidence with the aging may explain also the observed increased prevalence of so-called isolated tricuspid regurgitation with age. And these have also clinical implication because we should aim more to restore the sinus rhythm more than just rate control to reduce the burden of functional tricuspid regurgitation in the early population. Thank you very much, Shantanu, for this opportunity to contribute to ECHO Nagpur.
Thank you, Luigi. Amazing concept about the functional TR pathophysiology. So we have a couple of comments. So we were taught that the tricuspid valve apparatus is a part of the ventricle, right ventricle. So this is a game changer. You showed a pathological specimen. Do you say that the tricuspid annulus is a part of the atrium now?
Yes, I don't know if it is a part of the ventricle of the atrium. What we know is that the muscle fibers are entering in the tricuspid annulus are those of the atrium. And in those patients who have no ventricular disease, the size of the tricuspid annulus, as you have seen also by the two cases I have presented with you, is clearly related with the remodeling of the right atrium, and there's nothing to do with the remodeling of the right ventricle. It seems that the remodeling of the right ventricle is more acting on the position and the orientation of the papillary muscle, creating a tethering of the tricuspid leaflets.
Do you remember, Dr. Mohan, I had presented one case of thyrotoxicosis presenting with atrial fibrillation with tricuspid regurgitation, functional tricuspid regurgitation, but that patient had RV dysfunction with TAPSE and RVS prime going down. And so what is your experience with when the RV becomes dysfunction and there is no, what happens with the reversibility if we control the rate?
Yes, that's a problem, because when the right ventricle becomes dysfunctioning, then you have the realignment of the papillary muscles, and so the tethering is entering into the mechanism of a functional tricuspid regurgitation. So not always just recovering the sinus rhythm provide enough remodeling of the atrium to reduce the tricuspid regurgitation at that extent. But we have a lot of questions still, because not all patients remodel more the right ventricle, the right atrium than the left. Some remodel more the left than the right, and we don't know why. And not all the patients who remodel the right atrium and have the tricuspid regurgitation, when you recover the sinus rhythm, the tricuspid regurgitation comes back. So we have just at the start of understanding this mechanism, and you know that we have designed this international study about tricuspid regurgitation because we wanted to collect more patients, the experience of the different centers around the world to better understand the exact mechanism of the occurrence and recovery of tricuspid regurgitation in atrial fibrillation.
Dr. Mohan, your thoughts?
No, I'm amazed by thinking of Luigi Badano and his work. We have seen this thing, as you rightly pointed out. We have seen isolated atrial fibrillation, so-called lone AF or thyrotoxic AF, predominantly affecting the right atrium and size going up and tricuspid regurgitation occurring. And we just said that the AF effect, the thyrotoxic AF affects the right side more than the left, and we moved forward. Luigi has actually looked at the problem. For some unexplained reasons, atrial fibrillation affects the tricuspid annulus and right atrium more, and that is why isolated functional tricuspid regurgitation. We have known it for quite some time. We never put that observation to test or do any proper scientific structured research. And now we have good amount of data, and we understand the difference between atriogenic tricuspid regurgitation and ventriculogenic tricuspid regurgitation. Thank you, Luigi, for actually enlightening us. I am actually amazed that such a simple concept, it has taken such a long time to come to some kind of conclusion. I mean, we have been seeing atrial fibrillation for ages, in fact.
Thank you. We appreciate your words, really. I have to say that there is a big advantage of using 3D echo because this provides you really the sizing of the right ventricle and the right atrium that we were missing with the conventional echocardiography.
Will it not apply same thing to the left-sided LA dilatation, more observed in patients of mitral stenosis, or for that matter, atrial fibrillation being more common in mitral stenosis than in mitral regurgitation?
Yes, this is a common belief. Unfortunately, I don't have a direct experience because we don't have such a lot of rheumatic diseases. I have seen a lot when I was at the medical school, but nowadays we don't have. So I don't have an experience in comparing mitral stenosis and mitral regurgitation. What I can say is that with looking at the tricuspid regurgitation, mitral stenosis usually acts creating a pulmonary hypertension. And so once again, you have a more ventriculogenic tricuspid regurgitation than not atriogenic tricuspid regurgitation.
Great, Luigi. Thank you so much. Amazing concept. We'll start looking at it more often. Thank you so much.
Great.
Welcome. Thank you.
So if I can request Dr. J.C. Mohan to share his slide. He's going to be speaking on exotic adult congenital heart disease, diagnostic and therapeutic pitfalls. Yes, we can see your slides.
Thank you, Shantanu. Thank you, Mahesh, for inviting me to Echo Nagpur, this virtual experience. I normally don't talk much about adult congenital heart disease, and I'm pretty sure for people like Luigi or Marcelo that may not be a very, very popular thing. But has 400 cardiologists, of which only 25 deal with congenital heart disease. So we have a cardiologist for every 50,000 individuals, but when it comes to a pediatric cardiologist, that number is 1:17. So the lot of echoes have to be done by adult cardiology specialists, and they make all kind of mistakes. And my idea of this 20 minutes discussion is that we should be little more systematic, more organized in dealing with patients who come to us with congenital heart disease, especially the adults. So I will present you two 30-year female adults who presented with exertional dyspnea. Let me show you the case number 1, and that is a fallacy. That is the issue. This 30-year female was sent for ASD closure by a qualified cardiologist to our center.
So can I have this
And
slide?
the person who referred actually was actually a qualified cardiologist from a postgraduate institute. This is the institute from where I graduated. So this is my alma mater.
Can I have the full slide?
That is a 50 years old story.
Dr. Mohan,
but the patient was admitted under a cardiothoracic surgeon. Cardiac catheterization was done by one of my intervention cardiologists and ASD was confirmed. So the patient was for ASD closure. And it so happened that the echo was ordered by cardiothoracic surgeon and Dr. Madhu was performing echo when I just walked in the echo lab. And I noticed some unusual things and I thought we should review this case completely. This 30 years medium built female actually was having exertion dyspnea for last few years, exertional palpitations. She had no syncope, no swelling or syncope or squatting. Blood pressure, heart rate was all right. She had mild central cyanosis. And note this central cyanosis wasn't noticed by many adult cardiologists because they never actually looked at the nails. It was detected late after cardiac catheterization by us when we were doing an echo. And she also had grade 2 uniform clubbing in all 4 limbs. Again, noticed much later while doing echo. And she had injected conjunctiva. She had basal ejection systolic murmur, split S2, no variation, A2 equal to P2, and systemic arterial saturation, which was recorded first time in echo lab was 85%. That is her hemoglobin 17.4. So she had obviously polycythemia. And of course, these are her nails. Actually, you can see the clubbing as well as the cyanosis, and that tells you actually the systemic saturation would be 85% or less. It is surprising that adult cardiologists don't look for this and tend to miss more often. Surprisingly, the lower limb also she had some clubbing and of course the blueness of the nails. The tongue did not show much actually change, and maybe that was one of the reasons why cyanosis was not diagnosed. You sometimes don't look at the nails of an adult patient who is presenting with so-called ASD. So before I show you this case in detail, keep in mind one thing, that whenever we encounter congenital heart disease, we try to divide into 2 parts, cyanotic congenital heart disease and acyanotic congenital heart disease. And again, these are divided by whether there is a reduced pulmonary blood flow decided by either a P2 which is absent or P2 which is diminished, or increased pulmonary blood flow where A2 and P2 are equal or P2 is increased in intensity. In acyanotic congenital heart disease, there can be increased volume overload, where always the P2 is equal or louder, and decreased pressure, of course, where quite often, if this is a right side disease, P2 is diminished in intensity. Cyanotic congenital heart disease, on the other hand, you could actually, for an adult cardiologist, it is easy to remember this way, that either the patient can present with pulmonary stenosis or no pulmonary stenosis. If there is a pulmonary stenosis, either P2 will be absent or P2 will be diminished in intensity. And if there is no pulmonary stenosis, then the P2 can be normal or it can be loud. And then, of course, depending upon whether pulmonary hypertension is present or not, you can go down further. But this also seems quite an algorithm for adult cardiologists. So a simpler thing which I suggest adult cardiologists is that whenever you see cyanotic congenital heart disease, remember 5 T's and try to see, is it truncus arteriosus, is it transposition of great arteries, tricuspid atresia, tetralogy of Fallot, or total anomalous pulmonary venous return. These are the 5 things you have to see, and surprise or surprise, ECG and X-ray can help you in differentiating these conditions to a great extent. ECG in this particular 30-year female shows you right bundle branch block right axis deviation, sinus rhythm. So things which are clearly out just by looking at the ECG are tricuspid atresia, single ventricle, and truncus arteriosus. This ECG would be suggestive of ASD with PS or tautology or double outlet right ventricle. So we are very clear about few things which the ECG can tell us. This is of course X-ray chest, and the X-ray would also rule out tautology of fallow and also transposition of great arteries. You know the classic appearance of egg on side appearance and of course Corin-Sabot appearance. There is some mild cardiomegaly and increased plethora. Actually, when the pulmonary plethora tells you that you wouldn't be dealing with a patient with reduced pulmonary blood flow. It's not going to be. This is not going to be a patient with the tetralogy of fallow or tricuspid atresia. The other problem which adult cardiologists have is catheterizing these patients, and of course they are extremely poor in catheterizing and understanding. Well, I don't want to go in these details about this, but the fact is that the catheterization actually has to be done probably in a more systematic manner, and you can't have in an AS where you are diagnosing as an ASD, you can't have a wedge pressure of 30 and you can't have a right atrial pressure 13. 30 and 13 just wouldn't be possible. They have to be equal. That means that that is not the wedge pressure, that is actually the PA pressure. We'll forget for a moment saturation. There are plenty of problems. Just to tell you that if you can catheterize, take help of an adult, take help of a pediatric cardiologist who can do the job better than you. And Dr. Fulwani will be laughing at it, but this is a fact of life. This is how intervention cardiologists actually practice cardiology other than opening up the coronary arteries. So let us come to this patient. Can we run it? Let me see if I can run it. Okay. All right. So I need to actually go full scale. Right. So let us see this 30 years female. The inferior vena cava is dilated, somewhat collapsing. There is a suggestion of a thrombus at the origin, at the IVC-RA junction. And of course, this needs to be kept in mind. Let us look at the parasternal long axis view. The things which are obvious are dilated right ventricle outflow tract. And the other things which are obvious are marked here. You have a number at number 3 behind the left atrium is coronary sinus, which is intrapericardial, which is dilated. You have descending thoracic aorta, which is extrapericardial at number 2 position. And anterior to both these structures, there is another structure anterior to descending thoracic aorta. And you would remember from your knowledge of anatomy that left pulmonary veins cross over the descending thoracic aorta to go to the right side. And hence you would know that this would be something to do with, this number 1 would be something to do with the pulmonary veins. So more or less the same thing, actually just trying to show you dilated coronary sinus and of course descending thoracic aorta, the one being extrapericardial and the one being intrapericardial. Whenever you have dilated coronary sinus, few things should come to your mind. It could be LSVC to coronary sinus, it could be intracardiac TAPVC, it could be CS diverticulum, it can be heart failure with raised left ventricle filling pressures. We continue to see this parasternal long axis view, and we realize behind the left atrium and between the descending thoracic aorta, now you see a chamber which seems to be lobed actually, which seems there is some kind of partition, but we are now understanding that since it is in front of the descending thoracic aorta, it has to do something with the pulmonary veins. And of course, the color flow, in fact. So let us go to the modified 4-chamber and 2-chamber view. You again see the left atrium, and you again see a chamber adjacent to left atrium on its left side. Show you better. Now you can see that there is descending thoracic aorta down, and you can see a venous connection with the red flow, which is actually traversing the descending thoracic aorta, and of course, obviously, it has to be some kind of pulmonary venous channel. Okay, I would run this, and there is some degree, there is a significant tricuspid regurgitation with a trans-tricuspid peak gradient of 3 meters per second, suggesting a gradient across RV to RA of 36 millimeter of mercury. So moderate to severe tricuspid regurgitation, but let us concentrate now again on the fact that we have some interesting phenomena. Right atrium and right ventricle are dilated, and we need to identify more about the chambers which are present on the upper left side. So let's look at the chambers. And here, one thing is clear, that there is no atrial septum. There is no interatrial septum. Actually, it looks more like a common atrium. And the structure which you are seeing are coronary sinus as well as the left side and right side pulmonary veins draining into a common chamber which has a thin cribriform kind of plate through which it is communicating with this common atrium. And the transesophageal echo shows the same thing actually. Behind this structure which you are seeing, which is mobile, right near the apex, actually is a wall of that confluent chamber which is opening in the common atrium. There is no differentiation of right atrium and left atrium. So and you can see the color flow here. So from that common chamber, flow comes straight, of course, to the common atrium, passes through the right ventricle through the tricuspid valve. This is not a CT angio. This is a plain CT which shows you dilated right atrium, usually dilated right atrium, dilated right ventricle, and of course a big portion of pulmonary veins directly communicating along with coronary sinus, making a funny kind of chamber which is like an octopus, and it is connected to the atria. There is a portion of the atrium which we have labeled a left atrium, which is actually a left side of the atrium rather than calling it left atrium. This is the same thing. So this patient was operated actually, and the diagnosis, of course, was total anomalous pulmonary venous connection draining into coronary sinus in an adult, common atrium, and CS was not deroofed, right to left shunt, and mild pulmonary artery hypertension. Keep in mind, this is an adult 30 years female. 80% of the TAVPC patient die within the first year. Rare survival till adulthood has been reported. About a dozen cases have been reported, 50% of which are from India. And this is a cartoon showing what our patient had. This is the coronary sinus, and of course the right and left pulmonary veins make a common kind of chamber, which is opening right at where the interatrial septum should be. The commonest variety is supracardiac, but you also have cardiac like our case, and infracardiac, again draining in portal vein or hepatic vein, is the second commonest, and then you can have a mixed variety. I wouldn't go in the embryology, but keep in mind one thing, that these pulmonary veins develop from splanchnic plexus, which actually is something which is related to the left and right cardinal veins and umbilicovitelline veins. And from this splanchnic plexus, a common pulmonary vein arises which connects to the left atrium. And this common pulmonary vein then gets adsorbed, and all four pulmonary veins have different openings into the left atrium. Failure of the common pulmonary vein to connect to the left atrium is the embryological basis for TAPVC. So this is again a cartoon to show you how on the left side the common pulmonary vein does not join the left atrium, and if it doesn't join the left atrium, it can either form a vertical vein to go up or to go down, or of course this can form a common chamber which can connect to right atrium directly or to the coronary sinus. Let me show you the second case, and before we have some more discussion. So this is again a 30 years female who actually had exertional dyspnea, and of course she was in failure, jugular venous pressure was elevated. She had no cyanosis, no pedal edema, diffuse cardiac impulse, parasternal lift, and same typical finding: wide split second heart sound, no click, no S3, loud P2, which rules out, of course, many conditions as we already discussed, and of course, pansystolic murmur at left lower sternal border. She also had right bundle branch block like the first case. She also had same kind of X-ray. I wouldn't be spending time because we have limited time. And her arterial saturation was 88%, so she had systemic desaturation. So we did perform echocardiogram. And the parasternal long axis view, the two views, you can clearly, the arrow points to a perimembranous VSD, which shows bidirectional flow. But you also see the right ventricle, which is dilated. What is important is see behind the left atrium. Again, behind the left atrium, you see, in fact, you see three chambers, two anteriorly and one posteriorly. The one which most posterior, close to the very border, the descending thoracic aorta, and the two which are at the top probably represent two common pulmonary veins. Let me show you again. Now, this is a four-chamber view showing you right ventricle, right atrium which are dilated. And you can see a cribriform type of atrial septal defect. Very small left atrium. But what is interesting is that at the top of the left atrium, since it is upside down, you could say the bottom of the left atrium here, but actually the top, there is a chamber. There is a chamber. And one of the left pulmonary veins
Day clinical use. You want to measure global longitudinal strain quickly to better assess overall
Am I
cardiac
audible?
function of patients in an everyday setting.
Can you connect me to the...
Epic CVX uses advanced automation
audible.
technologies
Yeah.
to deliver one
What
button
happened?
push
You don't know.
robust and reproducible results, eliminating the need for user interaction and aligned
think
with the
did
Speckle
he log
task
out?
force.
I can't see him.
I think the Zoom has something went wrong.
Yeah, this time the Zoom is not... So do we think we should... do we have some questions? There's a question I think somebody else can answer.
Yeah, I think he's logged in. He's logged
He's
in.
logged in. He's back. Yeah.
Yes.
Dr. Mohan? His audio is not... Yeah, I think by the time he is trying to log in, there is this question: what is the difference between a common atrium and a single atrium?
I think it's the same.
It's the same, yeah. It's the same thing, right? Okay.
It's a difficult topic to discuss. Therefore, there are no many questions because, as Dr. Mohan said, very less people practice pediatric echocardiography, and therefore we do not expect also many more questions. Go ahead.
Can you see the slides? Can you see the slides?
No, we can't now.
We can't see you.
What is wrong actually at your level? Anything wrong at your level?
No. I think everybody else we can see. Can you show the video, please, sir?
Sure. Shows you video.
Can you share your screen?
Start video first.
I'm sharing the screen actually.
Start video.
I'm sharing the screen. I actually stop sharing and then you can let us see. Can you see me now?
No, sir. No, sir.
That's okay. What I'll do, I am going to reconnect. Give me a minute.
Okay. Yeah.
I will reconnect.
Yeah. Yeah, take a break.
You want exceptional
Can you
image
see me
quality.
now?
Yeah, we can see you. Can you get?
Yeah, we can see you now.
Yes, we can see you now. Yes,
Yes.
Dr. Mohan, we can see you now. Can you share
Okay.
your slides?
Yeah, I'm sharing the slides. Okay, okay. This is the second patient who shows actually the last is 5 meters, indicating RV systolic pressure from 110. Are you able to see it?
No, I think your bandwidth is slightly lesser. That's why it is not coming. You can turn off your. No, again he's gone. Do you think we take another slide? Yeah, we'll just wait for 2 minutes. Next question for the Doctor. Significance of dilated coronary sinus in an adult. Dr. Nitin, can you take it?
The most common is obviously the left SVC draining into the coronary sinus, and you can prove that by injecting the saline bubble contrast into the left antecubital vein. Then the second one, another which is more common is another one which is very common is actually the right heart failure, and especially if your TRJ is going towards the coronary sinus, it is dilated. Thirdly, you can have the, of course, in the younger age group, intracardiac TAPVC, where either the right-sided vein or the all the veins draining into coronary sinus. There you can have coronary sinus dilatation, and I think these are the most. I mean, these are the generally the common causes.
Right.
Rarely you can have AV fistula in an adult, which was, but the color flow will be able to tell you that. Color flow, the minute you put the color flow, I think the right coronary artery or left circumflex artery you can have very rarely the one which is causing a flow, and with the color flow you'll see it. And I think one of the important things is when you see a coronary sinus which is as big as what Mohan was showing, it becomes important for us to make sure that the right SVC is seen by doing a subcostal sagittal view where the right superior vena cava is seen or not. And as Nitin nicely pointed out, that not only you do the left brachial injection, agitated saline injection, you should also do it from the right, because the communicating vein between the left and the right may not be present in about 10 to 15% of the patients. Then, if the communicating vein is there, even if you have a left SVC, you can still use the left side for your pacing and other things. The communicating vein is not there, then I think you can't go. It becomes important to do it on the right side. So I think the suprasternal notch view of the SVC sides and the color flow showing both sides. And sometimes you can even see what appears like another thing that is going to be seen on the suprasternal notch view is going to be in a short axis view, you'll see the color, both of them going in a blue direction, one for SVC, one for the left SVC. Then when you see that, then you know that right SVC is also present. But injecting from the left arm and the right arm becomes important to make sure that the communicating vein is present or not. That can be only seen only with the suprasternal notch view, where you have a long axis view. You see the aorta coming like an arch, then tilt it a little bit anterior, then inject the bubble. You can see going across.
Great. So I think I cannot see Dr. Mohan logging in. I think his bandwidth, there's a problem with the bandwidth of his connection. So if I can request Dr. Nitin Burkule to share his presentation, share his slides on aortic. I'm sorry?
Okay.
Okay, yeah. So,
Okay, Dr. Mohan is back.
So let me just quickly finish that case actually.
Okay,
and then
fine.
we can, yeah, what happened. Let me see if I can get it back. Just give me 1 minute, I will be with you. 1 minute.
Innovation and you, Philips.
I think I have some issues. You get going with the program.
I think there's a problem with the bandwidth at your end, Dr. Mohan. If then I can request Dr. Nitin Burkule to share his slides and on aortic regurgitation assessment from basics to post AVR. Dr. Nitin, please. Yeah, we got you, Nitin.
You're seeing my screen?
Yes.
Okay. If there is any problem with the viewing of the slides, just let me know.
Sure.
Thank you, Shantanu, for this opportunity to present in Echo Nagpur. And Dr. Shantanu had told me that the audience will be having echocardiographers at different stages of their career. So you start with the basics to advance of the aortic regurgitation evaluation. So dear friends, as we know that the aortic regurgitation evaluation is multifaceted. You cannot just stick to just one value and one parameter. As you see that there is a 70-page document by the AAC on the regurgitation, on the assessment of mitral and aortic regurgitation or valvular regurgitation. So the approach is that we have the qualitative assessment of the aortic regurgitation, then a semi-quantitative assessment of the aortic regurgitation, and then a definitive but very carefully done quantitative assessment, and then in certain cases taking the help of other modalities, which is generally the cardiac MRI. Now remember, the valvular regurgitation evaluation is just like your clinical examination or just involves all the clinical skills. The way you take the pertinent points from the history, you take the pertinent points from the clinical examination, see which parameters are moving in the same direction, and then you synthesize the diagnosis. The same thing you have to do for the aortic regurgitation, that you have to look at the parameters, because it is very naive to think that each of the parameter in each of these headings will be moving in the same direction with the same intensity. It is not possible. So you will have a mixture of them. So you pick up the parameters which are moving in the same direction, and also find the answer for the parameters which are not moving in the same direction. Look at the quality of data and then synthesize what is the amount of aortic regurgitation. And in certain cases, you take the cardiac magnetic resonance help. So what I did is I took a regular case for the AR evaluation, and I think we'll go right from the basic to more advanced quantification in that case. So this is a case, a 63-year-old lady. She is hypertensive on treatment. She had a type A dissection 10 years back, and she had a valve sparing ascending aorta replacement with prosthetic prosthetic material replacement. She's class 2 dyspnea. She has an aortic regurgitation murmur, and now the surgeon wants to know the aortic regurgitation quantification, because now is the time whether the spared valve is leaking more or not. Now this is her, so we'll start with her echo just as if we are starting in the echo lab. always start gathering everything that is possible, qualitative and quantitative data. If it is a volume regurgitated lesion, we should know that the LV has to be dilated and should have some hypervolemic contraction. But let us look at this, that the LV dimensions are increased. The diastolic dimension is 64. The systolic dimensions are 44. We'll look at all the long axis views. Now, one thing is sure that this LV has an eccentric hypertrophy. It is remodeled. And so also in a volume overload lesion, you would expect a very hyperdynamic LV. The fact that the LV looks, the systolic function looks slightly impaired. And this is the short axis view. There is no regional wall motion abnormality or no dyssynchrony here. And the QRSS is narrow. Now you have to do the first, quantification by the Simpsons, and here what we get it with a more careful analysis that the ejection fraction is 50%, the end diastolic volume is 162, and end systolic 83. Now remember that we are going to systematically underestimate the end diastolic volume and end systolic volume compared to a contrast enhanced LV opacification. And even the contrast enhanced LV opacification on with the LV volumes measured by Simpsons are going to be lesser or smaller than the cardiac MRI derived end diastolic volume and end systolic volume. However, you are systematically underestimating EDV and ESV. The EF change is much less. So this same patient on the cardiac MRI, later on I'll show you the volumes, and the EF was 55%. So the E by E prime was okay. And then we'll look at the GLS. The GLS is definitely reduced in this patient. And now we'll start looking at the aortic regurgitation first with the qualitative eye. So what is the qualitative eye? That you look at the breadth of your AR jet in the LVOT, how much it is occupying the size in the LVOT. Whenever you are doing a color Doppler of the color Doppler mapping or the color flow mapping of a regurgitation date, you look at three things. One is you look whether at the same Nyquist limit of your regular setting, are you seeing some flow convergence? Whether how much is the qualitative thickness of your vena contracta? And then you look at how much is the extent of the jet. But remember, do not put any money on the extent of the AR jet. Just look at the origin of the AR jet. So what you would be looking at is the whether you are seeing the flow convergence without adjustment of the baseline, and how much is the thickness of your vena contracta. But currently we are just doing a qualitative assessment. Then you will look at the CW jet of your aortic regurgitation. Obviously, luckily this is a central jet, so it is easy to get a complete envelope. If you don't get complete envelope in an eccentric jet, then don't use this particular qualitative assessment. You will look at the density of the jet. Higher the density, more significance is the regurgitation, because as you know that this particular spectral broadening tells you that there is a turbulence and different quantums of RBCs are moving at different velocities at a particular time. Then you will look at whether the slope is quite fast or whether the slope is very slow. A slower slope is definitely a mild aortic regurgitation. However, in an acute AR, you will get a very rapid slope. But however, if the slope is reduced or it is rapid, in chronic AR, definitely the volume is more. Then this is a patient who had a type A dissection with the, you can see that this is the prosthesis which is sutured here. So you still have a false lumen here and a true lumen here. And we'll look at the regurgitation, we'll look at the color flow map in the descending thoracic aorta, because we are just qualitatively mapping everything. Look at the reversal of the flow in the diastole. If it is pan-diastolic, very likely it is a significant aortic regurgitation. However, as you know, that if you have got a left AV fistula or in children where there is a significant flow to the cerebral circulation, you will have a lot of reversal, or even in a PDA, you will have a reversal, or in a ruptured sinus of ulcer, you will have a reversal. So it need not have to be always the AR. Then you can also look at more creatively by putting a color M mode and just look after the T wave, how much is the red flow map there, and you know that this is a pan-diastolic reversal there. You can also look at the end diastolic velocity of the reversal at the peak of the R wave. Something which is more than 18 centimeter is generally significant. One can even do a velocity time integral of the reverse flow versus the velocity time integral of the forward flow and just take the ratio of it. If you take the ratio of this 350 by 500 or something here, you know that it is more than 0.5. This is like something having a very rough estimation of the forward versus backward flow or a regurgitant fraction, though this is not a regurgitant fraction, but it is a qualitative assessment. So if we look at the qualitative Doppler, we just look how much is the width, how much is the convergence, what is the density, whether the PHT is fast or slow, and what is the diastolic duration of the flow reversal in the descending aorta. So if we put all our findings particularly, we are somewhere here. So we have a mixed bag here. We have got certain parameters looking severe qualitatively, something looking like in the moderate range. Now we'll go for a little semi-quantitative way. Now, as I told you, when you look at the color flow map, do not look it as an ultrasound angiogram. Okay, do not look it as if the jet area is going all the way into the receiving chamber. Do not look at that way. The only use of the color flow map is to look at the origin of the jet. So you should know what is the vena contracta and how good is the flow convergence radius. That is what you want. So the first thing is that you would look for a vena contracta, which is generally on the LVOT side, just below the valve, where the flow continues to narrow. And then you measure it perfectly vertical in a zoomed view to improve your resolution. And always your ultrasound beam should be perpendicular to the jet so that your measurement in the direction of the jet is accurate. Never measure vena contracta laterally, okay, because the beam diverges. So you have to do in the beam, in the direction of the beam. So you measure here something like 5.9 vena contracta. Never overlook the ascending aorta SOVs because they will have a clue to the diagnosis of the cause of aortic regurgitation. So every AR report should have the SOV and ascending aorta reported on and the images documented. Then there is a way to look. These were very early papers coming from the color Doppler. When the color Doppler imaging came in vogue, very early reports look at the jet height divided by the LVOT height. And the guidelines recommend us that you do the measurement within 1 centimeter of the vena contracta downstream and at the same cross-sectional level. And here somewhere we get it at around 36%. And the same thing you can look at the jet area end on. However, you have to be slightly towards the inflow, that is slightly towards the receiving chamber, that is slightly towards the LVOT. And you can measure the high velocity short axis of the jet area and the LVOT area. Now, if we put all this, there are only 3 semi-quantitative parameters here, that is the vena contracta width and the jet width to LVOT width and CSA. Now, most of our measurements have fallen somewhere here. As I told you, don't be chauvinistic of only one parameter. As I told you, it's a way of clinical examination. Your ultrasound is just an extension of your clinical examination, and you have to synthesize everything putting together. Okay, the way you do come to arrive at the diagnosis. You never have a classical case. You always synthesize it from various parameters which are moving in the same direction and finding the answers why some of the measurements are lagging behind. Then come to the quantitative estimation. Now, this is something which I find always lacking when I see the reports. I think you have to make it make a habit to do quantitative estimation. Though the guidelines tell you that you do it only when you are in the moderate range, where you have got a very florid, severe, and very mild, you don't do it. But luckily, most of your ARs that are coming to you will be in that moderately severe, that kind of a range. And I would urge you to do the quantitative estimation, because unless you do it repetitively, you will not become expert and you will not know the pitfalls in it. Now, there are 3 things that you look at the quantitative estimation: a regurgitant volume, a regurgitant fraction, and a effective regurgitant orifice. Now, remember, the regurgitant volume is nothing but the stroke volume across regurgitant wall minus the stroke volume across a competent wall. So if the regurgitant wall is aorta, then you will take the stroke volume across the aorta, forward stroke volume across the aorta, and then if the mitral wall is competent, you will take the stroke volume across mitral wall, or if the pulmonary wall is competent, that you will take it as a competent wall stroke volume, and you will subtract, because the stroke volume across the aortic wall is going to have the forward stroke volume and also the regurgitant volume. So you will get the regurgitant volume. Once you have a regurgitant volume, regurgitant fraction is very easy because it's the numerator, the regurgitant volume is the numerator, and you have to just divide the total stroke volume across the regurgitating wall. So that is how you get the regurgitant fraction. And if you are going by the quantitative Doppler estimation and not using PISA, then you will have to get the ERO last. Otherwise, the PISA starts with the ERO and then it goes towards the regurgitant volume and the fraction. But when you are not using PISA and you are using Doppler quantification or volumetric methods, you will get the ERO last. And the ERO is nothing but the regurgitant volume divided by the velocity time integral of a carefully done planimetry of the regurgitant jet. So we'll look at the same case ahead. So we'll always start with the LVOT diameter, a proper focused view, and at the hinge points, a perfectly perpendicular LVOT diameter, and that we have got something like 25 millimeter here. Then you take the LVOT flow with obviously your PW sample not going inside the proximal convergence high velocity, but somewhere at the boundary here. And then you take multiple of them and planimeter the outer border of the modal velocity, and you take a average of it. Averaging is very important to reduce the error. So we have got something here like 147 ml, but we'll take it something like 150 ml for the calculation. So let us look at the non-competent wall at the pulmonary level. Now, this is a very trivial pulmonary regurgitation, and you can always use it for the stroke volume calculation. Put your PW exactly at the wall, because RVOT is very notorious in changing its diameter throughout the systole. So put it at the LVOT, and you have put it at the pulmonary wall. That's why you get the clicks here. And then you have the diameter, and generally this diameter is best to take it in the parasternal long axis view tilted laterally rather than the parasternal short axis view. And here we have got something like 24 millimeter diameter here. So your radius is 12 millimeter, and then you take a velocity time integral of your RVOT, and then you get an RVOT stroke volume, which is 90 ml. Now we know that something is going 150 ml across the pulmonary wall, the regurgitant wall minus the competent wall, and you have a regurgitant volume of 60 ml here. And when you have got a regurgitant volume, you divide it by the stroke volume across the regurgitant wall, and you get a regurgitant fraction, which we got it as 40%. And then you divide the 60, which is the regurgitant volume, you divide it by the velocity time integral of your regurgitant jet, which is nothing but the AR jet, and where the VTI is 160, and you get an ERO of something like 0.38. Now, the next non-competent wall or the competent wall is the mitral wall here. You're going to get a very mild mitral regurgitation, and let us use it. However, the PW has to be positioned at the level of the annulus, never at the tip of the mitral leaflet, which you use for the E and A estimation for your diastolic dysfunction. So your PW should be at the level of the mitral wall annulus. And your major, so here we have put it exactly at the level of the mitral annulus, and then you get an E and A, and then you take absolutely, you average it multiple bits, at least 8 to 10 bits, and then you generally get the mitral wall VTI somewhere like 12 to 15, 16, 18, that kind of a one. And here we have got it around 11.5. And then you look at the mitral wall annulus. This trick is that it has to be a mid-diastolic frame, and there is a way whether you take it in 4-chamber and take it as R1, and then you take it in 2-chamber and take it as R2. But however, the studies have shown that actually measuring it in one direction is much more reproducible and much more better, because that actually leads to a better stroke volume estimation. So we have got a pi here, and we have got a diameter of 28 millimeter and the VTI of 11.5. So we get a mitral stroke volume of 70 ml, which is actually less than what we were getting at pulmonary. But I think this difference are going to come because, as you know, that mitral annulus we are going in because we are going to have a lot of error in measurement of the mitral annulus cross-sectional area. So here we get a regurgitation volume which is higher, and then we get the regurgitation fraction which is 53, and we get an ERO of 0.5. Because again, you have to use the same velocity time integral to get the ERO here. Now, the third quantitative measure that remains is the PISA. PISA is very rarely used for the AR than the mitral regurgitation. So here we have got the baseline, which always moves in the direction of the regurgitation to reduce the Nyquist limit to 37. And then you measure the radius. Now, most of the fellows ask me where you start to measure. First is turn the color off and on and find out where is the anatomical location of the aortic wall. And second, which I find more useful, is that you look at the black band. Remember where the flow when it is going towards this hole, whenever it is perpendicular to your ultrasound beam, it will have a signal wide because it is perfectly perpendicular to the ultrasound beam, and you get a black band there. And that is the point where exactly you have the base of your hemisphere. And from there you measure it, and we have got a PISA of 9 millimeter, that is 0.9 centimeter here. So we use the surface area of a hemisphere, which is 2 pi r square, and then multiply it by the Nyquist limit, that is 37 that we had taken there, and then we get the numerator and divide it by the peak velocity of the ARJ, which is 420 centimeters. And we get an ERO of around 0.044 here, 0.44 here. And now you get the regurgitation volume by multiplying the ERO by the velocity time integral, and that is 70 ml. And now you get a regurgitation fraction by regurgitation volume divided by the forward stroke volume that we calculated at the LVOT, that is 150, and we get a regurgitation fraction of 46%. So we'll put the spread of all these values here, that you have got an ERO by LVSV minus RVSV, or by PISA, or by the LV stroke volume minus mitral stroke volume, ranging from 0.38 to 0.5. We get a regurgitation volume of 60, 70, 80 here, and a regurgitation fraction of 40, 46, 53. Remember, lots of errors would be there despite doing it again and again. However, remember, unless you are doing it regularly, your inter-study variability won't reduce, or even your inter-observer variability won't reduce in your same echo lab, unless all of you are doing it with the same discipline. So now this is quite a spread, but anyway, these all are definitely going in the range of grade 3 at least. So we are somewhere here for this for the regurgitation volume. We are here for the regurgitation fraction, and our ERO is consistently above 0.3. Now let us look at this patient has to undergo a cardiac, has to undergo a CT, because as you know that she had a dissection earlier, and here we are going from the superior to inferior. So what we'll do is we'll look for the aorta, and we'll look for the descending thoracic aorta here. And then as we see that the descending, you can see the arch of aorta we just missed here. I'll just go back, and you can see that this arch of aorta is showing the dissection flag, because as you know that in the repair, the suture line was somewhere here in the ascending aorta. So the arch is going to have the false lumen and the true lumen. And the as you go down, the spiral dissection, you can see in the descending thoracic aorta going all the way down as we approach. While the ascending aorta, you have got the conduit there, and you go all the way down towards the diaphragm. Now the thing is, this patient had excellent images, but as I told you that I wanted to show the entire spectrum of assessment in the same patient. So let us do the cardiac MRI evaluation for this particular patient. Now, more reason for doing here was not to get an additional information, but to show the audience how the cardiac MRI quantifies all the regurgitations, because we should know how our MRI colleagues are doing the quantification, and we should also know their pitfalls. So this is the cardiac MRI of this patient. And you can see this is our 4-chamber view, this is our 2-chamber view, and this is the long axis view. and you can see the aortic regurgitation. And this is a coronal view of the LV and aorta, which generally we never take or we can't take in the echo. So here what you can see is the aortic regurgitation. As you know, on the color Doppler, we see the aortic regurgitation by those beautiful colors. In MRI, you see them by something called as the dephasing, or they call as signal void, because all those turbulent RBCs cannot generate any magnetic signal or any spin signal. So they look all black. So the black extent is what is the aortic regurgitation jet. Now always remember, in the regurgitation jet, in the center, there are RBCs which are still having a very high velocity laminar flow. And you can see that white thing in the center of the jet, telling you that the center of the jet, there is a very high velocity, which is actually most probably aliasing also. And that is why you are getting a light white color in between. Whatever is the black is all those turbulent RBCs which are dephased. They are not going to produce any magnetic signal, and that is why it is a signal void. So signal void is a regurgitation in the MR. So you can see that it is quite a significant jet there. And this is like qualitative estimation, and the LV is quite dilated, LA is not dilated, the root is dilated, and one can also take certain thin slice to look at the valve. Then you take a series of short accesses, and there is no dearth of taking short accesses right from the mitral wall or the tricuspid wall to all the way down to the tricuspid wall. And how does that help? Now, somehow, without using a contrast, the MRI can get a very good contrast from the flowing blood, and that's why it gives you a good endocardial delineation, and you can actually include all this trabecula inside. And it also, because of the epicardial fat, gives you a very good epicardial delineation. So what is the strength of the MRI, or what is the strength of your MRI colleagues, is that they can planimeter the LV endocardium and epicardium very well. And then they divide it from base to apex by small small slivers or small slices. Each slice has got a thickness of around 6 millimeters, and the area anyway you get by planimetering it, and that area into the thickness of 6 millimeter, you get the volume of each of these slices. And then you can just add all these slices to get the end diastolic and end systolic volumes. The same thing is possible for the right ventricle, because you can actually have the slice going into the RVOT, and that is why you can include the RVOT also in the slice, and the same way you get a very good RV end diastolic volume, end systolic volume. But again, remember, your MRI colleague has to be very diligent in looking at the basal slices, that he is not entering into the RA, he is not entering into ALA, and also he is not making any mistakes at the apex, and he is delineating the endocardium well. So that also needs so don't say that MRI is a gold standard. It is the reader who is a gold standard of any modality. The reader is a gold standard. So the reader has to be very good. So what does the MRI then does? What it does is that it gets an end diastolic volume by getting this stack of LV short accesses and end systolic volume. So end diastolic volume is 226 here, end systolic volume is 102, and you get an EF of 55%. And then you get a stroke volume, which is 124 ml. Now the same stack it uses for the right ventricular end diastolic volume, end systolic volumes, and then gets the RV stroke volume, which is 62 ml. Now remember, if there is no significant TR and if there is no significant MR, then just subtracting the LV stroke volume from the RV stroke volume, you are going to get the regurgitation volume. So we get a regurgitation volume here of 62 ml. So we have got a 62 ml of regurgitation volume. Then this regurgitation volume, you divide it by the LV stroke volume, and you get a regurgitation fraction of 50%. So this is a volumetric method that the MRI guys can use. However, they have got two other tricks up their sleeves to again give you the measurement of the aortic regurgitation. And one of that trick is what they call as the phase contrast image. That means what they do is that they can measure the flow going across the aortic wall, both in systole forward and also in diastole, which is going backward. So what they do is that they get an image. One image is an anatomical image, and another image is just a blood flow image. Now in the blood flow image, the forward flow, which is going towards the head or the left side, is shown as white, and the flow which is going away towards the leg is shown as black. So that is why you can see that the systole, the flow is white here in the aorta and the black in the descending thoracic aorta. But also you can see that in the false lumen, you are having some swirling here. So this is the true lumen here, which is looking black. Now, look, it is not just looking at these particular blood flow images, which they call as flow phase contrast, but one can put an area of interest and can actually quantify the flow by measuring each of these pixels. So how do they do that? Now here in our Doppler, what are we doing? We are giving an ultrasound frequency which strikes the RBCs, moving RBCs, and the returning frequency is of different wavelength. We get this frequency shift, and that frequency shift is directly proportional to the velocity of the RBCs. While the MRI uses different principle, what it does is that it takes that tissue slice and just gives a magnetic gradient in one direction and then rapidly changes in the opposite direction. So what it does that whatever is the stationary tissue, it loses its or gets cancelled magnetization, but what has moved through this image slice is the only thing which achieves magnetization, and that is directly proportional to the velocity. So it is a completely different way of measuring the blood flow. Okay, and that is how the blood flow is measured for every pixel in the area of interest that you are giving, and then you get a forward flow, which is nothing like a velocity time integral, and you get a flow here, and then throughout the diastole you are going to get a flow, so you get actually directly a regurgitant volume. Now this looks a panacea, but remember, this is not a panacea. You have to be very careful in knowing your area of interest. You should not include the aortic wall. Secondly, look at the data points throughout the cardiac cycle. Now at this study, you can see there are only 20 data points throughout the cardiac cycle by which the forward flow and the reverse flow has been measured. Remember, in Doppler, we are accustomed to very, very high frame rates, and the events are resolved at 5 milliseconds and so forth. Now here there are a few, so it's possible that you are missing some data points and the curve would have been different if you had taken 25 data points. If the machine would have allowed 50 data points, this curve would have been different. So again, that is, you should know the limitations. But again, the positive side is that it can continue to change your area of interest throughout the systole, unlike our echo Doppler where we take a fixed area for measuring the forward flow. So what we'd get in this patient? So this is our forward flow, which we got at 103 ml, the velocity under this curve, and this is the regurgitation, which is pan-diastolic, and we get the direct regurgitant volume, which is 37 ml, which is actually less than what we got by our echoes, or also what we got by the volumetric assessment by the MR, and we get a regurgitation fraction of 37%. Now there's a third way of doing is that the same flow you can take across pulmonary wall and across aortic wall, and you can subtract it and get a regurgitant volume and the regurgitant fraction. Now one would say that you are getting lower volumes of regurgitant fractions in these particular two methods that you showed us, the phase contrast measurement. Now the thing is, currently there is the literature on the cardiac MRI for regurgitation volume measurement is very less. So the prognostic cutoffs are derived from the echo literature. So we are using the regurgitation fraction of 50% as severe, which is from the echo literature. We do not know whether it is the same threshold for the MRI or not. And it may not be true, because if we look at now this patient, most of our measurements, except for the severity of regurgitation volume that we measured by the volumetric methods of CMR, was in severe, while when we use the phase contrast images, we were in the moderate range. And I will bring you to your notice that what cutoffs from the echo literature for the prognosis of the patient may not be true for the MRI cutoffs. So this is a study of 113 asymptomatic subjects with moderate AR followed for 9 years after their initial cardiac MRI. They looked at the regurgitation fraction cutoff of 33%, and they looked at the end diastolic volume cutoff of 246. And you can see that the event-free survival from the need of surgery was quite different at the regurgitation fraction cutoff of 33%. Our patient, or the phase contrast, we got 37%. So though we had most of our echo Doppler or the volumetric method from the MRI, we got the regurgitation fraction at 50%, and we got little nonplussed looking at that 37% figure. Probably we are still in that severity zone. Plus our end diastolic volume was 226, and we know that this cutoff of 246 has separated these graphs. So we put all these all the things together here. The red ones are from the CMR methods, and the black ones are from our Doppler methods. So we have these 6 different methods to look at the same aortic regurgitation jet. And we see that there is a good agreement between the Doppler and the CMR volumetric method, while our agreement literally became shaky somewhere at the phase contrast imaging. But as I told you, that the cutoff for the regurgitation fraction may be different for the MRI from the prognostic purpose. So this is all about actually evaluating the AR in so much of detail. So it consumes a lot of time. But there is another situation where you have no time. You are in the cath lab, patient is on his back, the interventional cardiologist is on his toe after releasing the TAVR valve, and now he wants you to measure the paravalvular leak fast. Now you can't do all these measurements, because then the people will go mad there. You have to be very quick in measuring the paravalvular leak in the cath lab when the TAVR valve is being deployed. You really don't have time to do all these 6 different modalities. So what is the intra-procedural? Now this you can see that this is the self-expanding evolutive wall there. And what are the things that you are doing during the procedure? T versus TT. Now most of the labs have gone to the transthoracic echo, and they have left the transesophageal. They are not doing transesophageal more anymore, because obviously now you don't need anesthesia. But this has increased the problem of the echocardiographer, because as you know, it's very difficult to do transthoracic of an elderly patient on his back who cannot turn to the left, and you have got a limited access to his chest to get such kind of good images on the table. So what I always tell is that you first mark the echo windows in the flat position before even the procedure starts, so that you don't fumble after the TAVR is deployed. You look at the depth of the implantation so that it is not encroaching beyond the aortomitral curtain. You look at the acute regional wall motion changes, that there is no coronary embolization or occlusion. Look for the intraprosthetic leak, that there is no, that the leaflet has not got deployed and has got stuck, and there is an acute AR. Then look at the PVL. Now PVL is what? That is the paravalvular leak. That is what we want. And as you know that now you are not going, though you can use all those measurements of quantitative, qualitative and semi-quantitative, but you really have no time there. So you can bank upon only 3-4 of them, and I'll show you. Then you look at the prosthetic gradient, then you look at the pericardial effusion so that there is no root rupture. And then if at all the retrograde aortic wall crossing is difficult, then you have to go anterograde, then probably you will need a T to guide the septal puncture. Anyway, so the first thing is actually more than the echo is to look at the screen, to look at the simultaneous LV and aorta pressure measurements, and you look at something called as AR index. That is nothing but at end diastolic, what is the pressure difference divided by the LV systolic pressure. Now, as you know that if there is a significant paravalvular leak, obviously the gradient is going to reduce from aorta to the aorta to LV. But the thing is, at the end diastole, if there is a less of a gradient difference, that means there is a significant regurgitation. So if the numerator becomes so smaller and the denominator is large, that means there is a significant PVL. So if it is less than 25%, that means it is quite a significant paravalvular leak. Then you start looking at your images, and of which I'll go step by step. Now the AAC guidelines to look at this, 3 of which the vena contracta are the same this thing, and the circular extent of the PVL in short axis, whether it is taking 10% of your circumference, whether it is taking 10 to 30%, or it is taking 30%. Now remember, you have to add them because the PVLs can be different sites, because depending on how the calcium is there in the annuli, you can have PVLs at multiple positions and you'll have to add them together. You're not going to have only one single PVL. And the vena contracta area, this is actually more of a 3D generated vena contracta area, but you can try to fix it with your 2D image also slightly towards the alveoli and take the area of the short axis of the jets and add them together. And if it is more than 0.3 square centimeter. Now, the first thing is to start hunting for the PVL, because most of the time you will see a nice jet here, probably there is no PVL. This is just immediately after the deployment. But you start moving around and then you start seeing the jets. Now here you are in the 5-chamber, slightly tilted up, and you start seeing a significant PVL here, okay, which was not seen in your apical long axis view. Then you go for different odd views, and then you start picking up. Now if you have started getting some flow convergence, as I told you in color flow mapping, it is not just locating the AR, but also knowing the significance. So if you, without shifting the baseline, if you're having some flow convergence, some thickness of vena contracta, that is a significant one. Then look at, this is a P-lax, but this is not a good P-lax. This is a P-lax with lateral tilt, and that is why you are seeing the PVL here. Now this is the secondary MR for this patient, but this PVL would not have been if this was a good parasternal long axis. So your parasternal window and your apical window, you mark it even before the procedure starts. And then when you do it, take all the unconventional views to search for the PVL. Then look at the PVL in a short axis. Now don't mix up this. This is the flow in the coronary. Don't mix up that flow in the coronary, okay? Because the coronaries are many times very prominent in these patients. And don't take it as this is, as you know, that this is the PVL. So what you do is you have to scan from the sinus back into the alveoli and try to catch the curve or the sector of the PVL there. You have literally no time. You have to do it very fast because everyone is jumping on you to tell you the PVL. Now this is a self-expanding wall. So probably there is not much after the release that you can do. But if it is a balloon expandable wall, he's waiting to further dilate it if there is a significant PVL. And that's why this is very crucial. And then here you can actually measure the VCA areas. Obviously, there should be a 3D data set, and you add these areas together to get your total area. If it is more than 0.3, it is significant. Then you can actually take the this arc, how much arc of the circle that it is having the PVL. So this is the entire 360-degree circle, and you can see that it is almost around 1/4 of the circle. So it is around 25%. Of the PVL. So this is how here you will have to completely rely on the semi-quantitative and qualitative data sets, looking at multiple jets. You don't have time to do all that kind of quantification. And as I told you, look at the hemodynamics on the monitor, especially the AR index. Thank you very much.
आगे 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 वो स्लाइड तक
You are muted.
रेफरेंसेस निकालो.
Okay. So Nitin, thank you very much. You have given us detailed description of quantification of aortic regurg. But we all know that it is not possible to do all such a detailed evaluation in day-to-day practice. Moreover, we have many beginners also. Many of us are doing echocardiography in next 5-7 years. So just for them, what we should do, maybe in 5-7 minutes of echocardiography, so that they give us good assessment that okay, our patient is having severe aortic regurg, so that he comes to us or maybe for someone else for the further evaluation.
So as I told you that that qualitative and semi-quantitative assessment is very important, and as you go that in the ASC document, though it looks a 70-page document, but I think every echocardiographer should go line by line from that document. And you know that there are very good flow diagrams there, where actually at the extreme ends you really don't need quantification. Now I did quantification in this to present it, but I will tell you, as you are maturing as an echocardiographer, keep on doing these quantifications again and again so that you become a pro. And then you are there to differentiate between a grade 2 to grade 3 AR. There's not much in differentiating between grade 3 and grade 4 or between grade 1 and grade 2. What is important is to make the difference between grade 2 to grade 3 AR or moderate to severe AR, because everything depends upon that. And as I told you that if you go by the AAC algorithms, you have those semi-quantitative and the qualitative data of severe and the mild. If nothing is fitting into that, then I think you would go specifically by the route of quantification. And all these three quantification methods of PISA, the PW, and the PW and the quantitative and the volumetric methods, you should be doing it for every patient, so that you have got even internal quality checkup also for your data set, and then discard the one which has got a poor quality images and which is not fitting into the general scheme. Those you can always discard or find out the reason why it has happened that way and synthesize your final diagnosis.
So Nitin, there is a question. Some suggest LVOT diameter at the same level of aortic annulus to avoid error. Is it advisable to do that way?
Yeah, true, because I think it is best to use this hinge point because they are very stable. As you know, the rest of the LVOT, the floor is made by the intermittent leaflet, and you know the LVOT can keep on changing its diameter there. So this has always been contentious point, but I think it is best to go by that. Unfortunately, if you've got a lot of calcium there, then you will have to move towards LVOT, but never into the sinuses.
Anything about eccentric jet assessment?
Correct. So the most of the, I showed you the case where if the jet was centered. So when it is eccentric, probably flow convergence, you can still get it very well, but you will not get a good vena contracta. You will not get a jet height by LVOT height. You will not get a good cross-sectional areas, ratios, so on and so forth. However, your descending aorta flow always remains there. It's a very, very good assessment in the semi-quantitative or qualitative way. That pan-diastolic flow reversal. So descending thoracic aorta is something that we first see even before doing the entire quantification. So in eccentric jet, probably I think use that descending thoracic aorta and then go for the quantification, because the quantification will not be altered, except probably you may not get a good PISA.
Perfect. So thank you so much, Nitin. We have Dr. Amuthan, who is going to speak on mitral regurgitation and update. Can we have your slides, Dr. Amuthan, please?
Thank you, Dr. Shantanu, for do you have seen my screen?
Not yet.
Not yet. Yeah, yes. Display kar do, please. Can we have the visuals? Yeah.
Yeah.
Yeah. Can you make it bigger? We can see it.
I don't. There is some bar which is coming here, which I'm not able to maximize. Is there any shortcut?
You have to click on that full screen.
That thing is not showing here.
Slideshow.
You can. Yeah, it is there. It is below.
Down. Yeah, that one. Yeah, just below.
You can go.
Right there.
You can go up.
And there's a column of slideshow.
At the top. At the top.
Yes.
Go to
Right,
slideshow.
slideshow.
Click.
From beginning.
From beginning.
Slideshow. Not animation. Not
Okay.
animation.
Slideshow.
From beginning.
From present slide or from.
Okay. Okay.
Yes.
Is it okay?
Yes.
Yep.
First of all, I thank Dr. Shantanu for giving me this opportunity to talk before you on this Nagpur. And is it the last lecture, or you are having Manish and Joy after me?
Yeah.
Yes, we have.
Okay, then I will make it fast. This is my homage to my beloved teachers, Professor Saktivel, who expired last month. He was the one who introduced me to echocardiography. And right side you have Dr. Srinivasan, who taught me the basics of echocardiography. These are the textbooks, and I'm happy to inform you that second edition of our textbook of echocardiography is to be published next year. And I expect all the reviews from you first regarding this. So as an outline, Shantanu requested me to talk more on fundamentals rather than the higher aspects of mitral regurgitation and prognostication. So we'll have the causes and an anatomy, assessment of mitral regurgitation, how do you do it echocardiographically, and how to prognosticate, that is most important, whether the patient requires surgery or not. And then some of the cases I will show if there is any time. So mitral regurgitation is defined as an abnormal reversal of blood flow from the left ventricle to the left atrium. It is caused by the disruption of any part of the mitral valve apparatus. So it can be there in the any part. So here you have the mitral regurgitation jet, which is seen here, and this can be due to the valve. If it is due to the valve, it is called as primary. If it is due to the apparatus, subvalvular apparatus or the mitral papillary muscle or the myocardium, then it is called as the secondary mitral regurgitation. So as far as to see the views, this is the American Society of Echocardiographic Society or primary viewing points. This is a long axis view which you take for viewing the mitral valve, and by rotating the transducer 90 degrees you can see the mitral valve in the short axis. And from the apex you can have the apical fourth chamber, and then you can have this. So this is the you can simultaneously switch on the color and you can see the color flow regurgitation both in long axis, short axis and apical fourth chamber. The advantages of 3D is that you can place the line, cutting point line exactly over the center of the mitral valve so that you see the mitral valve in full. So this is the triplane view of the mitral valve from the apex, and you have the mitral valve in end-phase view in the 3D here, which is seen here. This is the view from the left ventricular side, and this is the view from the left atrial side. So this is only possible only with 3D echocardiography, where you can have the surgeon's view. This is called as the surgeon's view, where you see this is the antemitral leaflet, this is the posterior mitral leaflet. You don't see the chordae tendineae attachment, and it is very smooth. And if there is a prolapse, it will be very well seen. So it's very easy to see with 3D echocardiography. And 3D echocardiography also gives you this peculiar view, which, where you can see the subvalvular apparatus, the chordae tendineae, papillary muscles, very beautifully, just like your anatomy. So you can have the transesophageal echocardiography when your echocardiographic window is not okay, and when you are especially considering whether the patient has to be taken for surgery or has to be treated medically. So that is the advantage. Now the problem of 2D echocardiography is that you have to take a minimum of 3 views. This is the two-chamber view, and this is the bicameral view, and this is the long axis view. You have to have all the 3 views to decide whether it is prolapse involving the A2, A1 or P3. It is very difficult. So that is the problem with the 2D echocardiography, and this is totally abolished when you have the 3D echocardiography. Here you see that this is the antemitral leaflet, this is the A1. From the lateral aspect, this is the A1, A2, A3, and from the posterior aspect, this is the PML, P1, P2, P3. And you can see here there is a beautiful A2 segment. This is very difficult with viewing by 2D echocardiography, but when you have a 3D TE, it will be very easy to see this. Now, another thing which is very important is that the mitral valve is a saddle-shaped valve. It is not your regular valve, which is very circular or something like that. It is saddle-shaped. And this software analysis you can have with the Tomtec or with the GE or with the Philips. You have the mitral valve prolapse, which is very well seen here. And prevalence of the various etiologies of mitral regurgitation. This is very important as far as the basic echocardiographer is concerned. See, all of us used to quote only this Western literature. This is the European survey of valvular heart disease reported in 2003 by Lang et al. And you can see here 61% is degenerative and rheumatic forms only 14%. Whereas this is the report from India, reported in Indian Heart Journal 2014 by Dr. Manjunath. And you can see here the rheumatic you can see here the rheumatic. This is a male. There is a male preponderance of mitral regurgitation compared to the female, and it forms 41%. Whereas the mitral valve prolapse and degenerative causes cause only 40%. So this is a great difference between the Western literature and the Indian literature. And then you have to know what is Carpenter's functional classification. The type 1 is normal motion, which can be due to annular dilatation. The mitral regurgitation can be due to annular dilatation, which is more common with ischemic heart disease, or annular deformation, which can happen with the dilated cardiomyopathy, may be due to ischemic cardiomyopathy also, or it may be due to perforation of the leaflets, which may be due to the endocarditis and clefts in the leaflets due to congenital pathology. And the second type is excess motion. So first is normal motion, and second is excess motion. When there is excess motion, you have the myxomatous degeneration, very commonly due to degenerative disease, that is fibroelastic deficiency. And when it involves all the leaflets, then it's called as Barlow's disease. So it can be associated with Marfan syndrome also. It may be due to the elongation of the chordae or rupture chordae, or elongation of the papillary muscle and rupture of the papillary muscle, which may happen with trauma to the heart. And type 3 is restricted motion. When there is a retraction or restricted motion, can be due to thickening of the leaflets, as it happens in rheumatic heart disease, retraction of the leaflets as it happens in carcinoid syndrome, thickening of the chordae due to radiotherapy and other things. Type 3B is restricted motion due to apical displacement or the tethering of the leaflets, which happens with the ischemic heart disease, papillary muscle displacement, which happens with the dilated cardiomyopathy. So these are the types, and this is the fibroelastic deficiency, advanced fibroelastic deficiency, and Barlow syndrome. So assessment of MR most commonly is done by the color flow imaging, but the caveats exist. As there was a similar question to Dr. Nitin, that there can be eccentric jets. So there can cause comparative deficiency in your assessment. So that you have to remember. So the mitral regurgitation can be quantified into mild, moderate, and severe depending upon this. So in mild, you have only mild central jet, whereas in severe form of the mitral regurgitation, you have mitral regurgitation which is more than 50% of the left atrium. And the mitral regurgitation can be early systolic, mid systolic, or late systolic. And common assessments for quantification of the mitral regurgitation also include the vena contracta, effective regurgitant orifice area, and anatomic regurgitant orifice area, which is easily achieved with three-dimensional echocardiography. So this is the three-dimensional echocardiographic structure of the mitral regurgitation. This transverse plane cut is made at the tip or the vena contracta width, and then you can quantify that. You can exactly quantify. You see that you can exactly measure. This is the hemisphere there. This is the vena contracta, and then you have the jet. The narrowest portion of the vena contracta has to be measured So this can be done. And you can measure here, it is 7 millimeter. And even if you place this exactly on the right hand side in the 3D echocardiography, you can planimeter over the regurgitant jet area, and that gives the anatomic regurgitant orifice area, which can be planimetered in 3D. So that is 1.9 square centimeters. If it is more than 1.5, it indicates severe regurgitation. So the associated findings which should be evaluated include left atrial size assessment, left ventricular size assessment, pulmonary artery systolic pressure. Ancillary testing may include cardiac MR, cardiac cath, exercise echocardiography, and elevation of the PASP. So the most important point to differentiate is whether it is primary versus secondary. So this is very important because primary means you have to intervene. Whether it is surgery or intervention, you have to intervene in primary, whereas in secondary it is not so. So here we will go by case-based assessment of the prognosis. Now this patient was referred for assessment. This is a 50-year-old gentleman. The reference was given by the cardiac thoracic surgeon, and he wanted to do mitral valve repair. So he referred this case. So the latest update on this mitral regurgitation is the focused update published very recently in JACC in May 2020 issue. You can go through this. And first point is the primary care provider and clinical cardiologist who does rapid assessment and refers the patient to the imaging expert. So very important. First point, you assess the mitral regurgitation, you identify whether it is severe, then you refer to the imaging expert. And you have to do the primary, secondary, and mixed, and classify the mitral regurgitation according to the Carpenter's classification. And then you can determine the severity. The quantification can be done by anatomic regurgitant orifice area, regurgitant volume, regurgitant fraction, assess the LV and LA size, PA systolic pressure, TR, and pulmonary flow velocity reversal. So these are the common things which can be done. So how do you diagnose whether it is primary or secondary is the main point. So define the leaflet motion and classify whether it is type 1, type 2, type 3A or type 3B. Type 1, when there is abnormal leaflet morphology, it is primary. So when there is normal leaflet morphology, it is secondary. It's very simple. So similarly in mitral valve prolapse, whether it is prolapse or flight, abnormal leaflet morphology, so it is primary. So in this way, you can easily differentiate between the primary and secondary. And another important point is the specific criteria, whether it is mild or severe or in between. In between, you can classify into grade 1, grade 2, grade 3, and grade 4. So all these things you have to do. The mild MR is small, narrow central jet, vena contracta width less than 0.3, and Pisa radius absent or less than 0.3. You have to keep the Nyquist limit in the 30 to 40 centimeters range, and mitral A wave dominant inflow, and soft incomplete jet by the continuous wave Doppler, normal LV and LA size. Whereas in severe, you have the specific criteria: flight leaflet, vena contracta width more than 7 millimeters, Pisa radius more than 1 centimeter, and central large jet more than 50% of the LA area, and pulmonary vein systolic flow reversal and enlarged LV with normal flow. So this is how you have to identify whether it is these are the specific criteria to identify if there is a severe MR. When there is a severe MR, you have to, so each and every method of each and every method of assessment has its own strength and weakness. Most important thing is the valve morphology. The flight leaflets or ruptured papillary muscles can be identified very easily, and then you have to have a team approach. You have to sit with the mitral surgeon, interventional cardiologist, valve expert, and heart failure expert, imaging expert, all have to sit and find together whether the patient requires surgical treatment or a transcatheter treatment. And then after the procedure, the patient has to be followed by the heart failure expert or the clinician. So intervention for primary mitral regurgitation is when the ejection fraction is less than 60. So first thing is whether the patient is symptomatic or asymptomatic. If the patient is symptomatic, you have to assess and find out whether it is a severe mitral regurgitation, whether the patient is a candidate for surgery, then surgery. Whether the patient, if the patient is asymptomatic, you have to assess whether the ejection fraction is less than 60%, not 50%. Remember, in mitral regurgitation, the ejection fraction less than 60% is considered as an indication for surgery. And left ventricular end systolic dimension more than 4 centimeters. So these two are straightaway indications for surgery. Or if these are not present, one or more of the following. One is the atrial fibrillation, new onset atrial fibrillation, resting PASP more than 50, progressive increase in left ventricular end systolic dimension more than 4, and progressive decrease in ejection fraction less than 60. So these are the algorithm to identify the candidate for surgery or intervention. So this is the algorithm in case of secondary mitral regurgitation, whether the patient has moderate or severe secondary MR, revascularization is indicated, then you have to suggest this revascularization by CABG and other things. If not, whether the patient is having ongoing heart failure symptoms, candidate for CRT. Ongoing heart failure symptoms, then you have to subject the patient for CRT. So this is how it goes. The prognosis of mitral regurgitation assessment is, and the most important factors affecting the prognosis in primary MR are the factors related to the left ventricle or left atrium, systolic dysfunction, LV enlargement, and LA enlargement, more than 60 ml per meter square. Clinical features like age, presence or absence of heart failure, functional class, and absence of coronary artery disease. Rhythm, most important thing is atrial fibrillation. And some of the other characters are when there is only one scallop which is involved here, only one scallop involved. So that indicates it's a good candidate for surgical repair. So here only the P2 is involved and in the end-phase view of the mitral valve, and this is a good case for surgery. When there is more than one scallop which is involved, the P2 and P3 are involved here, it's a durable surgical repair is possible. But when there is a calcification, severe calcification, then it is not a candidate for surgery or intervention. So this is the ideal anatomy and challenging pathoanatomies which are shown here, and the indication for surgery. The other method is the transcatheter edge-to-edge clip mitral valve repair is being done for secondary MR or patients with primary MR who are poor surgical candidates. This is being done in Western countries. This is not yet approved in India. And these are the common indications. And for primary MR, the grasping zone should be more than 10 millimeters and fly width less than 15 millimeters. So these are some of the criteria which you have to consider for the clip. Same thing, the single scallop prolapse is a good candidate, whereas multiple scallops involvement here P1 and P3 may be a difficult case, and then there is a calcification that is considered as a contraindication. So these are some of the favorable and unfavorable characters of the this thing. And problems with the prognosis assessment is that as the LV dilates due to the mitral regurgitation, LV wall stress increases. Incipient and irreversible myocardial dysfunction may occur with the long-standing LV volume overload. So this is and ejection fraction is not a good indicator of survival in these patients. So we come to the original case. This is the case of rheumatic mitral regurgitation. As you know, rheumatic mitral regurgitation, there can be caudal shortening, feathering, pulling, and prevent proper coaptation. And caudal lengthening, there can be caudal lengthening, caudal disruption, It can be minor or major. There can be a thick valve prolapse, either AML or PML. Superadded infective endocarditis of the leaflets can happen, and with perforation of the leaflets, annular dilatation and fibrosis and posteromedial and anterolateral papillary muscles can occur in these patients. So here, most important thing in measuring the end systolic dimension is that you have to use the anatomic M mode. Very, very important, simple procedure, which is often forgotten in the echo lab. You don't use the regular M mode. Yeah, regular M mode cuts like this, and it will be not perpendicular to the interventricular septum and LV posterior wall. You have to use the anatomic M mode, where you have you can take the end systolic measurement whether from M mode, or you can measure it from the two-dimensional echocardiography. And always use the three-dimensional echocardiography whenever it's available for calculating the ejection fraction, which is here around 57%. And the most important problem here is that when you do the ejection fraction calculation, never use the M mode echocardiography. Use two-dimensional echocardiography, Simpson method, or three-dimensional echocardiography. And this is the triplane view of the same patient. This is the mitral regurgitation jet seen in biplane view. And PISA radius, as Dr. Nitin was emphasizing, you can see you have to reduce the Nyquist limit to 33 centimeters and then take the PISA radius. As you see here, this is the biplane MR. The PISA is not exact hemisphere. That you have to understand. So that is the drawback of this PISA measurement. And PISA radius here is 0.6 in this case. And similarly, you can measure the vena contracta width. The vena contracta width can be measured. It is 5 millimeters here. The other important thing is that you can calculate the anatomic regurgitant orifice area, which is measured here. Anatomic orifice area is 1.1 cm square. More than 1.5 is considered to be severe MR. The most important thing is you can assess the mitral valve by three-dimensional echocardiography. The first thing you have to align the views and set landmarks. There are only 5 landmarks: lateral mitral and medial mitral annulus, and then the coaptation point, aortic anterior wall. So they have to be marked, and clearly it has been tracked, and you have the presentations. And 3D echocardiography usually gives you all the measurements which you want for the surgeon. And you can see here the tenting height is more than 1.1 centimeter. Anything more than 1 centimeter indicates the patient requires surgery. And incidentally, the E by E prime here is 16. You can see here 16. Another advantage is that when you have ejection fraction always remains good till the last, and it doesn't correlate with the mortality. Always the global longitudinal strain correlates with the morphology better than, mortality rate better than ejection fraction. Adding GLS criteria gives better understanding and better results to your assessment. The global, this is the point which I was mentioning. This is the global longitudinal strain, and this is the circumferential strain, and this is the ejection fraction. So its ejection fraction remains good up to prolonged periods, during which the global longitudinal strain reduces. So the early detection of deterioration can be done by assessment of the global longitudinal strain. So global longitudinal strain can be either assessed by two-dimensional echocardiography. This is the two-dimensional echocardiography which is used for this technique. You can see here the measurement in long axis apical 3-chamber, apical 4-chamber, apical 2-chamber, and then you have the bullseye plot. And calculation of the 3D global longitudinal strain is possible now. And this has the standard procedure of the 3D echocardiographic calculation of the ejection fraction first, and then the LV mass, and then marking of the region of interest, and then finally go for the strain. The advantages of longitudinal strain calculation by 3D is that you get a dynamic map. This bullseye map is dynamic, and you have this. You can simultaneously calculate in single beat longitudinal strain, circumferential strain, area strain, radial strain, and the twist also. So all these measurements are dynamic, and longitudinal strain less than minus 18 is abnormal, circumferential strain less than minus 20 is abnormal, radial strain less than 40 is abnormal, and twist degrees less than 6 degrees is abnormal. So these things are possible. And the advantages of 3D strain is that out of plane motion speckles are not there. See, in 2D you are holding in one direction, you are recording apical 3 chamber in one view, apical 2 chamber view in another view, and apical 4 chamber view in a different beat. And the speckles may move in different directions away from the your sector images. So this is called as out of plane motion, which is avoided in 3D strain calculation. And you have the added advantage of having the area strain, and acquisition is one apical 6 beat full volume, whereas here you have to have a 3D, I mean 3 different apical 2D views from 3 different cardiac cycles. And I have shown you the diastolic abnormalities in these patients. Here the mitral flow, this is the normal mitral flow, the tissue Doppler, and this is the apical rotation, this is the basal rotation, and this is the LA strain. LA strain should be more than plus 40, around plus 40. And with abnormal relaxation, the LA strain is around plus 30. With the pseudo normalization is plus 20, and with the restriction of the diastolic flow, it will be around plus 10. So the LA volume, I mean the LA strain is going to be spoken in detail by Dr. Vijay. So I will not elaborate on that. So this is the advantage which I was telling you. This is the cube which is followed in 3D, whereas in 2D a single dot is measured for calculating this strain. So this is the normal myocardial strain values which I was telling you, and the LA strain, I think there is a separate lecture, but I will show you the details of the 3D LA strain, which is very easy now. This is the recent article which has emphasized on the LA strain in normal individuals, delayed relaxation, grade 3 diastolic dysfunction, that is a pseudo-normal, and then grade 4 diastolic dysfunction, that is the so 3D LA strain calculation is very easy. You just mark this mitral valve center in apical 4 chamber, 2 chamber, and apical long axis, and then set the end diastolic point, in systolic point, pre-atrial contraction point, and then you have the graph. Very easy, very, very simple in 3D. And you have the LA volume, maximal LA volume here in this patient 85 ml. And LA strain, you can see here, LA strain is 17%. Unlike the normal patient who has 40, the LA strain is 17%, indicating that the patient requires surgery. So this is the LA longitudinal strain, which is plus. So this is the, in short, some of the points which I was asked to speak about. Now, if there is some time, I will show you some of the cases, other cases. Dr. Shantanu sir, do you have case time, or we'll close this?
I think we'll have to, if you don't mind, we have to close because we are slightly behind schedule. But I think you made a very good comprehensive overview of mitral
regurgitation. So this is one case. The patient came with severe chest pain. I think I am off the sharing screen.
Yeah, I think if you don't mind,
just this case.
Yeah,
This
you
is
want to show
the
one case?
patient with. Is this
Quickly, yeah.
seen?
Yeah, yeah. You
Is
can
my
go ahead.
laptop seen?
Yes.
Sharing is there.
Yes, we can see you.
This is the patient with acute inferior wall infarction and mitral regurgitation. And you can see here the mitral regurgitation and the LV strain in this patient. You can see here. This is the LV strain. The inferior septum, the inferior wall, infralateral wall. There is blue color indicating there is a reduction in the strain in these areas. So this patient has mitral regurgitation due to involvement of the papillary muscle in this case. One another case of ischemic cardiomyopathy I will show, and then we will close with that. This is one friend of mine who is a leading businessman who had anterior MI, extensive anterior MI. He had mitral regurgitation. You can see here this severe mitral regurgitation. Ejection fraction was only 20% in this patient. And we thought of subjecting this patient for CRT, but before that the patient expired. So this is the LV strain curve in this patient. You can see here. This is a strain curve, which shows the marked reduction of the global longitudinal strain in this patient. So with that 2-3 cases of ischemic MR, I will finish my talk. And if there are any questions, I will be pleased to answer. Thank you, Dr. Shantanu, for the time.
Thank you so much, Dr. Amuthan. The very nice cases, a nice overview of mitral regurgitation. I think we will have to move ahead because of shortage of time, and we have two topics to be covered. Both are very important. The first is cardio-oncology, and Manish is there. Yeah, I can see Manish. Yeah, Manish can share his slides, please. And then we have left atrial strain by Dr. Bijoy Khandiria. So Manish, can you share the slides, please?
Just a minute.
Yeah.
Okay, I think my slides are there.
Yes.
Okay. So good evening, everyone. First of all, I thank Shantanu and Dr. Fulwani for inviting me to participate in this meeting. I have been listening to all the great presentations since yesterday by all the experts, and it is definitely a great honor for me to speak at this meeting. So the topic given to me is in the form of a question. Is it necessary to look at the heart in a patient receiving chemotherapy? And I would like to begin with this case. This was a 42 years old lady, hypothyroid, no hypertension or diabetes, no cardiac illness, normal LVEF to begin with. She had carcinoma breast, for which which was HER2 negative. So she was planned for doxorubicin based chemotherapy, and she did receive the treatment, but after 4 months, she presented with rapidly worsening dyspnea. And this was her echo at that time. As we can see, she has global hypokinesia here, significant global hypokinesia and LV systolic dysfunction. She obviously had congestive heart failure. So now, even if she gets cured of her carcinoma, she is going to have challenges as far as her health is concerned throughout her life because of this LV systolic dysfunction. And this can potentially cut short her survival also, just like the cancer could have. So this is the kind of challenge that many of these patients who are receiving some of these cancer therapies face. And this is not rare, occurs quite commonly. This is a large series of more than 2,500 patients receiving anthracycline-based chemotherapy. And it was shown that nearly 1/10 of all the individuals developed cardiotoxicity, which was defined as at least 10 percentage point reduction in LVF. So it was not just mild reduction, it was substantial reduction in LVF, occurred in 10% cases. In patients who are receiving trastuzumab, the percentage reported has been much higher, especially if the patients are also receiving anthracyclines simultaneously, or if they have received anthracyclines in past and now are receiving trastuzumab. So in this particular study from Dr. Tom Marwick's group, 30% patients developed cardiotoxicity at 1 year. Now, cardiac dysfunction is not the only form of cardiac toxicity that can occur because of these cancer drugs. There are other forms of cardiotoxicities also, like the patients can have myocardial ischemia, they can have pericarditis, they can have thrombophilia, arrhythmias, or accelerated hypertension. And these are the common agents that cause these various forms of cardiac complications. However, from clinical point of view, the most common complication remains LV systolic dysfunction for two reasons. One is that the agents that we use the agents that cause LV systolic dysfunction are used quite frequently in the treatment of various cancers like anthracyclines and trastuzumab, which are used for breast cancer, anthracyclines also for hematological malignancies, and then these tyrosine kinase inhibitors, which are used for GI and renal cell cancers. So because of the frequent use of these agents, and also because of high incidence of heart failure with these agents, LV systolic dysfunction remains the dominant form of complication that we encounter secondary to cancer chemotherapy. And this is what I'm going to talk about during my presentation. So the myocardial toxicity that occurs because of cancer drugs can be broadly categorized into two types. Type 1 is the one which occurs typically with agents like doxorubicin or alkylating agents. This is characterized by oxygen free radical mediated injury to myocytes, leads to myocyte necrosis, because of which it is largely irreversible and it is dose dependent. On the other hand, type 2 toxicity occurs mainly with agents like trastuzumab. There's no myocardial necrosis here, just myocardial dysfunction, because of which it is mostly reversible. But the problem here is that it's totally unpredictable and it's not related to dose. It is important to understand these differences because these differences determine how we want to follow up these patients when we have to do imaging or their monitoring of cardiac function. So when patients receive anthracycline-based chemotherapy, the one peculiar feature with this agent is that myocardial toxicity can manifest long after the treatment with this agent is completed. So it's not necessary the patient will present only during the treatment period. In fact, when we use anthracyclines for carcinoma breast, the typical duration of treatment is only 2 to 3 months. But if you look at this same study which I showed you in the beginning, median time to interval was 3.5 months after the completion of chemotherapy. And therefore, it becomes important to follow up these patients even after their chemotherapy has been completed. But good thing was that 98% of all cases occurred within 1 year. So 1 year follow-up is sufficient. Further follow-up is not necessary unless the patient becomes symptomatic, because occurrence of cardiotoxicity after 1 year is quite rare. This is in contrast to cardiotoxicity mediated by trastuzumab, which occurs only during the treatment. So once the treatment is completed, we don't have to follow them up for development of cardiotoxicity. But what happens when the patients develop cardiotoxicity? I mentioned that anthracycline mediated cardiotoxicity is largely irreversible, but it does not mean that it does not recover at all. So we have this study of 201 patients who developed cardiotoxicity and their EF dropped to less than 45%. The patients were put on enalapril and whenever possible carvedilol also, and they were followed up for 3 years. The study showed that in 40% patients, LVEF recovered to above 50% after treatment. In 60% cases, either there was no response or partial response only. In other studies, it has been shown that the response rate to complete recovery is much lower. Only 10 to 15% patients have complete recovery, and 85 to 90% patients either do not recover or have only partial recovery. So substantial amount of myocardial dysfunction persists in these patients even after treatment. But the most important information from this study is contained in this slide. So this slide shows response rate as the function of time duration since the completion of treatment. So if you look at this, when the cardiotoxicity occurred early, diagnosed early, and was treated early, there was very good response rate. Nearly 2/3 patients recovered if they were treated within 1 to 2 months of completion of cancer chemotherapy, and no patient recovered after 6 months. So this clearly tells us that in patients who are receiving anthracycline containing chemotherapy, it is very important to diagnose cardiotoxicity early and treat it in a timely manner. So how do we define myocardial toxicity due to these cancer drugs? There's a term used for this called CTRCD, which is cancer therapy related cardiac dysfunction. So there are various definitions for this, but the one which is most commonly used is the one which I have mentioned here. It was put forth by the CRED, which stands for Cardiac Review and Evaluation Committee, in 2002. So if there has been LVEF drop of at least 5 points to less than 55% with clinical features of heart failure, or if there is drop of LVEF by at least 10 points to less than 55% without symptoms of heart failure, then we call it CTRCD. So clearly the detection of CTRCD so far has been based on recognition of drop in LVEF. However, there are some very important challenges as far as LVEF is used for detection of cardiac dysfunction. And the most important challenge which we overlook when we are using LVEF in our day-to-day practice is that LVEF is quite variable when we use 2D echo. In fact, 2D echo based estimation of LVEF is not accurate. And this was elegantly shown by this study from Dr. Tom Arwick's group, where 56 patients were included. They looked at their they echoed at 5 different time points: baseline, 3 months, 6 months, 9 months, and 12 months. And the patients whose GLS on all these 5 points was above minus 16%, which means their GLS remained stable. Only they were included. So therefore, any change in EF was not likely to represent LV systolic dysfunction. It represented only the only the variability in LVEF estimation. So what we found, there are intra-observer variability, inter-observer variability, and inter-observer test-retest variability is mentioned here. They looked at 6 different techniques: biplane Simpsons, without contrast, with contrast, triplane method, without contrast, with contrast, 3D without contrast, and with contrast. Now look at this. Here, this inter-observer test-retest variability is actually most relevant for clinical practice. This means that the patient comes for echo today, and then he or she comes back for another echo sometime later, and that echo has been done by some other person. So that will include both inter-observer and test-retest variability, and this is what happens in clinical practice also. So this is the most relevant parameter for us. And now look at this. If we are looking at this, the variability is large enough to preclude accurate detection of change in LVA of anything less than 13 percentage point, absolute points. So if the change in EF is less than 13 points, so 53 to 40, it can just be because of measurement variability, not necessarily because of LV systolic dysfunction. And even for the same observer looking at the same images at 2 different time points, so no same study analyzed by the same observer, the variability was significant, and minimum detectable difference in LVEF was 9 points. So up to 10% change in LVEF can be just fallacious because of measurement variability and not necessarily because of drop in LV systolic function. And this is a very, very big limitation. In comparison, 3D echo was much more accurate, and the measurement variability range in the range of around 6%. So we can more accurately detect cardiac dysfunction if we are using 3D echo. But 3D has its own challenges. We need to have good image quality, good volume rate, and all those things to be able to do proper 3D echo estimation of LV, EF, and LV volumes. So in this context, global longitudinal strain becomes a very important parameter. It has two main advantages. One is that, as we have seen in many diseases, it is a more sensitive marker of LV systolic dysfunction. It can detect impairment of LV systolic function much before there is a drop in LVEF. And just like so many other diseases, even in cardiac toxicity resulting from cancer drugs, it progresses through different phases. There's initial subclinical dysfunction, which we can detect using GLS, and then there's overdrop in LVF, and the patient develops symptoms. So here is a study which assessed value of GLS for early detection of cardiac dysfunction in these patients. So 81 patients receiving cancer chemotherapy, 30% of them developed cardiotoxicity at 1 year. So the investigators, Dr. Tom Arwick's group, they looked at 6 echo which was done at 6 months and various echo parameters to assess their prognostic accuracy for predicting LV systolic dysfunction at 1 year. And what they found, the delta GLS was the strongest predictor of cardiotoxicity at 1 year. If there was a drop in GLS by 11%, that is relative reduction, more than this had 65% sensitivity and 94% specificity for predicting cardiac dysfunction at 1 year. However, looking at variability in measurement, they proposed that more than 15% relative reduction should be considered to be significant. Less than 8% should mean that there is no significant change in LV systolic function. So if we assume that normal baseline LV GLS is around 19 to 20%, 15% relative reduction would mean fall of roughly 2.7 to 3% in GLS value. And if that much fall occurs, then we should consider that there is significant subclinical left ventricular systolic dysfunction. But now, as I talked about variability in EF, the question comes, is GLS reproducible enough to detect such small variations? And this question was addressed again by Dr. Tom Arwick's group, and this paper is not yet published. It is still in press in Heart. In this study, they looked at 60 subjects, 30 controls, 15 patients with breast cancer who developed cardiac dysfunction, and 15 another patient with breast cancer who did not develop cardiac dysfunction. And they looked at MRI, echo, different parameters. And 3 scans at 3 different time points were included, analyzed, and temporal variability in the measurements was looked at, and which is shown here, displayed here in this chart. These different colors represent different groups: healthy participants, patients with without cardiac dysfunction, and with cardiac dysfunction. Here we have 2D EF, 3D EF, echo GLS, echo GCS, CMR LVF, CMR GCS, and CMR GLS. Now look at this. Out of all these parameters, only 3, that is 3D EF, echo GLS, and CMR LVF, could clearly separate cardiac dysfunction from the other 2 categories. So which meant that only these 3 modalities are accurate enough for detection of cardiac dysfunction. And if you look at minimum detectable difference, GLS had minimum detection difference of 2.7, which is quite small. And this is exactly what we saw in the previous study also, which suggested that any reduction of GLS of more magnitude than this should indicate significant LV systolic dysfunction. So this clearly tells us that GLS is very accurate for following up or monitoring these patients who are receiving cardiotoxic chemotherapy and in whom we are worried about development of cardiac dysfunction. And the paper also recommended GLS as the most suitable parameter because of the ease of application, easy availability, and high degree of accuracy. Now, accuracy also depends on experience, and that applies to GLS also. This is a slide from the Sukur study. I'll come to this study later. This is a randomized study looking at value of strain in managing patients who are receiving chemotherapy. So here, Dr. Tom Arwick and his group, they looked at variability of GLS according to the experience level of operators. So 4 groups: no experience, limited experience, intermediate experience, and high experience. As we can see, the minimum difference, standard deviation, and variability all became smaller and smaller as the experience increased. But very important point to note here is that even those who did not have any previous experience of GLS measurement, for them also minimum difference, mean minimum difference was hardly 1.5%. So this shows the power of GLS estimation, that even basic training is good enough to provide very accurate estimation of GLS, even by those who have limited experience in its use. So now that we know how to detect cardiac dysfunction and how to detect it early, what we can do about it. So here we have two randomized studies. In the first one, all patients who had troponin rise secondary to chemotherapy were treated with enalapril. And in this study, all patients who were receiving potentially cardiotoxic chemotherapy were treated with a combination of enalapril and carvedilol. In both these trials, there was significant attenuation of cardiac dysfunction secondary to chemotherapy in patients who were treated with these heart failure therapies. However, these were not based on EF or GLS. In this, the trigger was troponin rise, and here every patient was put on treatment regardless at the baseline itself. Now we have more data on this, and this study here shows the role of GLS for triggering treatment of the patients. So in this, 159 patients receiving chemotherapy were included. 50 developed a fall of GLS by minus 11% or more at 6 months. Of these, 20 were treated with beta blockers and 28 were not treated with beta blockers. However, this was not a randomized study. The treatment choice was based on the discretion of the treating clinicians. So here we cannot draw much inference, but still what it showed was that we look at LVEF here and GLS here. The patients who did not receive beta blocker, in them EF continued to drop up to 1 year. And GLS dropped at 6 months and became almost stable at 1 year. But those who received beta blocker, in them both EF and GLS increased significantly when at 1 year. And I have a case here showing something similar. This was a 45-year-old lady who was diagnosed with invasive ductal carcinoma of breast. She was treated by with epirubicin at some other center for 3 months, and then she came to our center. Here it was planned that she would be treated with Herceptin, which is trastuzumab. She was sent to us for baseline evaluation. Her echo at that time was absolutely normal, EF 61%, GLS minus 22.2%. So everything was good. She was put on Herceptin, and 3 months later when she came, her EF was again normal, 60%, no change, but her GLS had dropped significantly. It was now minus 18.7%. And if we compare from the baseline, there was almost 16% reduction in the GLS, which is substantial. So we put the patient on beta blocker, and then she was under regular follow-up. At 6 months, her echo again showed same EF, good EF. GLS became stable. In fact, it increased slightly. And after completion of therapy, GLS was absolutely normal. EF always remained normal. So here the patient was receiving trastuzumab. So one could say that trastuzumab mediated cardiotoxicity is anyways reversible. So what's the big deal? But the advantage of using beta blocker here was that it prevented further drop in EF, and it prevented temporary discontinuation of therapy, which many times we have to do if EF drops significantly. However, other trials have not shown such salutary benefits of heart failure therapy in patients who are receiving cancer chemotherapy. This is a review, extensive review published just 3 days back on the ACC website on July 30. It summarizes all the trials that have used various cardioprotective therapies in patients who are receiving anthracyclines and trastuzumab type agents, and concludes that while there is evidence to suggest that carvedilol and enalapril are beneficial, the evidence is weak only, and we really don't know how best to treat these patients. But intuitively, one could imagine that if there is a patient who is developing LV systolic dysfunction, it would make sense to treat such a patient with these agents, beta blockers and ACE inhibitors, because there's nothing else that we can do to prevent further deterioration apart from limiting the dose and using some or possibly modifying the regime if that is an option. And therefore, the guidelines currently recommend routine monitoring in these patients. There are different guideline recommendations from different societies. The ASC and EACVI jointly published this document 6 years back. As per this document, any patient who is receiving agents that can cause type 1 toxicity like anthracyclines, we need to do echo at baseline, look at GLS and troponins. If everything is normal, then the treatment is given. And after that, we have to look at all these parameters only at completion of therapy, because the treatment duration is short with these agents. And then 6 months later, this 6-month follow-up is needed, because as I showed you in the beginning, these patients tend to develop cardiotoxicity even after completion of therapy. On the other hand, if the patient is receiving an agent like trastuzumab, then because the toxicity is unpredictable, we have to do echo every 3 months, echo and troponins. Treatment with these agents is typically for a year, so we will keep doing echo every 3 months, but no further follow-up is needed once the therapy is over. On the other hand, if the patients are receiving both agents, either sequential or concurrent, then we have to use a hybrid approach in which we do echo every 3 months and then 6 months after the completion of treatment. Some other investigators have provided more elaborate recommendations, like this one from Mayo Clinic, in which the risk scoring system was proposed, which looks at the type of chemotherapy that you are using, you score accordingly. And then various patient-related risk factors like hypertension, diabetes, pre-existing cardiac illness, prior anthracycline use, age, and likewise. And then you calculate a total score. And the patients who appear to be at very high cardiotoxicity risk, this algorithm recommends echo before every cycle, and all patients should be put on cardio protective therapy right from the beginning. So now this may appear to be quite aggressive, especially because, as I told, that the overall evidence is still weak in favor of routine use of these cardioprotective therapies. Therefore, this could appear to be too aggressive an approach, but there are variabilities and variations and different protocols. The final answers to this question will come from this study. This is the first randomized trial, the SUKUR trial, which I briefly mentioned about during the presentation. This is a trial being led by Dr. Tom Arwick. In this, 320 patients who were receiving potentially cardiotoxic chemotherapy were included, and they were randomized to 2 groups. In one group, EF was monitored, and if there was significant drop in EF, they were put on cardioprotective therapy. In the other group, GLS was monitored, and if there was significant drop in GLS, they were put on cardioprotective therapy. And then after that, they were followed up for 3 years to look for the final EF and overall incidence of CT-RCD. So 1 year follow-up of these patients is completed. Recruitment already completed, and 1 year follow-up is also completed. I am not in a position to share the results yet, because I believe the results will be disclosed in the upcoming ESC meeting or maybe later in one of the papers. But once the results and final results of 3-year follow-up are published, we'll have better understanding how frequent the monitoring is to be done, whether GLS based monitoring is really useful, and whether cardioprotective therapy really works. So until then, I would summarize: the myocardial dysfunction is a dreaded complication of certain cancer chemotherapeutic agents. Early detection and timely action are helpful in prevention and recovery of overt cardiac dysfunction in these patients. GLS is currently the most useful echocardiographic parameter for monitoring cardiac function in these patients. How useful it is in terms of overall prevention of cancer toxicity, that only time will tell. Thank you.
Thank you, Manish. Thank you so much for having such an important topic. There are a couple of questions. Whether to add beta blocker along with chemotherapy from the onset of treatment, is it advisable?
See, as some investigators have said that uh, what is the harm in adding beta blockers or even ACE inhibitors also right from the beginning in these patients? They will reduce the risk of complications, if any. But the challenge is that many of these patients, they develop nausea, vomiting because of the effect of the drugs, and they develop hypotension, tachycardia. So their use of these drugs becomes challenging, and reaching target dose becomes challenging. And in many of these patients who are not going to develop cardiotoxicity, why to expose them to this risk? So routine use is not recommended by the guidelines at present.
And how frequently do you suggest to do an echo for a patient who is undergoing chemotherapy, of course with cardiotoxic drugs?
Yeah, so as I mentioned, if the patient is receiving agents that cause type 1 cardiotoxicity like anthracyclines or alkylating agents, then we do it at the baseline. And after completion of therapy, if the treatment duration is short, 2 months to 3 months, and provided the maximum recommended dose is not being exceeded, after that we have to repeat echo at 6 months. But if the maximum dose, which is recommended as 240 milligram per meter square for doxorubicin or equivalent, is being exceeded, then for each additional 50 milligram dose, we have to repeat echo. For trastuzumab type therapies, we do it every 3 months. And if there is a problem, then after that, we do it before every cycle. And I would suggest that for every patient, whenever we are doing echo, we do echo before the drug is given and repeat troponin within 24 hours after chemotherapy. So we combine both troponin and LVEF and GLS for monitoring these patients.
Right.
In one of your slides, you shared that a patient who is having high risk of developing cardiotoxicity, you give beta blockers, carvedilol, and statin also. So,
Yeah.
exactly.
Yeah. I forgot to mention that there are many studies which have used statins also and have shown benefit. So statins are hemodynamically neutral, so they can be used in most of the patients. So I would suggest that patients who are at risk of having cardiotoxicity, we may use them more regularly.
Dr. Mohan, your thoughts about usage
So
of
I have three different things to say. One point blank question. I have a doctor who has to undergo chemotherapy, ejection fraction 46%, strain is 16%. What would be my recommendation? Husband, wife, both are doctors. Chemotherapy has to be done. What should I suggest?
Sir, what form of chemotherapy the patient is going to receive?
Yeah, that is important, but it is a hybrid kind of thing. A drug of four drug combination. None of them is anthracycline like looking thing, as far as I could remember. But
Okay,
the issue is, we always talk of trastuzumab and anthracycline, nothing else, or doxorubicin, anthracycline and its sisters, and we don't talk anything beyond that. What about those monoclonal antibodies, tyrosine kinase inhibitors, and other things? There are hundreds of drugs. We talk about two drugs.
No, sir. I mentioned that in the type 2 toxicity is caused by agents like trastuzumab and tyrosine kinase inhibitors like sunitinib and lepitinib and all those agents. And anthracyclines, alkylating agents, and taxanes, they cause type 1 toxicity. So they are grouped together. So in a patient who's who's going to receive potentially cardiotoxic chemotherapy and has pre-existing LV systolic dysfunction, then we have to do a risk benefit analysis. If there's no other option available, there's no alternate regime, then I would still go ahead with the chemotherapy, but I would be very aggressive in monitoring. Before every cardiac cycle, I would like to monitor the EF and GLS, and if there is further drop in EF, then in that patient we'll have to hold off the chemotherapy.
But if nothing drops, you are happy with 46%, 16%, keep giving?
Yes,
and
sir.
drop is negative?
Yes, sir. Yes.
Then continue.
All right. I could accept that. My problem is I get large number of such patients. I don't know the answer to the question. My number 2 point, don't you think both GLS and ejection fraction are not really what you call robust, reproducible parameters in real world? Forget about some people talking about it. We know machine to machine variation. We know the quality of it. The moment quality of imaging goes down, the strain can be. I have a Philips system here. I yesterday did a case. I got a blood ejection fraction here, the GLS 11% here. I saw his report I had done 1 month back with the GE machine was 16%. How do I believe? I am the same person doing it. So I know there are a lot of issues.
So there are a lot of issues. There's no doubt about it. But whatever we have at present, this is the best that we can do.
So do you think there would be one agent, maybe high sensitive troponin, or maybe a anti-proBNP plus troponin, or some ratio says, okay, this is there, that's cardiotoxicity. Forget about EF, forget about GLS.
So there are many studies that,
or maybe just do a cardiac MRI, do the T1 mapping, and the T1 says 1,590, 1,059 or more. Well, do you have to actually stop the drug here? What do you say?
So, sir, yeah. So my answer to this is that just as we have been discussing for AR, MR, everything, we have to look at many parameters in toto, and we have to see which direction most of the parameters are moving. So as I mentioned in the last slide also, we have to do troponin in every patient. We have to look at EF and GLS also. If there is a patient who's got significant rise in troponin, then I'll be very concerned. If both EF and both GLS and troponin show abnormality, definite myocardial injury has occurred. If only troponin has gone up slightly, GLS remains stable, then I'll be careful. I'll monitor that patient, but I would still not label that as definite cardiac injury, cardiac dysfunction. Regarding MRA itself has a lot of variability, sir. So even though, as I showed, it has accuracy, which is MRA is considered gold standard for LVEF and volume estimation, but we know that also depends a lot on expertise, and we get fallacious reports from MRI also. So we have to take everything into consideration. There's no single
I
short
understand
answer.
that we don't have a solution to this problem. What I'm saying is, when I listen to these lectures and I listen to Dr. Plana's lecture, I have seen a lot, but when I practice cardio-oncology in real world, it is very different, and I am not able. Trop is usually negative. I mean, if you don't talk about high sensitive trop, the kind of trop we are doing is usually negative. I find strain has gone down by 3%. I'm holding my head. Should I stop the medicines, or I should say, okay, have another cycle and come back to me? I don't know.
I think the Sakkar trial will give us a good information, and I think the results are supposed to be out at this ASC or ACC. I think that's what they are.
ESC.
ESC. Yeah.
Even then, it will apply to people who know how to do both these things perfectly.
Very true. That is the point.
That is true, sir.
You don't have AI which says that, look, okay. And how many of these people, because of SCAR and other things, would have good quality echo windows?
Yeah, so I think the point here is very much valid. But the point is you have to do an echo before giving an chemotherapeutic agent which is cardiotoxic. Lot of places it is not being done. And what Manish is telling is that 0 baseline, 3 months, 6 months, 1 year. I think these are the things which we have to percolate to people to get it done. And there is something.
No, that is
the point.
Is a good thing.
Right. Because GLS people are not doing.
Oncologists, but you know what we don't discuss is practical issues.
Yeah.
Where I'm sitting, and I told you 20 feet away from there is echo, and every single day 2-3 patients post breast cancer come. It is so difficult to get a window post breast cancer. If they have got a left mastectomy, I can assure you, you can't get a window that easily. You can try anything. You're talking about GLS, you won't get anything.
So we do a lot of echoes in patients who have undergone left side mastectomy, and it is usually a challenge getting good windows, no doubt about that. But I've seen that still we are able to get decent images for GLS estimation.
Yeah, I think I go for subcostal and get it done. Yeah, even subcostal.
I have another question to you. If there is a foreshortening, is the GLS correct?
No.
I know what you are saying.
No.
So
Dr. Chandra,
my difficulty is at the apex or below, I'm not getting this thing, but I move further, I get a good fortune looking thing. Should I rely on that GLS?
No, sir. No.
So I'm telling you that this is a real issue actually.
Very
This,
true,
this
very
is
true,
a
very
big issue.
acceptable. Yeah, yeah. So I think can we move ahead, Manish? Thank you so much for making our
Most welcome.
important points. And I think we are at the fag end of this Echo Nagpur, and we have important topic of left atrial strain, and it is by Dr. Bijoy Khanderi, and Bijoy has pre-recorded it because he is unable to join, and it is on left atrial strain. So if you can allow us to start the presentation.
Yeah, sure.
Yeah. Start. Yeah.
For having me
Loudly,
and making this accommodation. I wish I was there, but a pesky virus has made sure that we stay where we are. So again, my apologies that it doesn't seem and feel like the same thing, but we will try our best. So I am going to share with you a little bit about left atrial strain, give you some examples on why left atrial strain has become important, and uh, also highlight some of the value in the diseases that I'm going to share with. And I don't have any conflicts for this particular presentation. We know very well that left atrium plays a very important role in modulation of left ventricular filling. And left atrial size for many years, even in the time when M-mode echocardiography was there, was utilized as an indicator for cardiovascular disease, and was also utilized more commonly in atrial fibrillation for adverse outcomes. With evolution of technology, with evolution of knowledge that we have gained, we realize that knowing the deformation of the left atrium makes it more specific with respect to looking at cardiovascular diseases and looking at outcomes from cardiovascular diseases. And a lot of studies have been done on this, and I shall share some references at the end of this presentation for you to peruse at your leisure. We look at strain, and we can divide strain into the phases of cardiac cycle, the reservoir phase, the conduit phase, and the contractile phase. But for clinical purposes and for day-to-day utilization, we just use a global number. So here is a schematic showing the ECG, showing what is happening to the heart and what these phases are, the phasic functions, the contractile phase, the reservoir phase. So contractile phase is when the ventricle is contracting, reservoir is when the atrium is filling, and conduit is when everything is closed, and but the atrium, the mitral valve is starting to open and is going to start helping fill the left ventricle. So here are the three phases to remember, but we will focus on the global strain. And I thought that rather than go into all the details of it, let me just share with you a few cases and highlight what happens in each one of these diseases, pretty common diseases that we look at and we use in our clinical practice. So the first case is that of atrial fibrillation, and just take this particular case and apply it to any patient with atrial fibrillation that you would be encountering or you would be dealing. What we know in atrial fibrillation is that the contractile function is absent. We know that the reservoir and conduit function is reduced, and because there is fibrosis of the wall of the left atrium, and because the left atrium is stiff, these then help, or these contribute to the lower values of the reservoir and conduit function, and also for the absence of the contractile function. If you take the same patient who is in atrial fibrillation, and whether you look at that patient post cardioversion, whether it is electrical cardioversion or mechanical cardioversion, or when you look at it more commonly in our practice following an ablation procedure, what we find is that the strain values improve, and this has been shown by several investigators, a lot of them from Europe, that they improve in as much as 4 weeks or even less than that. And clearly, if the values were better pre-cardioversion, we now know again from European investigators that their likelihood of remaining in normal sinus rhythm or remaining following a procedure in normal sinus rhythm is more likely than if the strains were markedly reduced. And I think for all of you, it becomes pretty clear that if the left atrium is terribly fibrosed, the patient is going to not do well from atrial fibrillation conversion or ablation versus if the left atrium is less fibrosed. So these are some facts that we know that I collated for you. And I thought I'll show you this patient. So this is a 73-year-old male who has chronic mitral regurgitation and also has atrial fibrillation. On the left-hand side, on the parasternal long axis view, you can see that the global left ventricular systolic function, or the ejection fraction, is normal. You can also see that the right ventricle looks fairly normal. There is a trivial pericardial effusion, and one sees that the left atrium in size is larger than the size of the aorta. The mitral valve is thick, and the aortic valve has some sclerosis. On the right-hand side, you see the four-chamber view, and you clearly see that both atria are very large. Right ventricular systolic function is normal, and left ventricular systolic function is normal. When we calculated the left atrial volume index, it was 55 milliliters per meter square. And you know that it is way, way, way higher than the upper limits of normal, which would be in the 30s in this particular individual. So this patient clearly has biatrial enlargement, well-preserved global systolic function by ejection fraction, well-preserved right ventricular systolic function, and not terrible looking valves. When we do the global longitudinal strain, which again, all of you are very familiar and very comfortable with, you see that the global longitudinal strain in this individual is low. It is minus 14%. And this brings me to a point that ejection fraction, which is one of the measures we use to look at systolic function of the left ventricle, is good, but I apologize, but as you can see, the global longitudinal strain, which is a finer parameter, is abnormal, and this patient does have ventricular dysfunction. And then on the right-hand side, you see tissue Doppler and you see the mitral inflow velocity, and you can see that the mitral inflow is also abnormal. There is a short deceleration time with hardly any contractility or hardly any filling. The majority of the filling seems to take place in the early phases and no A wave as we would expect it to happen. So then we do the left atrial strain, and left atrial strain is done, at least in our practice, in a 4-chamber view and in a 2-chamber view. And you can see here then on the left-hand side is the left atrial strain. And in the 4-chamber view, it is 17%, and in the 2-chamber view, it is 15%. Remember that 40 would be a normal number. So this patient definitely has reduced strain of the left atrium, and this patient clearly fits with what you would encounter or what I would encounter in our practices in patients who have atrial fibrillation. So summarizing, atrial fibrillation, chronic atrial fibrillation, fibrosis, fibrosis meaning left atrium is stiff. If we look at the left atrial strain in these individuals, they are reduced. Let's then move on to another disease where also strain has been studied very well. And this is an example of a patient who has amyloid heart disease. Amyloid, as you know, impairs not only the ventricular myocardium, but also impairs the left atrium. And one sees in amyloid that the impairment of the left atrium takes place very early in the phase of amyloid infiltration before even diastolic dysfunction starts taking place. So here is a 74-year-old male who has amyloid, and on the picture on your left-hand side on the parasternal long axis view, you can see that there is trivial pericardial effusion. The walls of the right ventricle as well as the left ventricle are thickened. The valves are thick, the mitral valve in particular, and clearly the systolic function of the left ventricle is markedly diminished. Then when we look at the 4-chamber view, you can see that the right ventricular wall is markedly thickened, as are the left ventricular walls. The valves look a little bit thick. Both the atria are enlarged and ventricular function is reduced. Some of the classic findings, echocardiographic findings that we encounter in patients with amyloid infiltration. On the right-hand side is the very characteristic strain pattern. First thing to notice is the global longitudinal strain is reduced. Second thing to notice is that amyloid infiltration, as you all know, spares the apex, and apical sparing pattern is seen that it looks like cherry on top or whatever you like on top, and you can see that the other walls have markedly lower strain values. On the left-hand side, you can see that the E to E prime ratio is elevated, showing that there is markedly elevated filling pressures. And you can also see that the annular velocities are lower, again, characteristic of a patient who has amyloid infiltration. And as expected, when we do the 4-chamber and the 2-chamber left atrial strain, the thing that strikes out is that the 4-chamber strain and the 2-chamber strain are severely reduced. This finding has been reported, reproduced, and reported that in amyloid heart disease, one of the early markers is reduction in left atrial strain. And I just wanted to draw it to your attention so that when you are learning or when you are practicing how to do left atrial strain, look for diseases where you know they are going to be abnormal so that you will succeed and you will build confidence in your ability to do the left atrial strain. So let's turn our example to a third patient, another common disease that we encounter, which is a patient with aortic stenosis. All of us see aortic stenosis. Aortic stenosis has become a disease where we now treat this disease with transcatheter implantation of the aortic valve, and it is one of the most common valve disease, at least in America, and also I believe to a great extent in India as well. So what happens to strain in aortic stenosis? Well, we know that aortic stenosis causes elevation of filling pressure, which causes elevation of left atrial pressure, and that it therefore impairs the left atrium. So we know that left atrial strain, whether it's the reservoir phase, conduit phase, or contractile phase, all of them are reduced. We also know that the booster pump function, or also called as the contractile phase, is affected. The reverse remodeling that occurs after aortic valve replacement or after a percutaneous aortic valve change shows that left atrial strain does improve after treating the aortic valve, because we are lowering the filling pressures, lowering the strain on the left atrium, and we can now document and demonstrate it on echocardiography. And this has now been reported in patients who had aortic valve regurgitation and have had aortic valve replacement as well. So let's look at this patient. It's a younger patient, 55 years of age, critical aortic stenosis. Mean gradient was 120 millimeters of mercury, and the aortic valve area was 0.5 centimeters. On the parasternal left long axis view on the left side, you can see that the aortic valve is hardly showing any opening or closing. Ventricle is hyperdynamic. Walls of the left ventricle are thick, and the ejection fraction is hypercontractile. And in the zoomed view, you can see the valve, and you can see very small opening, very narrow opening of the valve in the short axis. And then one can see the gradient, which is in the center panel. And again, for your reference, the gradient was 120 millimeters of mercury. When we do the left atrial strain, we find that the left atrial strain is not all that bad. Remember, I showed you left atrial strains of 6, 7, 14. This one, the left atrial strain is 27 and 27. Still lower than what we would see in a normal left atrium, but not all that bad. And this is an example of the left atrial strain in a patient with severe or critical aortic stenosis, mechanism being pressures go up, left atrial pressures go up, starting of fibrosis, but potentially reversible. So let's look at this fourth example, the patient with hypertrophic cardiomyopathy. And we have a very, very large collection of patients with hypertrophic cardiomyopathy. We are actually the only center in the Midwest designated by the Society for Hypertrophic Cardiomyopathy as a center of excellence. And with Dr. Tajik here, we see all kinds of hypertrophic cardiomyopathy. And we have been systematically studying. As a matter of fact, we are Dr. Tajik and Dr. Partho Sengupta, not Dr. Shantanu Sengupta, but Partho Sengupta are doing artificial intelligence and recognition in a series of patients with hypertrophic cardiomyopathy. So we have some experience with this. And what I wanted to share with you was, what does the left atrial strain look like in a patient with hypertrophic cardiomyopathy, and how one can use left atrial strain to sort out between hypertrophic cardiomyopathy and athletic heart, sometimes which becomes very difficult. So we know that in hypertrophic cardiomyopathy, the left atrial strain value is decreased. We know that that is not the case in athletic heart or in heart of athletes who also show some degree of hypertrophy. So this is a 21-year-old male who has a reverse septal curvature and very classic hypertrophic cardiomyopathy that you can see in the parasternal long axis, in the apical forechamber, and in the short axis views. You can see all the features of systolic anterior motion, thickened septum 42 millimeters as it was measured here, well-preserved global function, small cavity, and you can also see in the middle picture, the four-chamber view, that both the left atrium is particularly enlarged, right atrium is not, and that there is systolic anterior motion that you can very nicely see on this four-chamber view as well. So classic example of a young man with reverse septal curvature, hypertrophic cardiomyopathy. And you can also see that the LVOT gradient shown on your right-hand side is 120 millimeters of mercury. There is also eccentric mitral regurgitation that you can see on the color flow on the left-hand panel on this apical long axis view. So with Valsalva, the gradient was 120, and you can see that this patient has mitral regurgitation, and the phenomena of eject, obstruct, and leak is very nicely seen in this example of hypertrophic cardiomyopathy. So let's turn our attention to strain, and you can see here that the strain in four-chamber was 23, in two-chamber was 30, and an average strain would then be, because you average the four and the two-chamber, it would be lower. And we know from data and from literature that strain in patients with hypertrophic cardiomyopathy are lower, whereas strain in patients who have athlete heart are normal or near normal. So these were 4 examples that I wanted to share with you on left atrial strain. Left atrial strain can be done and is being utilized. We do it in almost every entity that we encounter.
Dr. Bijoy. Yeah. So I think this is a pre-recorded video. He could not be with us because he had a emergency surgery for his eye, but he's doing okay. So I have 1 or 2 questions for, I think, with Dr. J.C. Mohan can address. Dr. Mohan, are you unmute? So in what situation in present era do you think LA strain should be done?
First and foremost thing is that LA strain needs to be validated. Unlike LV longitudinal strain, LA strain hasn't been validated. It is reduced in a large number of conditions. What is its incremental value has been studied in smaller studies. We have normal data available. Europeans have published it, normal data. And Bija did quote, and Tom Marwick did a meta-analysis of data saying anything from 31 to 41% the median value. But it's such a thin wall, and of course you are doing 2D strain. So there would be issues about variability, robustness of the data, and that needs to be kept in mind. Having said that, if it is significantly, markedly reduced, and with a LA which visibly looks all right, it probably would have significance. Where I am trying to find useful, actually, we are trying to actually find out some ways where it can be useful. The conditions which Dr. Vijay Khanderia showed, certainly you can use in those conditions. It has some incremental prognostic value. It has incremental prognostic value in heart failure. Incremental prognostic value, heart failure, preserved ejection fraction. There are also data to suggest that it has actually value in finding out the grade of diastolic dysfunction, more so in HFpEF patients where the E to E prime may be normal or near normal, and LA may not be really, volume may not be helping. If you have strain which is significantly reduced, it correlates with wedge pressure. There are multiple studies which have been done. Having said that, I still have, and I do it quite regularly. I report quite regularly, but I would frankly say I'm trying to learn. I am trying to learn where I would use it more often and I would say, look, this is the patient where you definitely require. I'm doing in most cases, but I'm still trying to learn where to say that I will definitely be
right
using this kind anything great confidence, and I also have to say that the Philips system is much more user friendly. The G systems up to E9 have not been very good actually used. You can't actually get LA strain. You have to fool the machine to get LA strain. And the Bijay also was showing some data. But did you see values when he was showing 17%? The value written actually from the machine were minus 3.4% or 3%.
That's.
I don't know whether you noticed.
Yeah, that's the fooling thing. That's because of the fooling thing. Yeah.
Yeah, they were the fooling thing.
Yeah.
But when you look at the various curves of the segments, you find actually very big variation. That itself tells us that what we are tracking are very different things. Even in a normal left atrium, quite often you find big variability in the curves of segments. I think we probably would get it there. We need to find out how to do it better. And I think we need to define really the steps and algorithm how to get optimal left atrial strain. But I continue to do in most of the cases just to learn myself. That's all I want to say.
Dr. Chandra, your thoughts?
Dr. Chandra's opinion on that, that would be much more relevant.
I think I agree with JC that I think that it needs to be validated. We don't have. But what we can do, the area where it can play a role is, especially in cardioversion. Who should you put them on long-standing anticoagulation? Because we send the patient for AFib ablation. They come back, if they do a wide area ablation, invariably, even though they may be in sinus rhythm, their LA mechanical function is down, even though they may have a good, if you do a tissue Doppler itself, you can see the MI A prime will be lower. But on the other hand, if you do a focal PVI, in them, the chronicity of the AF before they have the ablation, which we don't know, about 20 to 30% of them, they can go in and out. So if it was low to start with, those patients, even after a PVI ablation, then you keep them on anticoagulation rather than just leaving them on antiplatelet, and look at that. So that's one area I would think that we would. Second is, I think, MR. Before, see, we all look at the LV function, LV is global strain. But on the other hand, if there is a data coming along, if there is a LA strain is lower, and they may be at it may be a precursor to identify even before the LV dysfunction could occur. So the only area where we have done some work is AFib ablation, wide area versus PVI, and you definitely see changes. You use the same patient as a control, and then also the same operator with the similar settings, rather than changing the machine, changing the operator. All of them will have some confounding variables.
Right.
So Dr. J.O. actually recently published a paper from Korea, and he did LA strain, and then they did actually the CMR of the LA actually to get idea about the degree of LA fibrosis correlating with LA strain. And the interesting thing, and this is in rheumatic mitral valve disease. Remember, this is not the other thing. And he showed that in case the left atrial reservoir strain is less than 20%, there is more extensive left atrial fibrosis of the posterior wall, and above 35% there is hardly any. Between 20 and 35% there is a gray zone where you can get a variable amount of fibrosis. And these people have suggested that if you are using left atrial strain, anything when it falls below 20% certainly indicates the left atrium is significantly diseased and probably irreversibly.
Great.
I think, as JC pointed out, as you pointed out actually, that Tom Marwick has shown where there's a diastolic dysfunction, where you're not quite sure whether it's grade 2 or where does it behave. If you use the left atrial strain, and they're able to categorically separate out very nicely those who have elevated filling pressure, those who have normal LV filling pressure. I don't have any personal experience there, but I think it's something where probably clinically it may be applicable if we use it regularly.
Right, sir.
Yeah, I use quite often there, especially when I want to differentiate normal from pseudo-normal. And I find that if the LA strain is more in the territory of below 20%, more often than not, it would be a pseudo-normal pattern. But surprisingly, the interesting thing is that people who present with failure and who have E to E prime, which is actually within normal range, tend to have LA strain more like 13, 14, 15%, 10%. And so the distinction is so obvious that you don't have to apply too much of your mind.
Right. So I think we will have to wrap up now, sir. I think let me thank all the speakers and all the faculties. It has been an amazing experience, right, Dr. Fulwani?
Sure.
Yeah.
Perfect.
So
Perfect.
this was our 16th year and the first virtual meeting. I hope everyone enjoyed, and we will surely like to meet on site personally next year, and I think that's it from us now.
Yeah, thank you very much.
Thank you so much.
Great job.
Bye bye.
Mukesh.
Thank you.
And,
Thank you. Bye bye.
Bye-bye. See you, JC.
You want exceptional image quality. You need to assess the function of the whole heart, not just the left side. You need easy-to-use, robust quantification tools that deliver fast and reproducible results wherever you need them. With an 8% reduction in standard exam time and 21% fewer control interactions, ultrasound can be more definitive without extending exam time. You want to assess your pulmonary hypertensive patients more robustly, with a user-friendly tool to measure right ventricular function with consistent results. EPIC CVX uses artificial intelligence to align the view, position landmarks, and detect the RV border in as little as 15 seconds, enabling everyday clinical use. You want to measure global longitudinal strain quickly to better assess overall cardiac function of patients in an everyday setting. EPIC CVX uses advanced automation technologies to deliver one-button push robust and reproducible results, eliminating the need for user interaction and aligned with the SPECL task force. You need accurate mitral valve quantification with dynamic assessment to provide quantitative information that can aid better understanding of complex pathologies. EPIC CVX Release 5.0 brings together the unique strengths of Philips and Tomtec to create a seamless, integrated experience for all your echo examinations. Designed for cardiology, built for better care. Philips EPIC CVX. Innovation and you, Philips. You want exceptional image quality. You need to assess the function of the whole heart, not just the left side. You need easy-to-use, robust quantification tools that deliver fast and reproducible results wherever you need them. With an 8% reduction in standard exam time and 21% fewer control interactions, ultrasound